Members of the committee include Dr. Zachary Litvak, Dr. Kester Phillips, Dr. Matthew Smith-Cohn, Alon Orlev, and most importantly, the ladies at the Seattle Science Foundation, Linda Selin and Corey Kepler. Without Corey, none of this could have happened. She's amazing and has done a huge amount of work to bring all of this together. I want to also thank our sponsors, without whom we couldn't do this work, including Day Surgical, Integra, Novacure, Northwest Biotherapeutics, and UCB. In terms of some nuts and bolts issues, excuse me, if you have questions, please put them in the chat box and we will address them during the live Q&A portion. If we run out of time, we'll try to address your questions in the chat box directly. If you are interested in claiming CME credit, that will instructions for that will appear at the end of the conference in both the chat box and as a final slide. So please stay tuned until the end of the information for this information. Also, it should be noted the course is being recorded and will be available at the SSF YouTube YouTube site, which is ssfyoutube.org. And please subscribe. So now that we've taken care of some of these first issues, I'd like to thank all of our faculty participants for joining us and giving talks. Our first speaker is Dr. Kester Phillips, who is a neuro-oncologist here at the Ivy Center at Seattle Neurosciences Institute. He went to medical school at Ross University School of Medicine, residency at SUNY Brooklyn, New York, and a fellowship at Beth Israel Deaconess Medical Center in Boston and at UVA, Charlottesville. Dr. Phillips is a wonderful neuro-oncologist who has been here for a couple of years, and I enjoy working with him. And he will be giving a talk on advances in the diagnosis, evaluation, and systemic management of leptomeningeal metastasis. So take it away, Dr. Phillips. Thank you.
Thanks, Charles, for the kind introduction, and thank you to the Seattle Science Foundation for organizing this conference. I'm happy to share with you a few updates on the diagnosis and management of leptomeningeal disease. So just to dive in, it's estimated that about 5 to 50% of patients with cancer are diagnosed with leptomeningeal disease. Survival rates are dismal, and that's in part due to limited therapeutic options. The common offenders are lung, breast, melanoma. Hematological tumors also spread to the CSF space, as well as primary brain tumors. The molecular profile and the histology also influence leptomeningeal spread. We've seen a higher incidence with triple negative. In the lung met space, EGFR mutations are quite common. Tumor cells gain access to the CSF space via the hematogenous spread. Additionally, recent preclinical data have shown that the overexpression of complement 3 by tumor cells also cause a breach in the blood-brain barrier in the choroid plexus. The study also showed that increased CSF C3 complement 3 also influences the clinical course. Patients do worse when the level is higher, and that by blocking that pathway, you can attenuate disease progression. A human study corroborated those findings and also found increased complement levels. Not only did they find increased complement levels, but cytokine levels were increased as well. TGF-beta was also increased in patients who were exposed or treated with BRAF inhibitors. It was found that TGF-beta actually was protective. Patients present with a myriad of complaints owing to the diffuse nature of the disease. We see it quite common: headache, cranial nerve neuropathies, encephalopathy, nausea, vomiting, back pain if they have spinal mets and infarcts. On imaging, we look for enhancement in the cerebral cortex. I always look for enhancement in the cerebellar folia as well. Tumor cells can invade the ependymal lining, and if this progresses, patients develop hydrocephalus that may warrant a VP shunt. Here's a patient with leptomeningeal spread to the spine. It's a young guy with a myxopapillary ependymoma, no brain disease, just disease confined to the CSF, the spine. Leah actually radiated him with proton, and she's going to update us later on proton therapy. There's diffuse, lumpy, bumpy, nodular enhancement throughout the spine. The gold standard diagnosis is detection of malignant cells by cytology. Often pleocytosis and elevated protein, low glucose is also helpful. Sometimes, well, you should check for raised ICP or opening pressure. Flow cytometry can be beneficial for hematological tumors. Treatment is palliative. Surgery can be incorporated for VT shunt. For bulky disease, radiation can be employed. IT chemo, systemic therapies, and intrathecal biologics are still experimental. There's very interesting data with IT rituximab and Herceptin for breast cancer. Rituximab, obviously, for CNS lymphoma. There are limitations to conventional CSF analysis. The processing, it needs to be done rapidly. These cells are fragile and friable, so they can disintegrate over time. Cytology is also inconclusive. Very often we see atypical cells, suspicious cells, high false negative rates requiring multiple LPs or 3 LPs to increase the diagnostic yield. It's examiner dependent, and we know from Dr. Glant's study that we need about 10 cc's for accurate analysis. That's not always done, that I've noticed in practice. Due to limitations in cytology, there's been increased focus on refining methods to accurately diagnose leptomeningeal disease. Nowadays, or over the past decade, a lot of work has been looking at circulating tumor cells, cell-free DNA, next generation sequencing of cell-free DNA and cell-free RNA. The detection of liquid biopsy in the blood served as a foundation for research in the CSF space. There's a lot of methods that are available. That's beyond the scope of this talk, but just wanted you to know that, be aware that there are a lot of methods that are available. But by and large, label-dependent detection is widely available, widely used. The idea here is that these tumor components or cellular components are stained with immunofluorescent antibodies, and using fluorescent microscopy, you can detect tumor cells and separate them from white blood cells. So a tumor cell, the phenotype, they are EpCAM positive, and that's cytokeratin positive, DAPI positive, which stains for the nucleus, and CD4 negative, so you can exclude contaminants. The detection rate is in the order of 76 to 100%, and we know cytology on the first tap, it's about 67%. Next generation sequencing is also employed. We also get that data. FISH studies can also help for targeted therapy. NGS may also capture clonal divergence. Here's a study looking at samples of patients. CSF was sent in parallel with plasma and tissue. And what we're seeing here is a higher copy number variant in red in the CSF versus tissue in plasma, suggesting clonal divergence. The emerging next generation sequencing, some is still being verified in, for example, in melanoma, HMD45 and SOX10 still being verified. Here's a patient of mine, a 56-year-old woman, HER2 positive breast. She was diagnosed in 2018. About 2 years later, she was diagnosed with a MET, had that resected. About a year later, she developed lesions suspicious for leptomeningeal spread. Cytology was done by her primary medical oncologist. It was negative. 4 cc's of CSF was sent. She was referred to me for further workup. I repeated the scan. About a few weeks later, there was bulky nodular disease in the cerebellofolia. Spinal MRI was negative, and based on clinical grounds, I diagnosed her with lepto. Zach Litvak actually put in a Meyer, and we treated her. So baseline CSF was suspicious, again, atypical cells, and in parallel, I sent off CTC analysis and detected 14 cells that were present. FISH studies showed HER2 gene amplification. She was commenced on IT Herceptin. I treated her twice weekly for 4 weeks. Repeat scan showed partial response. Cytology was negative. I decided to add methotrexate to the regimen. So she got combo IT Herceptin plus methotrexate. She got treated for 4 weeks, twice weekly. She had a nice response, complete response that was sustained over time. CTCs was also sent to track response, and it was negative. I saw her this week. Her scan this week was also stable, no disease, complete response. She's doing well. She's about 9 months out. A phase 1, phase 2 study led by Priya Kumtakar looked at intrathecal Herceptin for patients with leptomeningeal disease. This was a great study. The MTD was determined to be 8 milligrams. Patients would receive treatment twice weekly for 4 weeks, once weekly for 4 weeks, and biweekly maintenance. The study showed a median overall survival of 12 months, which is well above historical controls. The novel taxane derivative ANG1005 has excellent blood-brain penetration, and the study also looked at patients with breasts with brain mets and leptomeningeal disease. Response rates were in the order of about 20 to 25%. In HER2 negative, the median overall survival was about 8 months. Patients also had durable responses and stable disease. Serial sampling of CSF may also be helpful as a prognostic marker or as a therapeutic response. Here's a study by Rachna Malani and colleagues. Patients were on clinical trial, and what they did was serial sampling, and they showed nice response rates. Over time, patients on average received about 20 to 22 cycles of chemo. In a small sample of those patients, there was an uptick, a spike in circulating tumor cells that portended poor survival. And in fact, about 4 to 8 weeks following this uptick or this spike, there was radiographic evidence of disease progression. Here's another patient of mine, a 75-year-old woman, BRAF wild-type metastatic melanoma. Screening images showed susceptibility artifact on GRE. It was questionable for leptomeningeal disease. There was no enhancement on post-contrast. There was no obvious bleeding on pre-contrast, but I did tap her. Cytology was suspicious on the first tap. The second tap is also suspicious, but I sent off for CTC enumeration. 4,000 cells, about 4,000 cells were detected, and the patient actually went to hospice and passed away about 2 months later. There are other emerging therapies. For example, immune checkpoint inhibitors. There's new data that's emerged for that. BRAF MEK inhibitors. There's also data. It's not as durable, but it's still in progress. Tagrisso is also available. There's new data showing for T790 mutation positive lung cancer. So to conclude, I think CTC enumeration may provide an accurate assessment of CNS tumor burden. It's helpful for pre-treatment staging, for prognostication. It may be helpful to track response to therapy and for clinical trials. And next generation sequencing to help molecular characterization will be helpful for targeted therapy. Thank you, and I can take any questions.
Thanks, Kester. It's Zach here. I'm just checking the chat, see if we have any questions so far. No, we're good. We don't have any questions. I do have one question for you.
Yeah.
You know, it seems like the domain of your talk is one of those areas that's not necessarily clearly standard of care for treatment of some of these things. And so
Right.
my question is, is this a 1 to 2 year time frame before we see this more common than not in terms of managing some of these leptomeningeal metastases? Or do you think it's still going to sit in the realm of secondary therapies after they've failed some of the more tried and true treatments?
That's a good question. I think the efforts are being made now to harmonize the way we diagnose and treat patients with lepto. I think we may be just at the cusp of, in the realm of the 1 to 2 years, where it's going to make a difference and hopefully become standard of care. And I don't think we should do away with the old drugs. Like I said, I incorporated methotrexate, and I'm a firm believer in combination therapy. So for that patient with Herceptin, I added methotrexate. So I think the treatment paradigm may change within I would say within 5 years.
And just to follow up to that, for those of us who aren't as close to this as you are, historically, when there's leptomeningeal spread of a non-CNS cancer, that's typically considered to be the beginning of the end, so to speak.
Right. It's almost doomsday. Yeah.
Yeah. And so I'm wondering if the molecular diagnoses that you're talking about and some of the more advanced biologic and immunologic treatments, are we sort of on the cusp of where we were 10 years ago with some of the systemic cancers and the transition from old guard treatments to more targeted therapy once we understood the genomics of it?
I think, targeted therapy is revolutionizing, the way we treat brain tumors now, and we'll learn more about that later. Dr. Sharma wrote a nice paper that was published recently about, therapeutics and targeted therapy for metastasis. I think that's the wave of the future, and I think soon that will evolve into standard of care.
Awesome.
Yeah.
All right. Well, Dr. Phillips, I think we're going to transition to our next speaker now. Thank you so much for being here.
Yeah.
And looking forward to spending the rest of the day with you.
Thank you. Yeah, thank you.
All right. Our next speaker this morning is Dr. Matthew Smith-Cohn. Dr. Smith-Cohn joined the IV Tumor Center here at Swedish about a year ago. We're thrilled to have him joining us. He, like Dr. Phillips, is a bit of a renaissance neuro-oncologist with lots of different interests. He's been instrumental in increasing our open trials for primary and secondary treatment of gliomas and meningiomas, and has just been an absolute pleasure to work with. And this morning, he's going to be talking to us about opportunities in opening the blood-brain barrier for delivery of chemotherapeutic agents for malignancies. Matt, thanks for being here.
It's a pleasure to be here. Good morning. Do you see my slide okay?
We do.
Excellent. So yeah, as Zach has mentioned, I'll be discussing ways we can transiently open the blood-brain barrier in malignancies. I have no disclosures. And so here's an outline of the talk. I'm just going to go over the general anatomy of the blood-brain barrier and then the challenges we have in primary and secondary malignancies. And then I'll be reviewing approaches that has been used thus far in the research, sort of big overarching research including focus ultrasound, intraarterial drugs, intravenous drugs. And then also I'll be going over some future opportunities with vasoactive peptides. And so glioblastoma, as much of the audience knows, has a poor prognosis, and compared to the rest of oncology, we're a bit behind the curve. Essentially, we have the same upfront treatment since 2005, the STOOP protocol, where we have 6 weeks essentially of chemoradiation temozolomide followed by 6 months of adjuvant temozolomide. And despite many patients being enrolled in trials, thousands of patients, many attempts, and a lot of fantastic research, we still have not really pushed the needle. And some of that is due to tumor heterogeneity within genetics, but also the blood-brain barrier, which would impede penetrance of drugs. And then similarly, metastatic brain disease has become more prominent. So systemic disease within has been controlled better with new drugs, new opportunities, new immunotherapy, targeted therapies. But since with increased controlling of systemic cancer disease, we have seen increase in brain metastasis. And in fact, recently it's been shown that in systemic cancer patients that have stable or responding systemic disease, up to 16% do develop brain metastases as their initial site of relapse, and underscoring the need that we need treatments that can penetrate through the blood-brain barrier early in the disease course to prevent this said relapse. And so a point of emphasis with outlining this importance is that the blood-brain barrier is an important organ. It has, you can see within this little picture of the blood vessels, it has there's a large surface area. It's an important part of the brain where it keeps drugs out that you don't want. It keeps toxins out. Even insects have a type of blood-brain barrier, so it's evolutionary conserved part of us. And so a little bit of the anatomy of the blood-brain barrier. So here's a little cross-section of blood vessel, just give an overview. You have a component of the astrocytes, parasites, you have the basement membranes, you have the endothelial cells within it, you have neurons, and together this makes this neurovascular unit which regulates blood flow within the brain. And if you take a closer look, you have these tight junctions between the endothelial cells, which helps keep drugs out. And compared to the rest of the body, the brain is enriched in these endothelial cells. And looking at these endothelial cells a bit closer to the tight junctions, there's a variety of different proteins, including glutens. There's actins acting on it with contraction and within the tight junctions as well, just as a basic overview of the anatomy. And with this anatomy in mind, I just want to emphasize that 98% of FDA-approved drugs do not penetrate the central nervous system. And so this not only has implications in cancers, it has implications in all of, I think, neurology, whether it be ALS, Alzheimer's, etc. And so with this kind of point, we can imagine why it's been so hard to treat brain cancers compared to some systemic cancers. And molecules greater than 500 Daltons will not cross the blood-brain barrier. And for example, temozolomide, which we use a lot in glioblastoma, is about 200 Daltons. In monoclonal antibodies we use commonly in a lot of other cancers do not cross. I mean, for example, rituximab is over 145 kilodaltons. And another thing is that the blood-brain barrier compared to the rest of the body is enriched in these ATP binding cassette transporters. So essentially, there's a variety of these pumps that maybe you can get the drug across initially into the brain parenchyma, but the drugs are pumped out in short order. And so some ways that that has been used to bypass the blood-brain barrier to open it transiently includes a magnetic resonance guided ultrafocus ultrasound. And so essentially, this is a non-invasive technique. You use perfluorocarbon microbubbles that are injected intravenously. And the basic mechanism is you have these little bubbles floating around. You use ultrasound in the part of the brain of interest. You have oscillation within the area, and you have tight junction disruption, as demonstrated here in this graphic. And here is the device, such a device being used. You have a patient laying down supine on MRI. You have the ultrasound device, and here's a voxel here of a pre-sonification scan T1 axial contrast MRI. And then you can see on the right-hand side, after treatment, there's contrast enhancement indicative of opening the blood-brain barrier with leaking of contrast. And there's been some trials using this approach in high-grade glioma patients. There's been a phase 1 trial using in 5 patients that they're exploring this technology, and it seems to be well tolerated. And there seems to be at least up to 50% receive an immediate gadolinium enhancement, and this enhancement seems to go away within about 20 hours. And there's ongoing trials and elsewhere in high-grade glioma patients and also in breast cancer patients that are up and going. There's also this device called Sonic Cloud, which is this cranial plannable ultrasound device. So you would implant the device in the cranium in your site of interest where you want to treat the said tumor, and it administers this unfocused low intensity sonification in the area. And similar to the prior approach, you use microbubbles using sulfur hexafluoride to facilitate opening. And here's a study that looked at that. So what you have down here on the left hand on the screen, you have the implant where the arrow is, and this is pre-sonification. This is a patient's getting 6 treatments with carboplatin. And within this rectangle here, you have increased contrast enhancement and increased blood perfusion. Something they noted after the 10th treatment in this patient is that there was recurrence of the tumor outside this area where the blood-brain barrier was opened, as indicated here by these arrows. So their argument was that since the blood-brain barrier was not open in this area, there was recurrent tumor. And here is some more information from that study. As a phase 1 study, they looked at 19 patients and they used dose escalating carboplatin infusion, and it was well tolerated. And in 11 of the patients, so 58% of the patients, there was felt to be adequate blood-brain barrier disruption. And in their hands, they had better than historic control, increased progression-free survival by a couple months, up to 4 months. And then overall survival was observed to be improved in their 11 patients. So you have about 8.5 months versus 13 months overall survival benefit. Another approach in terms of intraarterial drugs, a well-studied drug over the years is Mannitol, and it's been studied for some decades now. And Mannitol has an osmotic effect. So you have mannitol injected in the carotid arteries, the vertebral arteries, et cetera, and you have this increased diffusion and shrinkage of the endothelial cells, which opens the tight junctions, as you can see here in this little graphic, little cartoon, which allows chemotherapy to transverse. And the duration of opening with these infusions is 15 to 20 minutes. And on the right-hand side, we have some rodent brains. And so these brains are, this blue part of the brain is Evans blue, and Evans blue is a dye that binds to albumin. So albumin essentially has 65,000, this molecular size 65,000 Daltons. So much bigger than, if you recall the 500 Daltons I mentioned before as sort of the boundary size to get drugs across. And so in this arterial distribution here, in this intracarotid Mannitol infusion, you have opening the blood-brain barrier, and then you have Evans blue bound to albumin that's able to traverse across, resulting in blue brain. And there's been some evaluation in brain tumor patients. There's been 2 phase 1 studies using bevacizumab and cetuximab. It seems to be well tolerated. And then in this graphic here on the right, you see a glioblastoma patient that had intraarterial Mannitol, followed by bevacizumab. And what they had in their experience was a significant decrease in vasogenic edema that you can see, decreased contrast enhancement, decreased perfusion. This approach has also been explored in brain metastases using carboplatin and methotrexate. And when they look at the what would normally be a prognosis of 2 to 4 months in these patients in their hands, they observe an overall survival of 13.5 months, arguing better CNS control. And one thing with this prior approach is to emphasize is that for focal disease, they seem to be potentially useful. One limitation to diffuse diseases, such as gliomas, is that gliomas do not respect vascular boundaries. If one were to look on microscopic level, there's tumor cells everywhere. For the most part, distributed in both hemispheres throughout the brain. And here's some pictures from an autopsy study looking at a high-grade glioma patient with these black dots representative of tumor cells. If you were to look underneath the microscope, and you can see it distributed throughout the brain. So this is tumor cells that what you would not see on MRIs on flare or contrast enhancement. These are tumor cells that are outside. And similarly with brain metastases, there's often with these patients, there's marked metastases throughout different territories of the brain. Again, not respecting vascular boundaries or focality in one region. So one approach is using vasoactive peptides. One such peptide is BloodBrain, which is a beta-2 agonist, and the central mechanism is opening the tight junctions. You have increased pinocytotic vesicles that allow to carry the drug across. The duration effect is up to maybe 20 minutes. And in rats, it seems to be helpful. In tumor-bearing rats, it seems to be helpful, increases survival when you use methotrexate and carboplatin. Down below, you have this auto radiogram slide here where you have radioisotope bound to carboplatin. And if you use, it's also called Seraport. If you use Seraport, you can see accumulation around the tumor where there's increased carboplatin delivery. They have tried using this drug in children, and with different chemotherapies, there hasn't been an objective response. They did not measure if there was increased delivery of drug, however. Similarly, there's been phase 1 and phase 2 trials using carboplatin in high-grade glioma patients and adults, and they did not see an objective response. But again, it was unclear if it increased drug accumulation. The thing is, you need the right drug for the right tumor to see if there's a response. So that was one, sort of weakness in these studies, but it has been used and at least tolerated. Another such vasoactive peptide is regadenoson, which is an adenosine receptor agonist. It's FDA approved for cardiac stress testing. The effect can last up to 3 hours. In terms of mechanisms, essentially, one of the main mechanisms is downregulation of those tight junction proteins. You can see in this yellow box I have here, these a variety of tight junction proteins that are downregulated. You have a decrease in that. It also impedes some of those drug efflux proteins as well. And on the right-hand side, you can see if you use dextrin, which is a large molecule, 10 kilodalton molecule, with FluxScan, you have increased deliverance into the normal brain parenchyma in rodents over here. And a notable study using Lexacan is the use of temozolomide in non-tumor bearing rat brains, and increased temozolomide delivery by up to 60%, which was an impressive finding. And so that led to other investigations in adults, or in adult brain tumor patients, and then also in healthy volunteers. There's been some studies. So there was a pilot study using FDA-approved doses of Lexacan, one we use for cardiac stress testing. Anyways, and those patients agreed to get brain MRIs. They didn't see obvious radiographic increase in blood-brain barrier disruption with brain spectroscopy and CT imaging. There was a pilot study in recurrent glioblastoma patients where you use regadenoson. And so you have regadenoson administered 1 hour after oral temozolomide, and they use actually microdialysis catheters to see if there was increased temozolomide deliverance in brain parenchyma, and they did not see that. When we're looking literature into mice and rats, they actually have different doses required relative to their body weight to open the blood-brain barrier. And there appears to be even a sweet spot. If you're too high, it doesn't work as well. If you're too low, it doesn't work as well. So there is, because of some of these observations, there's ongoing trial currently determining if perhaps a different dose of regadenoson could be helpful in opening the blood-brain barrier. So just using escalating doses. And so the goal of the study that's ongoing is taking brain tumor volunteers who have stable disease, and they're interested in seeing if there's increased contrast enhancement in the healthy non-disease hemisphere. And that would be supportive of increased opening of the blood-brain barrier. And there are many other vasoactive peptides to be explored. Under the mentorship of Skip Grossman at Hopkins, we recently published a review looking at literature of a variety of different vasoactive peptides, and many of which have not been looked at the blood-brain barrier at all. And just if one were to look at different components of properties that might be supportive, such as sort of vasodilation, do these vasoactive peptides affect tight junctions, did they block efflux pumps, etc. So what we have is an opportunity to look at a variety of different other compounds. And with some luck and some funding, it'd be fantastic, I think, to include this within the province system as well, since I think blood-brain barrier research is important. And so the main takeaway I want you to get from this talk is that bypassing the blood-brain barrier is crucial for effective drug delivery of primary secondary cancer central nervous system. And whether it be improved drugs or whether it be ways to open the blood-brain barrier, both are attractive ways to move the needle. And we should be continuing to research this. And as mentioned a slide ago, there's a variety of acyclic peptides that have yet to be explored. And in Seattle over here, we have the American Academy of Neurology conference here in April, and I will be presenting a poster on some more research, and be happy to meet you there if you're in the area. I want to thank everyone for your attention. I'm happy to field any questions.
Thanks, Matt. It's Zach. Can you hear me okay?
Yes.
Good morning. Yeah, so I'm fascinated by this topic. I trained at OHSU, and Ed Newell was still practicing at that time, and he had been doing intra-arterial disruption of the blood-brain barrier with methotrexate starting in the 90s. So this is not anything new, right? This is now 35 plus years old, and I'm just wondering why it's still basically in the same state of clinical translational research and has not become more mainstream.
No, that's a good question. And I think, some of the challenges is sort of mentioned, at least in cancers, the intraarterial approaches, there's been case reports and such, but as kind of demonstrated by, again, this slide, if you inject the carotid artery, you're just going to get the MCA territory, and you're not really going to control the cancer, I think. So that would be my argument. So I think if one were to try approaches where you can open the blood-brain barrier up throughout all the vascular territories in an effective way to increase drug delivery of all the microscopic disease, then I think you would have a potentially more effective treatment. So I think that's one of the limitations. But in focal disease, sure, I think if you inject one vascular territory, it's fine. I mean, one can also inject multiple vascular territories with Mannitol, but that's, there's some risk to that. You need an inpatient admission. It's a lot less convenient than an intravenous drug.
And so by similar logic, do you feel that a product like the Sonic Cloud is less likely to succeed in the long run than
Yes.
combining, focused or whole cranial ultrasound, just because of that limitation on the territory?
I think so. I mean, if one will look at autopsies out of Northwestern of sort of people at the end of life with glioblastoma, the brainstem's affected. You see cancer cells in the brainstem, and a device like Sonic Cloud is not going to address cancer in there.
Hey, Matt, what about laser ablative therapy, lit therapy, which there's some thought that it opens the blood-brain barrier for I guess up to 30 days following.
Well, again, if you look at, let's say you did, if you have my cursor, let's say you, for the sake of argument, you did laser ablative therapy in this necrotic tissue where my arrow is. You saw all this cancer everywhere else. Right. So, I mean, it might have a role in very focal disease that's been a nuisance, but in the big picture, it's not going to control it for very, very long, I think.
Got it.
Matt, we have a question in the chat from one of our attendees, Jolien Pass, and the question is, what are the risks, medical risks involved in some of these techniques for opening the blood-brain barrier even transiently?
So I mean, with sonication, it's pretty minimal, it's well tolerated. I think with the intraarterial approaches, there is always, like any procedure, there's a risk of stroke. In the hands of a good interventionalist, it's within a low percentage, but that is a risk. And depending on with the vasoactive peptide approach that's intravenously administered, at least, it depends on the drug. There's a wide variety. Some of it could be as much as a severe migraine, for instance. Some of it could be, hypotension. Some of it could be more of an anaphylactic effect with some of these more kind of cytokine-based ones. It sort of depends really on the drug, since there's such a wide spectrum of physiologic components to the peptides. But at least the Lexiscan, the regadenoson, and the Seraport that have been really explored in people seem to be well tolerated, with not a whole lot of side effects, since it's given intravenously, and so those, at least those, seem to be well tolerated.
Great. All right. Well, we have a lot of great talks still to come, so we're going to transition to Dr. Coleman's slides. Dr. Smith-Cohen's going to do a nice introduction of one of his mentors. And if anybody has any questions for this or previous talks, feel free to put it in the chat. We'll continue to moderate that. And if we don't get time to answer it live on video, we'll answer it in the chat.
Yeah, it's my pleasure to introduce Dr. Howard Coleman. I know him very well from my training. He is a John M. Huntsman Presidential Professor at the Department of Neurosurgery at the Huntsman Cancer Institute at the University of Utah. And he's the leader for the Center of Neurologic Cancers over there. He is an investigator at the Huntsman Cancer Institute and a member of the Experimental Therapeutics Program. By ways of training, he has a degree in neurosciences, under a degree at Brown University, and that's followed by an MD PhD at Washington University. He completed his internship and residency at Barnes Jewish Hospital at Washington University School of Medicine. And this was followed by a neuro-oncology fellowship at MD Anderson Cancer Center, where he had a laboratory and was there for several years. And he has many clinical interests within primary and metastatic brain tumors, as well as the neurologic complications of cancer. And his research is focused on developing and testing new therapies for brain tumors, and he is well published within the field of neuro-oncology. He has thousands of citations, and he currently also has laboratory interests in identification of molecular markers of prognosis, treatment, and response in brain tumors. And also the role, he's also interested in the role of tumor stem cells and how they develop resistance to treatment within brain tumors. Thank you, Dr. Coleman, for being here. We're looking forward to your talk. All right. Dr. Coleman, are you good to go?
Okay, can you hear me now?
Yes.
Sorry, I thought I unmuted, but obviously not.
Yeah.
Complicated system with two monitors, but let me, are you guys seeing my screen yet right now or not?
I see your slide deck.
Okay, good. I think we're almost there. Okay, is that good?
Looks great.
Okay. Well, thanks, Matt. Thank you for that nice introduction, and thanks to you and the organizers for the opportunity to talk to you today. I think many in the audience are familiar with the new WHO 2021 and some of the changes in that. And so what I wanted to focus on today, at least for a couple topics, is how we got here to the new classification system and how some of these changes are important for clinical management and also for clinical trial design and interpretation. So as you know, in the prior WHO 2016, there was this shift from histologic to integrated diagnoses. So for the first time, molecular markers were included in 2016. And the key markers that were included as diagnostic criteria at that point were IDH mutation, chromosome 1p19q deletion, and H3K27 mutation. And so you can see on the right kind of what changed from the prior edition to 2016. But this was a little bit of a half measure. And even at that time, a number of markers were being used, and in clinical practice, a number of kind of tumor entities were being treated, even though they didn't quite fit into the WHO. And perhaps the biggest group that was problematic was this grade 2-3 IDH wild type astrocytomas, in that some of those would turn out to have BRAF mutations or fusions and perhaps be pilocytics or pleomorphic xanthar astrocytomas. Some had EGFR amplification, TERT promoter mutations, and looked a lot at the molecular level like GBM, but WHO didn't really recognize that. And so moving forward, there was variability in the certainty of diagnoses. So in the 2016 criteria, there were easy diagnoses. So if you had a tumor that was IDH mutant with or without 1p19q deletion, you knew that it was either diffuse astrocytoma or oligodendroglioma, and not a lot of confusion there. If you had an IDH wild type high-grade glioma with microvascular proliferation or necrosis, that was still glioblastoma by the old histologic criteria, and relatively little opportunities for confusion there. But the challenging diagnosis, again, are these diffuse gliomas, grade 2-3, IDH wild type, do not have microvascular proliferation or necrosis. And it turns out that there really is quite a wide range of potential molecular alterations and diagnoses here. And so this is really not a distinct diagnosis that was recognized at the time of the 2016. The kind of means to fix that were not there. So moving forward to 2021, there was an effort in the field to really say, how do we improve on this and move things more towards what's really needed and actually done at the clinical level. So this is a schematic from the lower grade TCGA effort led by Dan Bratt that we participated in. And I think it kind of highlights the problem. So again, in these diffuse lower grade gliomas, not having features of glioblastoma, you have the IDH mutant tumors. And if they have 1p19q co-deletion and mutations consistent with oligodendroglioma, that diagnosis is clear. If the 1p19q deletion is not present, they will almost certainly have mutations consistent with astrocytic tumors. And these are the astrocytomas, IDH mutant, grade 2-4, and we'll come back to the grading of those in a minute. This is the group that's problematic in that you see some tumors that have mutations consistent with glioblastoma. And I would say in older patients, most of these lower grade IDH wild type tumors are molecular glioblastomas, but you certainly see others, H3K27 midline tumors, tumors with BRAF mutations and fusions, even NTRK fusions. And so these have big clinical implications if that is what they are, and you don't want to treat them as similarly to an IDH mutant astrocytoma. So the group that was kind of tasked with coming up with suggestions for WHO 2021 was the C-Impact Now group, and there were different subgroups working on different specific issues. And this was the diffuse glioma group led by Dan Bratt. I was a part of this combination of neuropathologists, neuro-oncologists, and the goal was really to come up with some criteria within the diffuse gliomas that would be helpful to the field and address some of these problems that were still present in the 2016 criteria. And as I mentioned, a subset of those lower grade IDH wild type tumors have molecular features and prognoses that are similar to your typical IDH wild type glioblastoma in elderly patients. So in the left panel here, you see the tumors that were low grade and the tumors that were histologically GBM. And this is from the TCGA grade 2-3 cohort. And you can see by the heat map here of the molecular alterations, just eyeballing that, these tumors look pretty identical to those tumors. And so when you look at the prognosis, that's true as well. Here are the histologic GBMs. Here are the grade 2-3 IDH wild type tumors that have some of these alterations. And maybe a little bit of a difference of prognosis, but certainly not convincing. And so the question was, how do we define those tumors as a diagnostic entity? And so this was what the group came up with after a lot of consideration of the literature in this area, is that if you're trying to diagnose an IDH wild type diffuse astrocytic glioma, grade 2 or 3, if on additional testing, the tumor has EGFR amplification, chromosome 7 gain, chromosome 10 loss, or TERT promoter mutation, then that really is a grade for glioblastoma. And this was the terminology that was created to describe that: diffuse astrocytic glioma, IDH wild type with molecular features of glioblastoma, WHO grade 4. And one of the things that I found particularly useful, first of all, it's good to have a diagnosis for these tumors. But secondly, I found it particularly useful in large tumors where you get a small biopsy and you're going to get undersampling of the tumor for histologic features, necrosis, microvascular proliferation. But these molecular features are very homogeneous throughout the tumor. I mean, there's some heterogeneous nature of EGFR amplification, but it's pretty easy to make this diagnosis even with a small amount of tissue. So that was one diagnosis that was integrated into WHO 2021 that I think is important. Another question that our group tried to address was, does our current system of grading really work well in both these distinct diseases, IDH mutant and IDH wild type astrocytomas? And that question was based on some data suggesting that it may not. And this is courtesy of Ken Aldape, who in a retrospective series separated the tumors that were IDH wild type, tumors that were IDH mutant, that were histologically grade 2 or 3, and looked at what was the effect of proliferation on the grading, and how did that relate to prognosis. So here's the IDH mutant cases and ones that were graded as grade 2 or grade 3. You can see the Kaplan-Meier's are overlapping. Whereas in the IDH wild type, if you use various proliferation markers, the grade does correlate with prognosis. So this is mitotic index. I think this is MIB. I can't remember. But it's quite clear that our current grading system works well for IDH wild type, but not very well for IDH mutant. And we need to at least think about what can we do better for IDH mutant grading. And again, our group looked at a large set of literature, and consensus was that CDKN2 loss was really the single marker with the best prognostic association. There certainly are others that with additional data and validation might be important here. But this graph's a little complicated, but here are the grade 4 tumors histologically that have CDKN2 loss. Here are the grade 3 tumors histologically, IDH mutant, that have CDK and 2 loss. And you can see that those are almost overlapping. If the tumor is IDH mutant histologically, GBM histologically, and doesn't have CDK and 2 loss, has somewhat intermediate prognosis, and then the grade 2-3 tumors without CDK and 2 loss have significantly better prognosis. So this at least suggested that CDK and 2 loss was a marker of prognosis similar to grade 4 histology in IDH mutant tumors. And so the CIMPACT group came up with a set of grading criteria, which isn't perfect, basically kept the same criteria for IDH mutant astrocytoma grade 2, even though mitotic activity may not be a good grading system there. IDH mutant grade 3 basically stayed the same, except for the addition of the fact that CDKN2 deletion has to be absent. So the problematic part about that is it means you actually have to test for CDKN2 to know. And then IDH mutant astrocytoma grade 4, first the name change. So we deleted glioblastoma to avoid this confusion that somebody has a glioblastoma and it has a uniformly bad prognosis, and kind of highlight the fact that IDH mutant astrocytomas are really a different disease, and so didn't include glioblastoma in the name. And that to be grade 4 IDH mutant astrocytoma, you can have microvascular proliferation or necrosis or CDKN2 loss. So any one of those is sufficient for a grade 4 diagnosis. So this was also incorporated into WHO 2021. And looking back, we actually did a collaboration with Ken Aldape, where we thought made some interesting observations related to grade in IDH mutant astrocytomas, but actually kind of missed the punchline on the CDKN2 loss. What we did is we took a series of grade 2, 3, and 4 IDH mutant tumors and did copy number analysis. And this is, I'm showing you unsupervised clustering here on the right. This is grade. And the blue are grade 4, the orange are grade 2 or 3. And you can see that just with unsupervised clustering based on copy number, these tumors have a higher copy number, and that's mostly the grade 4 tumors. These tumors have less, and those are mostly the grade 2, 3 tumors. And we found that the mutant tumors had upregulation of things in the CDK pathway and proliferation, while the wild types had upregulation of receptor tyrosine kinases and other signaling pathways. What we missed here is almost certainly these lower grade tumors that are clustering here have CDKN2 loss. But we were focused on the histologic grade as the base truth and didn't really think about the fact that maybe there's a marker in there that would explain that clustering. I also want to discuss what I think is an outstanding model of high-grade IDH mutant tumors here. This is by Sherry Holman from our group using the ARCAS TBA, and I won't go through the details. It's complicated, but basically Sherry did this complicated cross of mice, floxed mice, with alterations that we see in grade 4 IDH mutant tumors, including CDKN2. So when you give them tetracycline, you knock those out, and then when you add IDH mutation and PDGF to these mice, you get high-grade tumors that show that even with all these alterations, you don't get really high penetrance of tumor. What you need to do is have all those alterations plus IDH mutation. So this was the first paper, I think, that showed IDH mutation drives tumor genesis in this setting. And again, I won't go through the histology, but in the ones where you have IDH mutation inserted, this really looks like a good model of grade 4 IDH mutant tumors. And so, we've got new classifications, we've got models that seem true to the biology and the molecular makeup of these tumors. What does that affect? It has at least implications on diagnosis, prognosis, treatment, and also importantly, clinical trial design and interpretation of trials. So I'm going to give you a few quick clinical vignettes just to show how these kinds of distinctions are important in clinical practice. So here are 3 non-enhancing tumors, all in young patients. I think these patients are all in their 20s or 30s, and all basically have a low-grade astrocytic histology. And so from this, I don't think you can really predict very well what the diagnoses are. But when you start looking at individual cases and doing some additional molecular profiling, so this was a diffuse astrocytoma grade 2. When we did the sequencing, IDH mutation, ATR XLOS P53 mutation. So this fits nicely. Again, this is an easy diagnosis, diffuse astrocytoma, IDH mutant grade 2. And this patient did well, did get treated with radiation and temozolomide, but good outcome. Here's another example. If anything, this tumor looks kind of more, less mass-like, doesn't look very aggressive. Histology, again, IDH wild type grade 2, but here, EGFR amplification, chromosome 7 gain loss, 10 loss, P10. So this is that entity of diffuse astrocytic glioma, IDH wild type, with molecular features of glioblastoma, grade 4 by definition. And the patient did somewhat as expected for a run-of-the-mill glioblastoma, survived 22 months, maybe slightly better than average, but still really a bad tumor, even though the initial imaging did not look that way. Here is another example, just a flare abnormality, again, astrocytic grade 2, but here we have a BRAF V600E mutation, and this was actually given a further distinction of plenty, a very rare tumor. Patient had surgery, just been watched, and all is good, hasn't had any evidence of recurrence. And so, this kind of summarizes how important these molecular diagnostic distinctions are, and how it would change potentially treatment management for various patients. This is also true in midline tumors. So here's a non-enhancing midline tumor. Here, again, astrocytic type 2. No molecular markers were done at the outside hospital, was treated outside, but this has a BRAF fusion, and on review with our pathologists, thought this was more likely a pilocytic tumor. We probably wouldn't have treated this patient, but they did get treatment and did do well. Here's another one, if anything, looks more like a pilocytic. Again, astrocytic tumor grade 2, IDH wild type, but now this has the H3K27M, which I think is pretty well recognized, but wasn't until recently. And we know this is almost always a bad actor. And indeed, this patient recurred within 2 years, was in the ICU with status, and actually died in the hospital at the time of that recurrence. So, what we think the C-Impact and WHO 2021 have done is take some previously heterogeneous tumor types and better define them. As I mentioned, you can make a diagnosis sometimes with smaller biopsies. You don't have this issue of undersampling. The IDH wild type group, particularly in young patients, is the biggest challenge. This is where you get a whole spectrum of alterations you have to be aware of. And then this molecular GBM, it also explains a lot of these tumors that in older adults that had low-grade histology but behaved badly. And another implication is that testing for CDKN2AB really is necessary in grade 3 or higher IDH mutant tumors, and there's some now better drugs in trials. And I just want to finish up with just some clinical trial implications. We can't write trials anymore that are based on astrocytoma grade 2, 3. We really have to define which molecular entities because this is really a very heterogeneous population. The sequencing or some additional molecular testing, is often going to be a requirement for accurate diagnosis and enrollment on trials. We have to reinterpret some of the older trials, like for instance, the Catnon study included IDH mutant and IDH wild type tumors, and they saw a clear difference in effectiveness of temozolomide. So we have to be careful interpreting some of the older studies that didn't separate out those tumors. And it's not entirely clear what we do with some of these new entities going forward. So are these astrocytic gliomas with molecular features of GBM equivalent to histologic GBM? Can we just consider them the same diagnosis for trials or not? That we don't know the answer to that. And I'm actually working with a group to try and figure that out. And it's not clear how the FDA will handle labeling for some of these trials that used inclusion criteria that don't correspond to the current diagnostic criteria. And I don't think we know the answer on how that's going to work. So really thank you for the invitation and happy to answer any questions.
Dr. Coleman, thank you for that overview. And it's a little sobering, especially for the surgeons involved, when it keeps changing every couple of years and trying to remember all of the markers that we're supposed to be testing for. So I guess one thing that might be helpful for me and other people attending the course is that currently in your shop, when somebody has a intermediate to high grade glioma resected initially, what panel are you asking pathology team to run?
Yeah, great question. So, we do as routine initial diagnosis on everyone, IDH by immunohistochemistry for patients that are under 55 and the immunohistochemistry is negative, it reflexes to sequencing for IDH. We do EGFR amplification, do ATRX and P53. And so that gets a 1P19Q FISH. And so that's all done usually, as part of an MGMT promoter methylation for IDH wild type tumors. That's usually done as part of the initial diagnosis. Now, there are some diagnoses like now, IDH mutant grade 3 tumors, where the pathologist sometimes issue a report saying CDKN2 testing has been ordered. And so that's a provisional diagnosis. And then we do molecular sequencing on everyone, particularly these younger patients with an IDH wild type tumor where, all you get is that IDH wild type, EGFR is negative, CDKN2 may be negative. And that's this wider group of patients that we really diagnose by next-gen sequencing. Now, the problem with that is that takes several weeks. So there's some patients we know the diagnosis at the initial report. Some patients we're pretty sure the diagnosis, but we need some additional clarification on follow-up testing. And there's some that we sometimes have to start treatment knowing that we really don't know the diagnosis exactly.
And I'm glad you mentioned next-gen sequencing. That's something that we do quite frequently. But as you know, it's a little bit of a waste bucket term in terms of the fact that not all next-gen sequencing is created equal. Are you doing it in-house? No. Or is that getting sent out to a reference lab? How's that work?
Yeah, I mean, we've used several reference labs. We do have an in-house lab, ARUP, but they've been a little bit behind the curve in terms of the quality of their assay. And there are also issues of them not being able to tell us how much patients will be billed, whereas the outside companies have much better, more transparency about what's the risk to the patient in billing. So we've used multiple outside labs over the years. Just our criteria is they have a larger panel, somewhere 400, 600 genes. Ideally that they're doing RNA sequencing as well to pick up the fusions. And the other thing is that they'll return the raw data to us for research purposes. And that they have a good financial assistance program for the patient. So that's been the criteria. I would say we haven't seen huge differences in quality or results between the labs. And so, really do it based on practical considerations. I will we'll mention one other thing on the diagnosis is we often do an H3K 27 mutation immunohistochemistry for anything that's remotely midline in that IDH wild type category. I think right now they're sending that out, but working on getting it in-house.
And can you comment for us on what you think the timeline is going to be in terms of translating our understanding of the molecular development of the heterogeneous forms of glioma into targeted therapies, especially when CDK is a great potential target and targeted in other cancers. Why aren't we targeting it in astrocytoma?
Yeah, so I think it's a good question. I mean, I think it was felt a lot of the older CDK inhibitors did not get into the brain well. There are some new generation that are brain penetrant. One that's in a first in human trial in gliomas at multiple centers now, and we've been participating in that. I think that in theory should be an attractive target. Now, we have had this problem in brain tumors before, even BRAF as a target, where it seems to work better in melanoma and other tumors, and maybe not so well in brain tumors. But I'm still hopeful. I'm not. I guess I've lost a little bit of hope on the run-of-the-mill IDH wild type glioblastoma in the elderly. At one point I thought we were going to be able to take the unique combination of alterations in tumors and find some combination of drugs for those patients. But I think that hasn't happened so well in other areas of oncology. So I'm not sure we know what the true driver is, or whether there isn't a driver. They're all needed, but when you hit one, the tumor just compensates. So I think when you have a good, a single target, BRAF, NTRK fusions, things like that have really been proven in other tumors, you have potential for efficacy in brain tumors, but haven't been completely thrilled with this. Oh, there are 10 alterations in the tumor. This one looks good. Let's hit it with a MEK inhibitor.
Dr. Coleman, do you think a cocktail in these situations could be helpful?
I think I certainly think it's theoretically possible. As I said, that was my hope. I think the problem is that, well, there's a couple ways to look at it. The one is you can say, well, all those things are important, so we need to hit them all. But those alterations are usually in different pathways. And if you really believe this idea of gene addiction, if that's there and it looks important, hitting it effectively should do something in terms of efficacy, even if there are other pathways that are also important. And so I think that's the concern, is that either we haven't hit those targets effectively, which is certainly possible. The drugs aren't great in the brain, or it's just something's different about those tumors, and individual alterations just don't have the same biologic impact of BRAF mutation in melanoma. It's interesting though, BRAF in melanoma, that's an example where the targeted therapies now are considered second line in many ways to immunotherapy. So even though you have a target, the immunotherapy has a bigger benefit, and you don't use targeted therapy as a first line. So, I'm hoping, I guess the bottom line is I'm hoping we have other approaches, immunotherapy or something for IDH wild type glioblastoma in the elderly. I'm not sure we're in a position to figure out the combinations in a rational way that could be highly effective.
All right, great. Reminder to all of our attendees today, feel free to chat in any questions for Dr. Coleman or any of our other presenters. And if any, I don't know if any of the other faculty and panelists here today from some of the other centers have any comments on the role of next-gen sequencing and potential targeting or cocktail therapy. That would be great. There is one question from the chat, and I think you were starting to answer it, which I think would be good to discuss, which is what is the role of reevaluation, rebiopsy, and remolecular profiling of long surviving patients?
Yeah, I think that's an interesting question. I would say a large proportion of those patients who are long survivors, especially the younger patients, would not have histology that would not be considered glioblastoma now. They're either IDH mutant grade 4, or they are pleomorphic xanthar astrocytoma. We've seen weird pilocytics in this kind of category where we send it off for methylation profiling. So I think, if you start interrogating those tumors again, a lot of them are going to have something that distinguishes them from traditional glioblastoma, but not all. I mean, I think there are some real long-term survivors with glioblastoma molecular alterations. Whether you need a rebiopsy to make that distinction, I'd say in most cases, certainly not in the absence of recurrence, but at the time of recurrence, that is where it may be useful. What I tell patients about sequencing is there's a good chance this is going to either confirm what we know already or give us a little bit more information, but not alter your treatment. But there's a small chance we may have something that really does open up other treatment options, particularly at the time of recurrence.
All right. Well, thanks again, Dr. Coleman, for a great overview of current state, and appreciate you being here today.
Thanks a lot.
And we're actually 3 minutes ahead of schedule. So we're going to try to keep everybody on time. And that's the nice thing. We don't necessarily need to build in coffee breaks. You can just take them as we go, as long as you mute yourself when you walk into the restroom. It is my pleasure to introduce our next speaker this morning. Dr. Orlev is our fellow this year in our skull base and surgical neuro-oncology fellowship here at Swedish. And he is an accomplished neurosurgeon who originally trained in Israel, along with being an accomplished fighter pilot in the military. He's probably one of the few flight surgeons I know in neurosurgery. And after completing a 2-year combined clinical and research fellowship at Johns Hopkins, he elected to join us for a year. It's been a pleasure working with him. And he's going to give us an overview of what's new in glioma surgery. Or as I like to subtitle it, it's not just meatball surgery anymore.
Good morning. Thank you. Can you hear me?
Yes.
Yep, we can hear you.
Okay, good. Let me share my screen. Thank you very much, Dr. Litvak. Okay. And you can see my screen, I hope.
Yeah.
Okay. So, my name is Dr. Alon Orlev. As Dr. Litvak said, I'm his fellow, and I work under his guidance here at Swedish. I'm going to talk about what's new in surgery for glioma. There are a few topics, small topics that I'm going to talk about. None of them, as we can expect, solves cancer yet. I have no disclosures, and we're going to talk about the first two are going to be adjuncts that we have in surgery in order to help us get a better resection, do a better job. And I'll go into detail about both of them. The third one is a replacement to our conventional craniotomy. That's a lit. And the fourth one is an adjuvant therapy that we use in intra-op, but it's part of the entire treatment that the patients undergo or comes to replace possible post-op treatment. So the first one is the minimally invasive port-based surgery. So we have surgical challenges with accessing deep lesions. Transparenchymal approaches have been quite devastating for patients. Classically, we've used PAL retractors, and that's been shown to cause quite a lot of flare damage and clinical and be clinically morbid on these patients. And in recent years, there has been quite a bit of development of minimally invasive tubular port systems, and they've been shown to cause less retraction trauma and allows us to access these deeper lesions. And so I'll show a little bit about these. There's growing experience. It started off by taking deep-seated hematomas out, spontaneous hematomas, and it expanded over the past few years to surgical resection of different lesions that are deep and difficult to access. There are really two systems that are the commercially available ones that are used. One is the NICO brain path, and the other one is the Vicor VBAS. There are other cost-effective systems that have been described by various people around the world, and I'll show an example of that. Intraoperatively, these tubular retractors are advanced from the cortex to the target lesion using navigation, and we dock on the lesion, similarly to how we do a biopsy, but we have a bigger port that essentially allows us by manual microsurgical technique, which is the way we like to do surgery, having two hands, two instruments that we can suction and work within the cavity. So just some of the examples. On the left side, we see the Vicor system, which is oval. In the middle, we see the brain path, the NICO brain path, which you insert the entire thing, and then you take out the obturator, and you have the tubular retractor, which is the clear part. And on the right side, you have one of many that has been described that just very similar in size to the others. It's just a cut syringe with a centrifugal tube through it that has been used as well. This is from some of the experience of my mentor, Dr. Litvak. This is a deep-seated, very large occipital, temporal, and some parietal glioma that was resected using this approach through an occipital trajectory. And as you can see, once experienced, you're able to really resect it all through this tube. So there have been some reports about the experience with these. So Eichberg and colleagues in 2020 report on 113 intraparenchymal lesions of all type that were resected by several surgeons from a few centers, like 4 or 5 centers, using this tubular retractor, and they achieved gross total resection 72%, which is great, with new deficits in 10%, that about 4% of them were permanent on a 5-month follow-up. And Kai from Mayo Jacksonville reviewed 309 surgeries in 13 different articles over 10 years. And the most common lesion that was resected was glioma at 41%. And the most common tubular retractor, interestingly, was the modified type, similar to the one I showed on the right from the 3 of them. And gross total resection was achieved in 75% with a 9% complication rate. These are all good numbers. We have to remember a couple of things. First of all, that commonly the lesions that are accessed are deep yet smaller, because very large lesions these are all lesions that were selected to be ones that you use a tubular retractor. These tubular retractors are limited in their size, and you're very limited in your manipulation that you do through the brain. So you normally don't go for very, very large lesions. So the 75% gross total resection is a great number. We have to remember that these are for selected patients. So next, I'll jump to the second adjunct that we have in surgery. It's fluorescence guided surgery. That's been around. I'll talk about that for a bit. And as we know, there's distinguishing between pathologic and reactive cerebral tissue around the tumor is somewhat difficult. We don't have many good ways. We do it by the way it feels, by the way it looks, and the more experienced the surgeon, the less he needs adjuncts. I had the opportunity to train a little bit and watch someone who had probably done over 2,000 gliomas, and he just knew how they felt. And the rest of us would like to and are very much aided by markers of neoplastic tissue, and those have been developed over the past few years, and they've been around for a while. and using these markers, the extent of resection is enhanced, and there is a risk, and I'm going to go over that. I'll show you that as well. So 5-ALA is the one that's been used most. It's a hem biosynthesis metabolite that accumulates in glioma cells about 3 hours after oral intake, and that's what we do. We give these patients the morning of surgery, early in the morning. We let them drink it, and then and it emits this violet red fluorescence when excited by blue light. I'll show an example. I'll show a picture of that. It was approved in Europe in 2007, and then much later in the United States. There was a landmark study in 2006 that on 322 patients that showed great results. It showed that complete resection was achieved in 65% versus 36%, and progression-free survival was also enhanced greatly from 40 or 6 months progression-free from 41% to 21% for the patients that had 5-ALA used in their surgery. So that led to the European approval, and quite early on, there were numerous following studies that also showed higher rates of complete resection in glioblastoma and increasing progression-free survival, but it comes at a price, and I'll talk about that too. So this is from a paper, one of the papers that I'm referencing, and this is in A. We can see what the tumor looks like. So when you excite with blue light, you see this violet fluorescence image the asterisk is where the tumor is, and you start resecting that, and that's all great because it lights up where the tumor is. Then once the tumor cavity is empty, or you've completed the resection of the enhancing area, then you get to B. And B is so the brain itself is blue, and what you see in violet color is area where there are potentially tumor cells that may not enhance on imaging, but these are tumor cells that with the uptake of this of the 5-ALA, and then you can continue resecting, and that leads me to and we know these tumors are infiltrative, so that leads me to some of the criticism, and that is that the fluorescence never ends really, and the problem with these is that it has been shown that these patients have more neurologic post-op issues because of the extent of resection is larger, and understanding during surgery when to stop when you're actually exciting when you're looking at through this blue light, and you see that there's still fluorescence in the tissue well beyond where you intended initially to resect. So that's one criticism. The second one is that many people have been talking in recent years and previously about anatomic supramaximal resection, and that may be advantageous to understand the anatomy and the physiology of where you're working, to be aided by either having the patient awake or doing neuromonitoring, and to design your surgery not based on what enhances, but rather to create a supramaximal resection, knowing that you have a lesion that the intra-axial tumors go way beyond the enhancing or what you see in the imaging. And getting the supramaximal resection has been shown, again, not using the fluorescence, has been shown to be effective in both overall and progression-free by the people who choose to do that. Again, it has its limitations and also its risks. And lastly, the criticism is that the 5-ALA is less effective in low-grade gliomas. It doesn't shine as much, and that's where it counts, getting a complete or a supramaximal resection. Just briefly, there are a few other fluorescent systems or molecules. One is fluorescein sodium. It's an intravascular fluorophore. It's IV. It's given IV intra. It accumulates in glioblastoma cells due to breakdown of BBB, and it's less specific than 5-ALA because it accumulates in peritumoral edema as well, because we know that the edema is partially because of this breakdown. ICG, it's another intravascular that is very much used in cerebrovascular neurosurgery because because you can see the vessels very well. It has a second peak 24 hours after admission, and it's similarly because of vascular permeability. It will light the tumor cells, but also the peritumoral edema similarly, and it has some of the same problems. Recently, there's been tumor paint here out of Seattle. it's interestingly, it's extracted out of scorpion venom, and it binds to glial tumor cell surface. Low and high grade gliomas, there was a phase 1 study in 2019, and we're still waiting to see what this may give us. I'll continue and talk about LIT. So LIT, again, is we're switching gears a bit. This comes to replace our standard craniotomies in many ways. It's a laser interstitial thermal therapy. It's a minimally invasive stereotactic insertion of a probe that creates a thermal lesion. It's a laser probe that creates a thermal lesion within the brain where you want it inside the tumor. There are two systems. They're Medtronic Visualase and Monterey's NeuroBlade. They're both MRI compatible cooled probes that have reproducible MRI thermometry, and we actually use the MRI in order to see what we do or how hot the area is, to both plan and also create the lesioning within the lesion. So the treatment steps are the trajectory from the skull to the lesion is planned, similarly to the way we do a biopsy. A bolt is fixed into the skull at the entry point, and this is all done in the MRI room. The stereotactic needle is advanced through the bolt into the lesion. The laser probe is inserted into the needle, and then the laser is turned on, and it's directional, and it creates it increases the local temperature inside the lesion, and over time you create this thermal injury of the lesion itself. So these are the two systems, the Medtronic and the Monterey's, and again they're both used inside the MRI, and we can see in the Medtronic one there's a picture of the laser itself that is directional, and you turn that around and you create your the lesion that you want to create. So there's a little bit of experience in that, not much. In high-grade gliomas, it was mostly used for residual or recurrent small tumors, and that's important. You can't do it for very large tumors for similar reasons that we talked about, and also because the thermal injury can go beyond. So some have talked about less than 50 ml, others less than 35. And in high-grade gliomas, it's been used following other treatment modalities, again, commonly for recurrent gliomas. Small series of 10 and 4 patients with deep recurrent GBM that underwent LIT showed extent of survival, which was great, 9 to 11 months. We know that in recurrent GBM, we're talking about 3 to 5 months. So this is something that may be promising for these recurrent GBMs. Again, deep, small. Low-grade gliomas, it's again, mostly deep-seated, less than 35 mLs. There were 18 studies on 98 patients with LGGs that underwent LIT as a single treatment. It seems to be well tolerated without permanent deficit, and the tumor sizes mostly remain stable, which is what we want it to look like once we lesion and heat it up. There isn't really yet true long-term data about progression-free and overall, just very, very initial ones. No clinical trials yet that have been published or long-term results, as I said. And the complications are seizures. That's not uncommon. Peritumoral edema and post-op transient deficit of around 5% permanent. Transient is more, 5% of it is permanent. Not very different than surgery, really. And my last topic in this talk is going to be about intraoperative brachytherapy. So brachytherapy is essentially, as we know, it's implantation of radioactive sources inside tumor cavity. It's been used for many different tumors, many different cancers, to reduce local recurrence. It has been tried in the CNS interestingly, since 1936, using the various radioactive isotopes that have been both minimally successful, and also there was a lot of issues of the radiation necrosis around that. So we've been honing in recent years to cesium-131. It's emerging as a promising isotope for many reasons. One of them is that it has a half-life that is quite short, less than 10 days, which is much better than the next one, which is iodine, which has 50 days, over 50 days, and it's been just safer to use. So Gamma-tile, that's a product that's around. It's cesium radiation emitting seeds that are implanted in nice pliable tissue adherent collagen matrix tiles. It simplifies intra-op placement. So once we finish resecting the tumor, we place these gamma tile pads, which are a little less than an inch by inch each one. They're placed in a single layer inside the surgical cavity following tumor resection. As I said, they deliver about 120 to 150 gray at the surface. Interestingly, they're not sitting while the gamma tile sits on the surface. These the radiation emitting seeds are a few millimeters above the surface, which is safer. And at a depth of 5 millimeter from where they're placed, it's about 60 to 80 gray. They're approved for treatment for any newly diagnosed or recurrent malignant brain tumor. And where do they come into play? We don't really know yet. I'll talk about that in a second, but they may be designed to replace or augment post-surgical radiation therapy, which we know for high-grade gliomas, according to the STU protocol, we give 60 gray at 2 grays per day. There's a picture of what it looks like. The limitations, the implantation requires either gross or near total resection because, as I said, it doesn't penetrate very far. So if you have a multifocal or GBM, or you're just not resecting all of it, it won't be as good as post-op radiation because, again, it's just very local. And it may increase the rate of post-op infection, seizures, and radiation necrosis, peritumoral. We don't have enough data about that really yet. So there are ongoing clinical trials assessing the safety and outcomes. Interestingly, there was a study by Chen and colleague on 18 patients with GBM that were treated with resection, then gamma tile, then post-op radiotherapy, and that was terminated due to high toxicity of 61%. And there are other studies, 2 other studies on 11 and 17 patients with GBM that were treated with resection and brachytherapy instead of the post-op radiation protocol. And those came to a progression-free survival of 7 to 10 months and overall survival of 9 to 16 months. You know, it's similar to what we know, right? These are not numbers that change GBM treatment, but it still has advantages. You don't have to bring the patient for 30 days in. It's something that ends intraoperatively by placing these pads that take a few more minutes. So it may have a role in the future, and it may replace post-op radiation to a certain degree. These are my references of the different studies for this talk, and I will gladly answer any questions.
Nice talk, Alon.
Thank you.
Yeah. I wonder whether there are a subset of patients you think that may benefit from ALA guided therapy surgery. I know you said low grade, it doesn't diffuse well, and high grade, it's all over. What about maybe anaplastics? There's less microvascular proliferation, or unifocal diseases. What's your thoughts?
So it's commonly it's used for GBMs when we think we have GBM, or when we don't really know. We like to use it when the tumor enhances. So that can be a grade 3 or a grade 4, because then we know it's going to the chances of the uptake are high. And like any surgical tool, it's great, but you have to know your limitations. You have to understand where you are, and intra-op you keep switching because you can't really do a lot of surgery under this blue light. So you switch to the blue light, you see where it shines. Sometimes it's very obvious because you're in the middle of the tumor according to navigation, and then you don't need it. And then once you finish resecting the tumor and you have the cavity, then you start looking at this, you keep switching to this blue light, and when you see that it areas that it enhances, if it's areas that you anatomically feel comfortable about resecting, it's worthwhile. The reason is because we have numerous papers that shows that we, by doing so, we extend their progression-free and overall survival. So it's a great tool, but you have to remember that it can be a dangerous tool if you just follow the shining light.
Yeah, I agree.
I would like to just add to that. Alon, good talk. Sorry I had to step away for a minute to go down to see a patient, so I missed some of your talk, but I think 5-ALA is great. in a certain sense, but last year we had a talk by Sean Hervey-Jumper from UCSF, and he had this graph that shows, between 20 and 80% of resection doesn't really impact overall survival for GBM. Anything above 80% does. My question has always been, is there good evidence that between 90% and 110%, like the Ray Sawaya kind of super maximal data, does that really help a patient overall survival? And certainly I myself have had neurological deficits post-op because you keep going after that red stuff, and then next thing you know, you've caused injury to the patient. So I think it's really one of these surgical judgment issues that you have to put all the factors together. What are you trying to accomplish? How old is the patient? Is it a younger patient? I mean, to some degree, like an 80-year-old with a giant multifocal GBM, you're not going to try to cure the case by taking the tumor out. So I think it's just one of these things where it's really got to be individualized.
Yeah. I also want to throw one more thing in there. I'm not sure this has ever been validated, but the MD Anderson group, Dan Cahill also did analysis looking at extended resection as a function of IDH status, and made this observation that extended resection of enhancement was prognostic in the IDH wild type GBMs, but total extent resection, especially non-enhancing, was important in the IDH mutants. And so I think that sometimes comes into our estimation, our analysis of benefit of additional surgery for patients when we see them and we have the pathology and we know which class they are, sometimes going back for additional resection of non-enhancing disease in the IDH mutants. But, if you get all the enhancement in a big, expansive GBM, maybe leave them alone.
Yeah.
Good point.
So I think that, as I said, for the low grade, which many of the IDH1 mutant are, that's where it really counts. And 5-ALA doesn't help you much because often these are not the ones that enhance, so they may not shine. Or many do give those, but you can't really count on that shining very well. So that's one of the main criticisms of this. And I don't know much about this, the very new tumor paint, but they seem to claim that it works also for low grade. So that may be a future promise.
Great.
Well, great. So I think we'll move on to Dr. Kamsen.
We have a little switch, Dr. Kester. Dr.
Oh.
Romo and Kamsen are going to switch spots.
I see.
Dr. Romo and Romo's up next, and Kamsen was kind enough to switch with him. Thank you.
Thanks, everyone. Thanks, David, for switching with me. I just have clinic starting in about 20-25 minutes, if that's okay with everyone. I am going to share my screen. Can everyone see my screen and hear me okay?
Yes.
Great. So first off, thank you again to Matt and the organizing committee for the invitation to participate. I'm thrilled to be here and be part of this. So I'm going to chat with you about mostly clinical and some molecular determinants of outcomes for people with NF1 who develop non-optic pathway gliomas. And specifically, we're going to chat about adults with NF1 associated tumors. I don't have any financial or competing disclosures. Just as a very brief background, we all know NF1 is a tumor predisposition syndrome that puts patients at risk of developing both benign and malignant tumors. And CNS tumors are really overrepresented in people with NF1. In kids, we know that optic pathway gliomas are common. In adults, high-grade gliomas are a little bit more common than the non-NF counterparts. Unfortunately, the natural history of these NF1 gliomas, specifically the non-optic ones, is not really well understood. And that poses many, many challenges, including that no standard treatments are available yet for this population. We tend to borrow a lot from the sporadic gliomas, but as you'll see from my conversation with you today, but there's really no standard treatment for people with NF1. So in order to understand these tumors a little bit better, we conducted a multi-center study with adults with NF1 who developed a non-optic pathway glioma, and this is a retrospective study. The objectives of the study were to evaluate the overall survival of adults with NF1, that's 18 years of age or older, with a histologically confirmed tumor. And we wanted to, as secondary objectives, look at the distribution of those histologic subtypes, what kind of tumors were they developing, and also evaluate the prognostic relevance of the commonly used variables to predict survival in the sporadic glioma cases. So histologic diagnosis and WHO grade, extent of resection, age at the time of diagnosis, the performance status, tumor location, and molecular data when available. With this being a retrospective study, we were missing a lot of the molecular data, and we were looking back since 2000. So the 20-year interval didn't lend itself for a lot of molecular data being available, especially for the early cases. And lastly, we wanted to evaluate the treatment patterns that were used and the response to therapy. So we evaluated any patients from 2000 to 2019 who were treated for a glioma and in the setting of NF1 at Johns Hopkins, Memorial Sloan Kettering, and Washington University. And we collected retrospectively data on their clinical presentation, how they were treated, if next generation sequencing or immunohistochemistry stains were available. We did that as well. We took that information and evaluated their radiographic monitoring studies as well as their survival. We recruited 3 neuropathologists, one from each of our institutions, to review all the slides together and evaluate how difficult or not it was to grade and classify these tumors. And I'll talk to you a little bit about that. And then we analyzed the data using statistical methodology. We were able to recruit 41 patients that met eligibility criteria. You see that the sex distribution was pretty fairly distributed with 21 females and 20 males. The median age at diagnosis was 32 years of age, which as you can see is surprising for a glioma population. The median Karnofsky performance status was 80%, but it ranged from 30 to 100%. You'll see that some patients were asymptomatic and it was an incidental finding at the time of diagnosis, but usually they presented with symptoms, and the more common ones were headaches, ataxia, visual disturbances, sensory deficits, and dysphagia. But we had many, many different presentations, including hiccups, and like I said, asymptomatic patients that were getting MRIs for evaluation of a known focal area of signal intensity, also known as a FOSI or a UBO, common findings in people with NF1. One of our objectives, as I said before, was the distribution, learning about the distribution of the kinds of gliomas that our population had. And as you can see, the more common ones were diffuse astrocytoma, WHO grade 2, and glioblastoma in 26 and 20% respectively. But we also had a few cases, that 14% here, others, that were a wide variety of things, including an embryonal tumor, neuroepithelial tumors, poorly classified. And there were 6 cases out of those 41 where the pathologist actually really struggled to classify them, as they did not meet any of the classical features from the WHO classification. So you can see here pilocytic astrocytomas and high-grade gliomas with pilot features, and anaplastic astrocytomas were also relatively common. And feel free to stop me and unmute yourself and ask questions as I'm talking to you guys, so I can answer questions. I'm happy to do that. IDH status was something we explored, and we expected them to be IDH wild type. 100% of the cases that we've seen of gliomas in the setting of NF1 are IDH wild types. Unfortunately, next generation sequencing was only available in 10 cases, and it varied widely what kind of genes and panels were tested or used. But as expected, in those who had an NF1 gene mutation tested, it was present and it was pathogenic. Additional variants included amplifications or mutations in EGFR, ATRX, CDK2A, NB, P53, TERT, and MSH, among others. MGMT promoter methylation status was only available in 11 cases, out of which 7 were unmethylated. One of the interesting findings, we kind of had an idea that most tumors would be located in the midline structures, but it was a little surprising that 70% of the cases were located in one of these structures, either brainstem, thalami, basal ganglia, or spinal cord. We weren't expecting such a high percentage of cases of midline gliomas. This is diffuse astrocytoma, whole grade 2. And you can see that it is T2 and FLAIR hyperintense, but had minimal to no contrast. But in case 2 and 3, these are also diffuse astrocytomas, and you can see that there are patchy areas of enhancement that we can see and affecting the brainstem, the midbrain there, and the thalami with extension to the midbrain in this case number 3. Case 4 is a tumor which was poorly differentiated and difficult to classify. It had some neuroepithelial features and gangliocytic features as well. And that patient did relatively well after resection. Case 5, unfortunately, was a case of glioblastoma, and you can see kind of that typical classic butterfly distribution crossing the corpus callosum with some areas of contrast enhancement and T2 and FLAIR hyperintensities. This is a case that was really interesting to me, a patient who was about 40 years of age at the time of diagnosis, who presented with this contrast enhancing lesion in the cerebellum, in one of the cerebellum hemispheres, very close to the peduncles, who started treatment after a biopsy with trametinib. He did not receive any frontline therapy with cytotoxic medications or radiation. And after receiving trametinib, soon after, he almost had a complete response where his tumors, the areas that were enhancing, almost completely disappeared. Unfortunately, the response was not well sustained, and after a few months, he started developing worsening of his condition. But he stayed stable for a pretty long time, and either stable or had some stable disease for a little while. Here is a case of a patient that I just saw recently, just a couple of weeks ago. He is not a case that was included as part of the study, but I thought it was interesting to show because it is also another patient who received frontline therapy with MEK inhibitor as opposed to STUP therapy with temozolomide and radiation. And you can see the progression of his disease. This is a patient with neurofibromatosis type 1. He is 21 years of age, presented with a hemorrhagic stroke that was later found to have an underlying tumor. Pathology was done in May. He had a gross total resection, beautiful resection, and he had a low-grade astrocytoma with pilocytic features, but there was something unusual about his histology. And as you can see here, which was pretty unexpected for a pilocytic astrocytoma, he started having recurrence of the tumor pretty soon after the surgery. And again, this is real recurrence. This is not pseudoprogression, as the patient had not received any radiation yet, or hasn't received any radiation at this point. We spoke with him about the natural history of these tumors and that we don't understand it very well, but in some cases we've seen that even low-grade gliomas can have a more aggressive clinical course in the setting of NF1. So he ultimately decided to start treatment with MEK inhibition, in this case with selumetinib, and we can see just within a month after starting treatment, this is late November, just before he started the selumetinib, and after a month of treatment, his tumor had significantly decreased in size. Going back to our study, the extent of resection, given that the cases were mostly located in the midline, were mostly biopsies with a few subtotal resections and very few gross total resections. Most cases had chemotherapy and radiation administered, by a portion of them, about a third of them, only received surgery as treatment and were monitored until disease progression. Radiation therapy as monotherapy was also administered in a very small percent of patients. And there was one patient in which we made recommendations of using chemotherapy, but he was lost to follow up. We only found out that he passed away a few months later, so we included him for survival analysis. The antineoplastic agents, for those neuro-oncologists here interested, that were used were 15 cases of temozolomide, trametinib as frontline therapy in 4 cases. Some people used bevacizumab, carboplatin, and procarbazine, either monotherapy or in combination for the treatment of these patients. 5 complete radiographic responses were seen, but most of them were either stable disease and some partial responses or disease progression. 13 patients were still alive at the time of the analysis and were censored at the last time of follow-up, with a median survival of 23 months, which is a little bit better than our glioblastoma population, but still, this is a mixed group of patients and histologies. This is the Kaplan-Meier curve for the entire population for those in whom we had survival. As I said, the median was 23 months, ranging anywhere from 2 to 109 months. This is Kaplan-Meier survival analysis based on the WHO grade. And as expected, those with grade 4 and grade 3 tended to do more, tended to do poorly, but still not as poorly as their sporadic counterparts. Ki-67 was the only part of our analysis which was significant, statistically significant, with a higher percentage of people passing away at earlier stages if they had higher KPS. But the other prognostic factors that we commonly use were really not statistically significant, although of course this is a small population. Again, this is another Kaplan-Meier according to histologic grade, regardless of their WHO classification in terms of grading, but most of them followed the traditional grading of glioblastoma being 4, pilocytic astrocytoma being grade 1, and diffuse astrocytomas being 2. Resection was really not statistically significant. Whether they had a biopsy or a gross total resection didn't make much of a difference, but there was a tendency for a better survival when the biopsy with gross total resection versus biopsy. And age, again, did not play a significant role in how these patients fared. We did the analysis by dividing the group into those who were greater than 40 years of age or younger than 40 years of age. So in conclusion, non-optic pathway gliomas in adults with neurofibromatosis type 1, even those that are low grade, can have a more aggressive course than expected. And this has been seen in other studies. This is the larger population that's published. It's not yet published, but it's been submitted for publication. But this is the largest cohort of patients with histologically confirmed gliomas in adults. It's a little bit different from kids, but our findings are supported by other studies that are out there that are smaller. And tissue diagnosis based on morphology coupled with molecular data is likely to improve prognostication. So we hope that as we move forward to more NGS collections and sending for genetic testing, this will improve with time. And that will in turn, hopefully, improve how to monitor and select treatment protocols for these patients. But we still need further evaluation, and a systematic and prospective evaluation of the natural history of people with non-optic pathway gliomas in NF1 is clearly necessary to understand and treat these patients better. So with that, I'd just like to acknowledge everyone from the 3 institutions that participated at Hopkins, MSK, and WashU. All of them were instrumental in the collection of data and the analysis of this study. And I'm happy to take any questions if there are any.
Great job, Carlos.
Really nice talk, Carlos.
I had to step away in a couple minutes, but I just want to ask, do you think the new World Health Organization classifications that are coming up later in the next years, do you think these patients should have their own category of subtype of glioma?
Yeah, I think so. I really think of these people with NF1 who develop a glioma as having a completely distinct entity compared to the non-NF counterparts. They have different response to treatment. They have different overall survivals. Their molecular features appear to be different. But again, there's a lot to be learned. But I do think that at the end, we'll learn that these are completely different entities compared to the non-NF counterparts.
Sounds like the next C-impact.
Yeah.
Carlos, my question is related to what we discussed earlier, targeted therapy and combinational therapy. Has that been attempted with NF2 gliomas, like combining solanezumab or trametinib with Temodar, standard of care?
That has not been, there is no prospective study in adults using combination therapies. There are some clinical trials that are ongoing and that will open soon in pediatric population where there's combinations of MEK inhibition with other agents. And Dr. Schreck is here, so she's going to talk.
Right, I figured that, that's probably, I can wait till her talk. She may.
Yeah, but these patients don't have a BRAF mutation. It's extremely rare that they have a BRAF mutation. Right. So maybe Carissa will shed some light into those BRAF inhibitors that are not paradoxically activating the MAP kinase pathway in people without a BRAF V600E mutation. But it'd be interesting to explore that and combinations with other targeted therapies, including mTOR inhibitors or SHADE2 inhibitors, things like that. Those combinations tend to be very toxic, but that's a potential avenue for evaluation.
Right. Great. Thanks. Great talk.
Thank you.
Thanks. So our next speaker is Dr. Kamsin. It's my pleasure to introduce him. He is at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. He did a PhD in neuroimaging. Following that, he did residency at University of Chicago. He also completed joint fellowship at research fellowship also at Johns Hopkins and the NIH. He is on a mission to redefine the way we image brain tumors. He's a dad. I spoke to him a few years ago or so. He was busy chasing his kids, and we're happy to have you. And he's going to give us an update on how we image brain tumors.
Thank you so much for the kind introduction. Can you guys hear me?
Yes.
Excellent. And you guys can see my screen?
Yes.
Perfect. All right. So thank you so much for having me. So the only disclaimer I have is I'm a neuro-oncologist and neurologist by training, not a neuroradiologist. So I have a certain bias when it comes to imaging. So I will start with just talking about the standardization efforts that we have ongoing in neuro-oncology. And I think these are the things that we don't talk enough about. So it's really important to highlight them. First key to this initiative is the publication of the Brain Tumor Imaging Protocol, or BTIP, in 2015 by Ben Ellingson and colleagues, which established desired parameters to be used and sequences to be used to image primary brain tumors. One of the key things, need to go back. So one of the key things I want to emphasize in this is the recommendation of thin slice images and 3D image acquisition, which is really, really key if we want to do machine learning applications in the future. This publication was followed up in 2020 with the BTIP brain metastases recommendations, which are largely similar to the primary brain tumor recommendations, but with a few tweaks that allow us to generate better contrast using TSC instead of GRE images for small brain metastases and allow us to detect calvarial lesions. But one of the key things I want to emphasize is this manuscript also increased recommendation for standard parameters for perfusion, which is becoming standard of care in neuro-oncology. So the next important initiative I want to talk about is the Brain Tumor Reporting and Data System, or BTRADS. This is an initiative that is coming from Emory, and it essentially utilizes the FLAIR, the T1 gadolinium, and the treatment information to standardize the language of MRI reports in neuro-oncology and harmonize the interpretation across the board of providers and neuroradiologists. The score goes from 0 to 4, where 0 represents the baseline image, 4 represents unequivocal tumor progression, 2 represents no change. And the most debated area is score 3, which is subdivided into 3 groups of certainty. So 3A favors treatment effect, and 3C favors tumor progression, and 3B is indeterminate. So this is not perfect, but I think this is a very reasonable compromise to help synchronize the language we're using around interpreting imaging. So I'm going to talk a little bit about new and old imaging tools, and one of the more exciting ones is 2-hydroxyglutarate imaging using MR spectroscopy. This is not a representative set of images, unfortunately. So on the right, you can see a super resolution MR spectroscopy image, which is generated using upsampling of the conventional MR spectroscopy and combining it with some of the data from the structural imaging. So this is not really representative of the state of the art, and it's not really representative of how in reality the data is acquired. But I'm hoping that in the next 5 to 10 years, this will become standard and we will have such high resolution 3-dimensional MR spectroscopy images. The next newer kid on the block is chemical exchange saturation transfer, or CEST MRI. This is a method that utilizes radio frequency excitation to saturate the signal of exchangeable protons on molecules we want to quantify. And as these protons get exchanged with the surrounding water, we generate a negative contrast, and we can pick that up on imaging. And we can do multiple transformations to generate a magnetization transfer ratio, which can be mapped out and used to quantify drug concentration or compound concentrations in vitro, as well as in vivo. One of our interests at Hopkins and the push that we have is to develop novel contrast agents using CEST by transforming already available, safe, FDA-approved agents such as sugar. This paper was published a couple of years ago showing glucose signal within a low-grade glioma after the administration of a bolus of glucose. And we are working on developing dextran to varying weight dextrans to map out the permeability of tumors. And the basic idea of this, and this is sort of a timeline or map of what it would be interesting to develop, going from the lowest molecular weight contrast agent glucose through gadolinium, through dextran 1, 10, and 70 to develop detailed permeability maps for tumors. And the next thing, next exciting thing in CEST imaging is potential use for PK imaging. So my collaborators, Drs. Liu and Van Zyl, have shown that certain anti-nucleotide and anti-folate chemotherapy drugs generate a CEST signal that can be actually captured on an MRI. And just a demonstration animal model that you can map out the distribution of these drugs. So I'm going to talk a little bit about radio tracers. One of the newer, increasingly used tracer is dotatate, which is a somatostatin analog. It's actually gallium-68 gallium dotatate, which is used in meningioma imaging. These grade 1 meningiomas express somatostatin receptor 2, which allows us to image them, and many of the grade 2s and some of the grade 3s as well. So it helps delineating targets. And I'm going to talk a lot about amino acid tracers. One of the new and coming ones is fluciclovine or Examin, that is already FDA approved for prostate cancer imaging, and it is being studied in the context of neuro-oncology. So I'll get back to this tracer a little later. And the last very exciting tracer to me is developed at Hopkins. This is a CSF1 PET tracer. It's highly specific to microglia, and it will allow us to better map out the neuroinflammation and the pre-metastatic and metastatic niche that is associated with brain cancer. So going back to the big questions in neuro-oncology, once we have the initial diagnosis, it boils down to really 2 or 3 questions. And the first one is, where are the margins? The second one is my treatment working? And if we see changes, is it treatment effect or is it tumor progression? But the third thing is actually the more exciting question. And I think in the next decade, that's where imaging will reposition itself, is developing predictive radiographic biomarkers to guide decision making. So instead of committing to potentially toxic treatments that don't necessarily work, we could help choose the right drugs for patients using imaging. So I think you guys have already seen this figure, and I just want to emphasize again that gliomas are whole brain disease. So you see cancer cells even in the macroscopically and radiographically normal volume. So because of that, local regional therapy is not going to be curative of these tumors, but still there are important improvement that could potentially be made. So just going to the regular classical approach, we have a drug that we inject into the patients, and we do a pharmacokinetic analysis, and that's actually the contrast, gadolinium contrast imaging. You can do it dynamically, and that's perfusion. So you have a general vague idea about the blood-brain barrier breakdown, but only at the level of gadolinium. And when you look at the T2 flare image, which is highly sensitive but highly non-specific, you will see this. So this is a combination of scar tissue, pure vasogenic edema, and tumor-infiltrated edema, and there are no margins here. So along these lines, me and my collaborators, we did a study about a decade ago using an amino acid PET tracer called AMT, or alpha-methyl-tryptophan. I manually segmented the metabolically active tumor volume, the T2 flare, and the gadolinium volume. And not surprisingly, what we found, and this is in gliomas, that the T1 gadolinium volume was the lowest, and the T2 flare volume was the highest, and the metabolic volume was in between, and all of these were significantly different. In a subsequent concordance analysis, what we found is that 20% of the tumor volume that we see were exclusive to the amino acid PETs, and 40% of the T2 flare hyperintensity did not have corresponding metabolic signal. If you look at the right side of the figures, you can see that all GBMs had amino acid PET exclusive area, whereas some lower grade gliomas had those too, not all of them. One caveat is that the gadolinium enhancing volume was also always metabolically active. We followed this up with an analysis of a couple of patients with surgical sampling of these areas based on the imaging findings. And not surprisingly, the solid tumor defined by gadolinium enhancement, which was again metabolically active as well, had the highest semi-quantitative tumor cell concentration. Areas that appear radiographically normal had still had tumor cells detectable, and the metabolically active but non-contrast enhancing tumor volume had an intermediate tumor cell concentration. And this takes us back to Dr. Orlov's excellent presentation about how should we think about margins. And one of the things I think would be the best approach is to think about tumor cell gradients. We cannot delineate the whole thing, but we could potentially establish a metabolically active tumor volume where we can make a difference. I actually removed that figure, but I've had a 5-ALA study referenced using FET-PET, which is another amino acid tracer, that showed just that this was a German study, or a French study. They couldn't get negative margins using 5-ALA, but there was always the residual PET and MRI positive areas were all positive for 5-ALA. So there appeared to be no false positives based on MRI or PET. So a follow-up study on this was in 2015 using FET, which stands for fluoroethyltyrosine, where they assessed the prognostic value of the biologically, the metabolic tumor volume. So high PET, I'm just going to refer to it metabolic tumor volume. So those patients who had low metabolic tumor volume had better survival than those who had high metabolic tumor volume. And the most important thing of the study is not that, but they divided the patients to a group who only had biopsy and another group who had resection. For the biopsy group, the initial metabolic tumor volume was prognostic. However, for the resection group, only the post-resection metabolic tumor volume was prognostic. So it's not predictive, it's prognostic. But it gives us an idea that this is not an inherent characteristic of the tumor. We might be able to surgically modulate this and do more adequate cytoreductions using PET targeting. And of course, the study involved a multivariable analysis where the PET volume actually completely obliterated the MRI volume as a predictor of survival. So another study, which was published a year ago, followed this up using an identical tracer, essentially MET, which is C11 methionine. They recruited newly diagnosed post-operative patients who got a PET scan before radiation. They established the metabolically active tumor areas, as you can see here, and they included it in the radiation field. And then they assessed the patterns of recurrence and survival and outcomes. So one of the main findings was that 45% of the patients who got gross total resection defined by MRI still had residual metabolically active volumes, and only 33 patients who had only 33% of the patients, so 1/3 of them had no residual metabolically active tumor. So this is quite shocking, and I think it may explain some of the inconsistencies in the extent of resection studies. And it also emphasizes that it may not be the actual extent of resection, but the residual tumor volume that mattered. So this study also included a multivariable analysis for overall survival. Here, the MRI residual survived the adjustment for other factors, but metabolically positive volume remained highly prognostic for survival. And if you can see, if you look at the Kaplan-Meier curve here, the metabolically negative and MRI negative volumes, patients with MRI and PET negative resection margins lived significantly longer, and those who had metabolic activity in the residual areas had a shorter survival. But the kicker is here. 80% of the recurrences still happened within the radiation field local to the area of positivity. So I think PET can help guide surgical resections and planning, but the regular radiation techniques may not make a major difference when it comes to integrating amino acid PET. And the follow-up of this study was a plan to do a boost study where they boost a metabolically active volume. And a similar study was performed in the United States, led by Emory in collaboration with University of Miami and Johns Hopkins, where they used MR spectroscopy and they used a colon to NAA ratio maps to deliver a 75-gray boost. So 15 gray boost to patients. This was a phase 1 study. It completed and enrolled 30 patients and was deemed safe. The anecdotal part of it is I've had 3 patients of the study and they all outlived the expectations by a year. But how do we approach response assessment these days? So this is a time-lapse view of a patient who was an IDH mutant tumor and was treated with off-label ivosidenib at one point. And as you can perhaps appreciate, the tumor expansion slowly decreased to some extent on ivosidenib. We did 1-dimensional, 2-dimensional, and volumetric analyses, and I think you can appreciate the volumetric changes were the most remarkable. So that puts a question as to what are we missing by just looking at the 2 largest perpendicular diameters to assess response by standard. So this is the same patient from a sagittal view, and you can see we are missing a lot of information on the time lapse if we just are focusing on a single cut. So this was also corroborated by Ben Ellingson's recent paper in neuro-oncology, comparing the standard Raynaud low-grade glioma by perpendicular diameter versus volumetric analysis, and they showed that treatment response assessment was much better using volumetric data. So the problem with volumetrics really is it's difficult to do it. I think computational advancements were necessary for us to be able to do this more consistently. Another trial that I want to show is the Severum trial, which used everolimus and octreotide to treat aggressive recurrent meningiomas. And they had shown a significant change in the growth rate of these meningiomas on the volumetric analysis. So before treatment, it was about 17%. Growth actually halted in the first 3 months of treatment, and then it remained reduced for the second 3 months of treatment. So this was a fine demonstration as to how to still capture activity of regimens that may not lead to partial or complete responses. So going back to the segmentation issue, the last important initiative I want to talk about is the BRATS, or Brain Tumor Segmentation Challenge, that collects AI experts from all over the world to train AI to do the segmentations for us. And it's becoming really, really good. So I think in a couple of years, we won't ever have to manually segment tumors. We will just rely on these algorithms. So the last couple of things I want to talk about is, again, Examin, an amino acid PET tracer that is approved by the FDA for prostate cancer imaging, and preliminary data showed that it was also helpful in differentiating malignant lesions from necrosis in previously radiated patients. And there are two concurrent prospective trials going on. One is the Pursuit trial, which is phase 2 and tries to assess the best way to interpret fusiclovine images, and the Revelate study that is a phase 3 to assess the utility, sensitivity, specificity of Revelate to distinguish radiation necrosis and recurrent tumor. We are aside for this study, and I just enrolled the third patient, so I'm very excited about this. And the last thing I want to talk about is distinguishing tumor versus necrosis using MI proton transfer, or APT, which is a form of CEST imaging done at Hopkins, and this is just a validation study of 60 biopsy specimens from 20 patients, showing that low APT signal predicted necrosis, intermediate signal was associated with necrosis combined with scattered GBM, and the high signal was actually predictive of highly cellular and proliferating glioblastoma. So a lot to cover, a lot of excitements. I just want to thank all my collaborators within the oncology group and at KKI, and outside of Hopkins, Drs. Juhas and Mannitol. So thank you very much, and thank you, Dr. Smith-Cohen, for having me.
Thanks, David. It's a great talk, great talk. We are about 25 minutes behind, so we'll just move ahead with Dr. Lim. And if anyone has questions, you can just text it in the chat box. Okay, so Michael Lim, thank you. Thanks for joining us. Thanks for coming. He is the chair of neurosurgery at Stanford. He has published numerous papers. He's been at Hopkins for some time now and has done a ton of research, translational research, and helped us understand the molecular underpinnings of the tumor microenvironment, the brain, the microenvironment, immunotherapy. He's published a lot. He's given a lot of lectures, a lot of talks, and he's going to give us an update on immunotherapy for brain tumors.
Thank you so much. Thank you, Dr. Phillips, for that kind introduction. Can you see my slides?
Yes.
Okay. So first of all, I want to say hi to everyone in the crowd. See a lot of friends from Hopkins too, and so I miss you all, and it's wonderful to see you doing some great stuff. So it's my honor here to talk a little bit about immunotherapy for brain tumors. I'm going to just try to cover a couple concepts over the next 10 minutes. So these are my relevant disclosures. I think we've seen the reports from BMS that said that the large phase 3 trials for anti-PD-1 and newly diagnosed GBMs are negative, and it's matching this first recurrence study. And so there's been a lot of dampened enthusiasm for immunotherapy. And so as we think about mechanisms of immune suppression, it's clear that this mechanism is very different than other cancers. The way we're thinking about resistance these days is that we classify it into intrinsic versus adaptive resistance. And if you look at intrinsic resistance, it's basically what the cancer cells have at the time to suppress an immune response. And for example, prostate cancers have high intrinsic resistance, which is why they're resistant to checkpoint inhibitors. Whereas with adaptive resistant, for example, lung cancers respond well to checkpoint inhibitors, but over time become resistant. As much as 25% of those tumors become resistant. Unfortunately, glioblastoma has high adaptive and intrinsic resistance. And so as we come up with therapies, we have to come up with therapies to address both. Exhaustion is actually one that kind of straddles both of the intrinsic and extrinsic resistance. And exhaustion simply means that a T cell loses its ability to kill, loses its cytotoxic function or cytolytic function due to chronic stimulation, okay? And so if you look at the literature that's out right now, it is very well known that T cells from a tumor, so if you take infiltrating lymphocytes, these T cells are exhausted. And the paradigm was that these T cells enter into the tumor does something to them, and then these T cells lose their ability to kill. This is from Peter Fecci's paper showing that these TILs express low levels of interferon gamma and TNF alpha, which again, are markers for cytolytic activity. So a couple questions I want to address in today's talk. What is the mechanism behind exhaustion? Which cells are driving the exhaustion, and is this exhaustion permanent? So exhaustion is actually an epigenetic phenomenon. It turns out that as T cells are exposed to certain signals, they become, if you look on the bottom part of this line, they have a spectrum of becoming exhausted where they have a progressive, intermediate, and a terminally exhausted state. And there are things such as TCF7, TBX21, and these epigenetic targets actually push a T cell into exhaustion. Now, if you think about what exhaustion is, right, it means that the T cells lose the ability to kill, and why? And if you look, oftentimes it's because T cells have alterations in metabolic function. For example, if you knock out the ability for T cells to do glycolysis, and when these epigenetic changes do indeed occur, they actually lose that ability to do glycolysis. There's also other metabolic pathways that are affected that I'll talk about in a second. Also, the membrane potentials of these mitochondria also become disrupted. And if you lose the mitochondria, you lose the engine to the T cells, and those T cells stop working. So if you look, one of the things that I think are highly relevant to GBMs are the fact that glutamine and glutamate, in terms of the metabolism of these two compounds, are very affected. And it's well known that there's high levels of glutamate in glioblastomas. And it turns out that it has, because of this metabolic change, there are two main effects on glioblastoma to help its tumorigenicity. And on the first part is this is Michelle Mondri's work, and she's kind enough to share this with me. But it turns out that if you have high levels of glutamate, you can actually activate synapses. And it turns out, and if you've seen Michelle Mondri's Nature paper, these glioblastoma cells actually make synapses with neurons. And when these neurons fire, it actually promotes and propagates tumor growth. And you can see from, this is Dr. Mondri's work, that these are actually synapses that are made with tumor cells and neurons, and they are actually firing. And she showed that if you actually, I'm going to skip to this slide. if you actually block those AMPA receptors and block the glutamate, you can actually slow tumor growth. But we were also interested at the same time on the effects of the glutamate on T cells. And it turns out that there's glutamate receptors on T cells. And it turns out that if you, I'll come to this slide, I don't know why I went there. It turns out that if you modulate the glutamate receptors or glutamate concentrations, you can actually improve T cell function. And this is Ravi Medikonda's work when he was in my lab. Basically, we upregulated this EAAT receptor by a drug that was given to us by Biohaven. And he did microdialysis work to show that you can decrease the concentrations of glutamate in the extracellular space with this drug. You can actually see that there's an increased infiltration of CD4 cells into the tumor once you do that. And once you treat these animals with anti-PD-1, you can actually reverse the exhaustion. So there is a metabolic cause to this exhaustion. The other thing that I thought was really interesting was that mitochondria, again, are the engines that drive T cells. And this was a paper that just came out in Science, Nature Nanotech, and then there's another neuron paper. But on this slide up here, if you can see, this is a T cell and this is a cancer cell. And they actually build these nanotube structures that can actually latch onto T cells. And if you look at these T cells, they're actually pulling mitochondria out of the T cells to cause them to become exhausted. Essentially, it's like putting a straw in and sucking out the mitochondria. And if you look at these electron microscopy slides, it's pretty cool. You can actually see these mitochondria being pulled out. And this is a paper that just came out in Nature Nanotech. I highly recommend reading it if you do. It's just a cool concept. Scary, but cool. And then there was a paper that was published by Vanderbilt Bilst, and they actually showed that macrophages can actually act as a bus to shuttle mitochondria between two cells. So mitochondria are essentially currency for exhaustion. So what cells are causing the exhaustion? It turns out that in glioblastomas, we all know, and we've heard this discussion, that there's a predominance of myeloid cells and very few T cells. And if you look, just going back to the basics of immunology, it turns out that myeloid cells aren't always just macrophages and microglia, which everyone refers to, but there's actually neutrophils and monocytes. But I think most of us, when we're trying to talk about myeloid cells, is really talking about macrophages. And it's interesting, if you look at the different types of cancers, macrophages are the predominant immune cell population. And it's actually a negative prognostic indicator if you look at macrophage density. On this figure, you can see that the blue lines represent the lymphocytes. So the lymphocytes are actually the minority population. So it turns out that these myeloid cells are Jekyll and Hyde. They can actually promote tumor function through doing things such as proliferation and invasion and immunosuppression. But if they're programmed right, they can actually facilitate tumor killing. So this is where that M1, M2 nomenclature comes from. But this is Christina Jackson's work when she was a resident at Hopkins. We worked with Drew Pardole, and couldn't have done it without Drew Pardole and his support. This was a very expensive study, but we did single cell sequencing on about 22 GBMs. And what she is showing is that there are actually about 14 different myeloid subtypes, predominantly macrophages and microglia. And so it's not just M1 and M2, but it's a very complex set of interactions that we have to understand. And through this time point curve, it actually shows that these macrophages can actually change phenotypes over time. So when we're trying to target these myeloid cells, what are we trying to do? If you look up here in the top left, this is an M2 phenotype, basically the immunosuppressive phenotype. Dr. Campson mentioned things like CSF1R inhibitors. Hopefully you hit it and you convert them to that tumor facilitating or tumor killing phenotype. And then they start doing antigen presentation and they start going down to the lymph nodes to start killing to train the T cells to kill. It also turns out that the lymph node is a very important organ. This was Tomas Garza-Mubdi's work, showing that when you gave these myeloid activators, the PD-1 only worked after you gave the myeloid activators because, again, the antigen presentation is occurring in the lymph nodes, but it's those myeloid cells in the lymph nodes are actually still expressing PD-L1. So PD-1 actually gets you over the hump, but it's not getting you up the hill to kill cancer. So it's an important concept that to understand and appreciate that the lymph nodes are probably a very important area in causing T-cell exhaustion. And so John Choi, who was a resident here at Stanford, but a medicine with me at Hopkins, showed that when we basically gave PD-1 and delivered it locally to the lymph nodes, not to the brain, but to the lymph nodes, that you could actually get improved survival. And it's interesting, if you did the inguinal lymph nodes, you got even better survival. So again, we need to really understand that exhaustion is not just occurring in the tumor itself, but occurring outside. Now, there's some therapeutic strategies to address this. You've seen some of my work here with LAG3. We found that LAG3 is another checkpoint that's expressed on exhausted T cells. This was Sarah Harris Bookman's work and showed that the LAG3 positive T cells basically couldn't kill. But if you didn't have LAG3 and PD-1, these T cells could kill. We did preliminary translational work where we treated animals with anti-PD-1 and anti-LAG3, showed improved survival. And as a result, this is our preliminary data here. We then went to the ABTC, ran a trial, and actually got some really interesting responses. This is a patient who had a GBM, it recurred, started on therapy, had classic pseudoprogression and disappeared. And he's 40 months out. So we have 4 out of 16 patients that are well past 24 months. 3 of the 4 are actually past 36 months now. And we're trying to go to the Alliance to do a large phase 2. The last thing I just wanted to highlight was Michelle Manju's work. You may have seen it come out in Nature this week. But you know, when you can get T cells working and they're not exhausted, they can do some pretty amazing things. This was her work with Crystal Mackel, looking at CAR T cells directed against GD2. This was the preliminary data or preclinical data showing that this could work actually for patients with DIPG. Crystal Mackel made the CAR T cell here, and the trial was run here where patients got CAR T cell infusions and did it intrathecally. Here's an example of one of the patients who had a DIPG, and it actually regressed and the patient's facial weakness improved. This was another patient who had, again, the H3K27M mutant glioma that was in the spine. You can see the tumor regressing away. Another one, after several infusions, you can see that the effects were quite dramatic, and you can see that they melted away. Here's another example of a 16-year-old that just disappeared on. And in the paper, there's actually even, we even show that the functional recovery of these patients are really quite impressive. Had a girl who came in with contractures and was riding her little skateboard after. So I think once you can figure out how to get the T cells to kill, that we can get very dramatic results. So in conclusion, you know, immunotherapies have been disappointing thus far. There's high levels of adaptive and intrinsic resistance. Exhaustion is the major barrier, and the mechanism behind this exhaustion is really probably due to some disruption of metabolic pathways and the mitochondria itself. The myeloid cells are probably contributing to exhaustion, and the exhaustion is occurring not only at the tumor, but in the lymph node. And this exhaustion can be reversed. We just don't know how to figure out which cells can be reversed and which ones can't be. But when you do reverse them, the effects can be dramatic. I want to acknowledge that I worked with some really amazing postdocs and students over the years. I want to acknowledge my clinical team at Hopkins that I worked with over the years, of course, the Stanford team, and this is my relevant funding. Thank you.
That's an awesome talk. Thank you so much, Dr. Lim. Really enjoyed that. Corey, am I taking over to introduce Dr. Heath, or?
That would be lovely.
Okay. Well, Dr. Heath and I were just Zooming on another Zoom call a minute ago, and now I'd like to introduce him. We're going to reserve questions till the end because we're a little bit behind. So Jim Heath is president of the Institute for Systems Biology He went to college at Rice University and then did his postdoc work at Caltech. He's co-director of the Parker Institute for Cancer Immunotherapy until 2017. He came from Caltech to ISB, and he is the president of ISB now. And his talk is going to be about some exciting spatial profiling of GBM and melanoma.
Thanks, Charles. Okay, so as Charles indicated, we were just on a call with a company called Macrogenics and about I want to just give some of the background and rationale for that.
I'm not seeing your screen. Is everybody else seeing it? Or I can't hear you either.
No.
Corey, are you seeing his screen?
No, I just see Jim Heath has started screen sharing, but I don't see the actual screen, and I'm not hearing Jim. Jim, it looks like your microphone may be muted.
I don't know if you can you hear me now?
Yes, we can.
Okay. I was been zooming all morning and I went to share screen and I froze.
Oh.
So let's see if it works.
Okay.
Can you see my screen now?
Yes, we can. That's great.
Great.
Perfect.
Okay. We're supposed to be at a high-tech institute with bandwidth and everything, but we'll see what happens. Anyway, as Charles, thank you for inviting me here. As Charles indicated, we were just on the phone with the company Macrogenics about a combination targeted inhibitor immunotherapy trial for neoadjuvant GBM and at the stage of recurrence. And I want to give a little bit of background and rationale for that study. So this is a study that was done in collaboration with Tim Clousey and Rob Prinz, but also Jennifer Wargo, where the goal of the study really was to do a sort of microanalysis at multi-omic analysis of the GBM microenvironment in comparison to melanoma, to compare and contrast a immunologically hot tumor and one that is challenging to get hot under very similar therapy conditions. And so the melanoma stuff was in collaboration with Jennifer Wargo, and this is work done by Yue Liu and Alphonsus Ng in my group, and Joe Beecham from NanoString was very helpful in this analysis. Okay, so I don't think anyone needs to, here in this audience, needs to be refreshed on this, but this is just the unique character of GBM, and this is from work that Ilya Shmulevich from my colleague here at ISB published several years ago on the immune landscape of cancer, where most cancers tend to occupy multiple of these immune type phenotypes, but GBM is just sitting here in this lymphocyte depleted phenotype here. And so the goal of the earlier goals in trying to do immunotherapy in GBM, especially with checkpoints, was just to try to see if you could convert a cold tumor into a hot tumor. And work that Tim and Rob Prinz and their colleagues did, and this just compares the two studies that we'll talk about. They looked at on the order of 20 patients with recurrent GBM, and looked at there was a transcript signature that they could associate with turning a tumor from immunologically cold to at least lukewarm. And they found what they describe as a molecular non-responder and a molecular responder. So two differential transcriptome signatures, and they did see some survival benefit, but I think the real goal was to try to see if you couldn't heat up the tumor. And of course, in melanoma, that's an easier thing to do. And this is a very similar study that Jennifer Wargos directed. And here's basically the analogous one for the GBM, neoadjuvant anti-PD-1 and metastatic melanoma. So the way that we analyzed, we looked at just a whole bunch of tumors from both of these types of studies at different stages of treatment, and with both transcripts and proteins at a spatial resolved method level. And we used this nanostring a digital spatial profiling system that I think people are pretty familiar with. It's what it allows you to do, is to identify regions in the tumor based upon, say, multicolor fluorescence staining done side by side with an H&E type staining. And then to, within this sort of region of maybe this size or maybe just a little bit smaller, so this is not single cell, analyze for a panel of reasonable number of proteins. These are largely immuno-oncology proteins, or one can also capture the whole transcriptome. This is not, from the transcriptome point of view, it's not a whole genome sequencing approach. It's basically, you're looking at specific transcripts, but you can build almost as many probes as you want, but you can't see mutations. And just to show you sort of how this works and the sort of fidelity of the data, here we've taken in a series of, I think, probably one or two tumors, but we've looked at regions that are immunologically active. At least there's a lot of CD3 plus cells here, and quiet, and then looked at these basically immune signatures, CD11, CD4, CD8, etc. And just you see alternating between immunologically active and quiet, you can really tell the difference. And so this allows you to then think about the molecular signatures you're measuring these tumors within a spatial context, which I think is, the whole point of this type of microscopy. And so when you look at the whole transcriptome, and this is just a lot of data, but I think over here I want to direct you. You do see that, in fact, the molecular responders and non-responders in this sort of UMAP representation really do distinguish pretty well in a much larger analysis than what one captures with the with just a limited a transcriptome assay, such as what was used by Rob and Tim, but nevertheless gives you a consistent story. And this is unpublished, but we did do now the protein work, and that is published. That came out last year. And so here's one of these one of these melanoma tumors. And here you see a extremely robust immune compartment, very, very different from what you see in GBM. And then one can begin identifying markers that illustrate the differences between these compartments, and then distinguish those markers based upon patient response or non-response. And that's the kind of thing we did. And I'm not going to go through in great detail, other than to say that the markers that one sees for melanoma make complete sense. And when you look at melanoma, it turns out, for example, beta-2M, which is associated with antigen presentation, can really fully separate responders from non-responders in this type of analysis when you're looking in the immune-rich regions. So when you look in the GBM tumors, it's very different. In fact, there is not much that really distinguishes between responders and non-responders, except for that one does see elevated Ki-67, so cell proliferation. And I want to emphasize that because you actually will see elevated Ki-67 in both the immune-rich and the immune-poor regions, but it is statistically elevated for the molecular responders in the immune-rich regions, and is statistically elevated for the molecular non-responders in the immune-poor regions. And so the point is that it provides context for interpreting this type of cell proliferation that one sees, whether it's immune cell proliferation, good, or cancer cell proliferation, not good. And so we took that type of data and we tried to use it to predict what do we see in terms of CD8 T cell infusion into these tumors. And when you look for in the melanoma case and you look in the GBM case, one sees a level of consistency that makes you think that even though these are very different tumors, this type of analysis has given you at least a reasonable, I don't want to exactly say apples to apples, but a reasonable comparison across tumor classes. Okay, so back on this Ki-67, the Ki-67 associated with cancer cell proliferation predicts the non-molecular responders in GBM. It's the cleanest predictor of who's not going to respond. And when we then say, well, what is it that it most associates with the Ki-67? What we see is, and I think I'll just pop to here, is we see this marker here, B7H3. And B7H3 is at the transcriptome level, it's actually pretty broadly expressed in many cells in the body, but it doesn't get translated into protein almost anywhere except for in tumor cells. It's pretty highly elevated in about 60% of cancers. And so it seems like a pretty good cancer target here. And IDO1, which I think one might have expected to pop up as well, also pops up. And so there's been a little bit of recent work on showing that this is maybe not such a bad target as well. There's chimeric antigen receptor T cells directed against B7H3 in both the patients here, and this is against in neurospheres and model systems. And so this is the suggestion that we have. And if there's feedback out there for the suggestion, I'd love to hear it. I think this is a trial that we're in the process of planning, and hopefully we'll be able to execute this within a year or so. And that's my short talk. But I'll indicate that we're working now with Macrogenics. We just had this call with them to begin taking their antibody against B7H3 and coupling it with anti-PD-1. And with that, I will conclude, and thank you for your attention. Happy to answer any questions. I think I took time.
Great talk, and you bought us 10 more minutes, so thank you.
Yeah, I was hoping to get feedback, but if the conference is too short or too
I think it's a dumb question. Ki-67 increased in those regions is associated with proliferation of tumor cells, right? Or are you talking about proliferation of lymph T cells? It's tumor cells, right?
Yeah, so when you have a molecular responder, you see Ki-67 associated with the immune cell rich regions. When you have a molecular non-responder, you see Ki-67 in the immune cell poor regions, tumor cell rich. So the context in which you see it is everything.
Got it. Okay. I don't know if we have time for any other talks right now, but Corey, should I introduce? Thank you so much, Jim. That was great. And really follows nicely on Dr. Lim's talk, which was an excellent talk. Should I move right to Parvi? And she's pre-recorded her video.
Yes, she did, and that would be lovely.
So Parvi is the director of. She runs our lab basically. So she wears two hats, not only running the lab, but also is just a bona fide excellent scientist. She came here actually when Dr. Mayberg hired her in like 2005 to run a vascular lab to look at blood vessels. And all of a sudden she started getting interested in glioblastoma with Greg Foltz and growing glioblastoma stem cells. And then she and Dr. Foltz came up with this concept of why don't we do high throughput drug screening to identify potential targets for GBM stem cells, which are the most resistant to tumors and possibly the ones that grow back after radiation and chemotherapy. She received her BS in genetics and biochemistry at the University of Leicester, England. And I don't know if I pronounced that right, Leicester. And anyway, let's play her video.
Hello everyone, I'm Parvinder Hoti. I am a research scientist and the lab supervisor at the Ivy Center at Swedish Neuroscience Institute. I will be talking about research ongoing at the Ivy Center, which is focused on targeting cancer stem cells for the treatment of glioblastoma. So cancer stem cells are believed to be a subpopulation of tumor-initiating cells that reside within tumors. They are responsible for tumor growth, resistance to therapy, and tumor recurrence. Hallmark characteristics of these cancer stem cells include the ability to self-renew, proliferate, and initiate tumors. Other common characteristics include stem cell marker expression and the ability to differentiate into the main CNS cell types, namely neurons, astrocytes, and oligodendrocytes. A glioblastoma patient undergoes tumor resection, radiation, and chemotherapy with temozolomide as standard of care. This is effective in reducing the bulk of the tumor. However, these cancer stem cells persist because they are resistant to standard therapy, and they go on and they generate a secondary tumor and cause disease progression. What is the greatest challenge with treating these glioblastoma tumors? Each GBM tumor is different, and it's also believed that the subpopulation of cancer stem cells that reside within these tumors are also heterogeneous. So the big question is how best to treat these tumors, and how do we identify the best drug or combination of drugs for an individual patient? One model that we've adopted at the Ivy Center to study these cancer stem cells is to develop patient-derived stem cell lines. Once patients undergo resection, their tumor is brought up to the lab where we process this to release the tumor cells. We grow these cells in serum-free media with growth factors to preserve the stem-like phenotype. There are two culture conditions that can be used to grow these cells. They can be grown as adherent monolayers on laminin-coated flasks, or they can be grown in suspension as neurospheres. These cells can readily be frozen down and cryopreserved in liquid nitrogen, and they remain viable for several years. At the Ivy Center, using this methodology, we have generated over 300 of these patient-derived stem cell lines to date. We've verified that these cultures that we're generating preserve stem-like phenotype by ensuring that they are able to self-renew, they express neural stem cell markers, and they have the ability to differentiate. And the gold standard being that they can also, when injected in mice, go on to form tumors. We've used these cancer stem cells to perform high-throughput drug screening. What's involved with this methodology is that the cancer stem cells are added to 384 well plates. A different drug is then added to multiple wells at different concentrations. These cells and drugs are co-incubated. At the end of the assay, we lyse the cells and we measure the luminescence to determine how many viable cells remain after exposure to a given drug. The advantage of this HTS platform is the ability to screen a very large number of drugs in a clinically relevant time frame. We have the ability to screen up to 50,000 compounds in a couple of weeks. This is an example of the data that's generated when we do these HTS assays. These are known as dose response curves, which are essentially tumor cell viability against increasing drug concentration. The data is fit to a sigmoidal function to determine a parameter known as half maximum inhibitory concentration, or IC50, which is essentially a measure of potency of a drug. The lower the IC50, the more potent the drug. So at the Ivy Center, we've taken our cancer stem cell lines and our HTS methodology, and we used it to launch a clinical trial, a phase 01 study of combination drug therapy for glioblastoma. The primary objective of this study was to determine the feasibility and the safety of the HTS approach. In the phase 0 part of this study, patients are consented for the collection of their tissue and the generation of a cancer stem cell line. We then assay these cells against a panel of 76 FDA-approved drugs. Once the combination drug therapy has been approved by DSMB and IRB, we wait until patients are eligible for treatment, which is when they show signs of disease progression. Once progression is observed, they are then eligible to enroll in phase 1 of the study, which is the treatment phase. The overall goal of this study was to treat 10 patients under phase 1. The flow diagram here outlines the steps that are involved. So in phase 0, patients with newly diagnosed glioblastoma are consented. They undergo surgery. We isolate the cancer stem cells from their tissue specimen. We perform the HTS assays using the 76 drug panel. Dose response analysis is performed. The study team reviews the candidates and selects 3 suitable drug candidates for each patient. The drug candidates then undergo a drug-drug interaction review by a team of pharmacists to ensure there are no overlapping toxicities. Following pharmacy review, these drug candidates are then reviewed by a data safety monitoring board and IRB to approve the treatment plan for each patient. Once a patient shows signs of disease progression, they are then consented and enrolled in phase 1, and they are eligible to start their investigational 3-drug combination therapy. The panel of drugs that we use for the HTS assays contain a variety of drug classes and mechanisms of action. There are several common chemotherapy agents used for cancer therapy, but there are also several drugs that are not typically used in cancer therapy, such as antivirals, anti-inflammatories, and antipsychotic agents. This is an example of the data generated during the current ongoing clinical study. Dose response curves for 4 GBM patients. You'll see in panel A, there is a varied response in IC50 for 4 of these patients against a given drug. A more dramatic response can be seen in panel B, for which we do see for some drugs and some cancer stem cell lines where there are clear responders and non-responders. So in panel B, you can see there are 3 patient-derived cancer stem cell lines that essentially did not respond to this given drug, but then there is one that is clearly sensitive and a responder to a given drug. So in addition to ranking these drugs in terms of their IC50 and potency, we do look at other parameters when selecting which drug candidates to treat individual patients with, namely the ability of the drug candidates to cross the blood-brain barrier. We do this by evaluating the polar surface area of the drug candidates. The consensus is that drugs that have a polar surface area of less than 90 angstroms are most likely to readily penetrate the blood-brain barrier. We also take the brain to plasma concentration ratio into consideration when selecting the drug combination therapy. For example, if we look at temozolomide, it has a polar surface area of approximately 80 angstroms and does readily cross the blood-brain barrier. This is a summary of the 9 patients that have been treated to date under phase 1 of the study. Each patient received an individualized 3-drug cocktail. And as summarized in the table, no serious adverse events occurred, and no unexpected adverse events occurred throughout the study for all 9 patients treated to date. Of these 9 patients, 2 are still alive. Of the 7 that were treated under the study and for whom we have survival data, the average overall survival for those 7 patients is 22 months. So next steps for the current ongoing study, which is treating recurrent GBM patients, we hope to treat the final remaining patient and publish this data set very soon. Although the study involves treating 10 patients in phase 1, a lot of data was generated in the phase 0 of the study. We actually collected cancer stem cells and performed HTS assays on a total of 45 patients. So we have a large data set of drug sensitivity profiles. We are using this data set to understand the sensitivity trends that we see and identify drugs that synergize well together. We're doing this in collaboration with the Institute for Systems Biology. We have an R01 to study this work further. It will be a systems approach to uncover the gene networks that are responsible for driving drug resistance in glioblastoma. So one of the biggest limitations of the current study that's treating recurrent GBM patients is that we are isolating cancer stem cells from the primary tumor, but then we have to wait until patients have disease progression before they can receive their drug therapy, at which point we don't know how relevant those drug sensitivity profiles are and how the cancer stem cell population may have changed. So this, combined with the safety data we've observed in our current study, led us to develop a new protocol for newly diagnosed glioblastoma. This protocol is close to being submitted to the FDA. It will involve the same cancer stem cell HTS approach. We will isolate cancer stem cells. We will perform the HTS assay against a panel of FDA-approved drugs. It will undergo the same safety review by pharmacy, DSMB, and IRB. Once approved, patients are eligible to receive this treatment alongside standard of care at the time of radiation and chemotherapy with TMZ. So the biggest advantage of this new study is, of course, that the patients do not have to wait for tumor progression to receive their personalized drug therapy. We know the methodology and analysis pipeline is well established, as well as our ongoing collaboration with ISB will generate complementary genomic data for this work. We have promising safety data from the first HTS study and potential signs of efficacy in some patients. We've been able to further refine our GBM drug panel to use the drugs that were most potent from the first study, but also include new agents for testing. Of course, the greatest advantage of the new study is that patients do not have to wait for reoccurrence to be eligible for their individualized treatment. The other exciting opportunity we see for this new study is the ability to generate primary recurrent matched cancer stem cell pairs. So the new protocol allows us to collect tissue and create cancer stem cells from the primary tumor and the recurrent tumor should a patient undergo a second resection. So the dose response curves shown here are examples of some preliminary data that I was able to collect from one patient for which we were able to establish a matched cancer stem cell pair. What's shown here is that the cancer stem cells derived from the primary tumor, shown in red, are much more sensitive than the matched recurrent derived cancer stem cells. So again, this reinforces the need to be giving patients their personalized drug therapy close to tumor resection and not waiting until disease progression. I'd like to end by thanking all the team members at the Ivy Center for the great work that they do and their support of the HTS study. And thank you all for listening.
Well, I would like to tell Parvi that was an awesome talk, even though she's not here. So, Matt, I believe you're introducing our next speaker.
Yes, I'd like to introduce my close colleague, Dr. Carissa Schreck. She had undergone her medical training and PhD at Johns Hopkins University, followed by a residency in neurology at Johns Hopkins, and subsequently completed the Joint Fellowship in Neuro-Oncology at Hopkins and the National Institutes of Health. She is an assistant professor of neurology, oncology, and neurosurgery, and is co-director of the BRAF Brain Tumor Center at Johns Hopkins. She has specific expertise in the treatment of BRAF gene mutations in primary brain tumors. She also works in Dr. Pristine Patella's laboratory investigating resistance mechanisms to BRAF target therapy. And she is very active in developing novel trials and writing them through the Adult Brain Tumor Consortium, as well as Alliance Oncology Group. Welcome, Carissa.
Okay, I see her online. Just hopefully she'll pop on here.
She is coming up. She was finishing up some clinic. What we might do is, it might be, she's going to be a couple minutes, so maybe we should move on to the next presenter as a suggestion, just keep on track with time. Yeah, I think that'd be good.
Okay, so let me figure out how to share screen, and then hold on a second.
Yes.
Oh, Dr. Schreck is here.
Oh, okay.
I apologize, you guys. I ran down to clinic and thought we were running a tad bit further behind than we actually are. So good job catching up in the last 30 minutes or so. Let me just go ahead and share my screen, and then we'll start. All right. So I'm going to focus primarily on incorporation of BRAF targeted therapy into neuro-oncology clinical practice. So this will be a pretty practically based talk, focusing on how to use these treatments for our patients. And so my three main objectives are to recognize which alterations we should be targeting, to identify which drugs we should be using for which alteration, and to think about how we should be treating toxicities in our patients. And so I think by this point, most of us have seen or at least heard about a patient like this. This is a patient I saw during fellowship who's 34, had multiple lines of therapy and recurred on all of them. And then he started on dabrafenib and trametinib, and you can see here his enhancing and his flared disease really melted away over the course of 14 months. And so he did remarkably well on dabrafenib and trametinib for quite a long time. And this is exciting. We don't have a lot of great options for recurrent high-grade glioma that has progressed on multiple lines of therapy. And so BRAF alterations do occur commonly in a subset of glioma. We know that the V600 mutation, the one that we think of most commonly as being targetable, is common in PXA and in ganglioglioma, but it also occurs in a subset, small but consistent, of pediatric and adult astrocytoma. One of the other BRAF alterations you'll hear me talking about today a little later is the fusions. And these are also very common in pilocytic astrocytoma. And if you put the numbers together, you can see that almost all pilocytic astrocytomas have some alteration in BRAF. And so I'm going to take one little pause. This is one of the only signaling pathways I'll show you this talk, but it's really important to understand how mutant BRAF works. And we understand that by understanding how physiologic RAS and RAF signaling work. And so what happens in a normal cell is that ligand binds to a receptor tyrosine kinase. That receptor tyrosine kinase, through multiple scaffold proteins, activates RAS from its inactive GDP bound form to GTP bound form. That then recruits RAF to the surface where it dimerizes. You can have homo or heterodimers of BRAF, ARAF, and CRAF. And these then activate MEK and ERK and intracellular signaling, leading to cell proliferation and all sorts of things, okay? Now, there are many different mutations that can happen in BRAF. The one we think of most commonly, V600E, is an activating monomeric mutations. That means if you take mutant BRAF and drop it into a cell, it by itself is sufficient as an oncogene to activate ERK signaling. There are many other BRAF alterations that don't act quite the same way, but can also be oncogenic. And we divide these into two groups, class 2 and class 3. And both of them occur in glioma. So class 2 don't need RAS, right? So BRAF by itself is where the activation starts, but they do need to dimerize. So they're not able to be active all by themselves. There need to be two around. So they don't need active RAS, but they do need to dimerize. And this is a list of some of the class 2 BRAF alterations one might expect to find. Particularly of note for glioma is this bottom one here, fusions of the BRAF kinase domain. So these are those BRAF fusions that we think about in pilocytic astrocytomas. The other class is class 3, and these are BRAF alterations that are dependent on dimerization, yes, but they need activation of upstream RAS. And so this could be through a RAS mutation, not very common in glioma, or through loss of NF1, as we heard earlier from Dr. Romo's talk, very common in a certain subset of patients with neurofibromatosis, but also very common in glioblastoma in general, right? Often see loss of NF1. You can also see activation or mutation of receptor tyrosine kinases. And so these BRAF mutants cause the BRAF and either BRAF or CRAF molecules to stay bound together longer so that activation can continue downstream. Okay, and I realize there's a lot of molecular biology here, but it becomes relevant in just a minute. The one aside I will say is that not all of the BRAF mutations that we find are going to be pathogenic. And so here you see a lollipop plot where each little lollipop is one or more mutations that we have identified in a glioma. And you can see that V600E is common in that group. You can also see these yellow and green mutations. These are class 2 and class 3, sort of clustered in regions that make sense in the kinase domain. But then you see all of these mutations found in the linkage domain or the N-terminal domain that are not pathogenic. And this is really important to think about. So targeting those mutations is unlikely to produce any beneficial effect for the patient because these mutations are not activating RAF signaling in those cells. And so if we look at about 300 adults with BRAF mutations, what mutations do we see? A lot of them are BRAF V600E mutations. We also see class 2, class 3, and fusions in adults, as well as gains and other mutations of unclear significance. I will point out that some of the fusions we identified actually were in glioblastoma or high-grade astrocytoma, not just in pilocytics. So it's important to look, it's important to ask the question if we're going to be able to have a therapeutic option for these patients. Okay, and so what treatments are we going to think about? So I talked briefly. For wild-type BRAF to be active, you need BRAF to dimerize with another BRAF molecule or a CRAF molecule or an ARAF molecule, and that activates downstream signaling. BRAF V600E is sufficient by itself to activate downstream signaling. And so there are an array of drugs that are FDA approved for BRAF V600E, right? These are the monomer selective RAF inhibitors, VEM, dabrafenib, and encorafenib, and paired MEK inhibitors. These will be effective against mutant BRAF only. When you think about class 2 or 3 mutations, fusions, or wild type BRAF, you cannot think about these drugs. In general, we think about these drugs as making it more likely for wild type BRAF to find a partner and bind. So they can paradoxically increase ERK signaling in cells that don't have a V600E mutation. And so for patients with these mutations, one might consider a dimer disruptor, something that interrupts this pairing, a pan-RAF inhibitor, something that's going to be effective against any of these RAF molecules, or a MEK inhibitor, either alone or in combination, as Dr. Romo referred to earlier. And so how do we pick the right drug? Which drugs should we be using? How well do they work in these patients? So there was a study that was done of vemurafenib monotherapy. It was sort of the first one. A basket study included about 24 patients with BRAF V600E mutations. And you can see here the response rate for PXA was highest at 43%. For glioma was malignant glioma was lowest at 9%. But what I'll show you on this swimmer's plot, which I think is really nicely illustrated, even though these tumors didn't shrink, patients lived longer than they should have with a recurrent high-grade glioma. So this was exciting. And these data have been further substantiated with the ROAR trial. This is Novartis's drugs, dabrafenib and trametinib in high-grade and in low-grade glioma. And we can see that even in GBM, the response rate, like tumors shrinking, is 31%. These patients had a heterogeneous treatment history. Most of them had gotten radiation and sort of standard first-line therapy, but not all. But still, in the recurrent high-grade glioma setting, a 31% response rate for GBM is pretty exciting. And again, all of these patients had BRAF V600E mutations. In low-grade glioma, the cohort is smaller, 13 patients, but the clinical benefit and response rate were large. And again, clinical benefit, that's the patient population who maybe didn't have their tumor shrink, but didn't have any progression for a whole lot longer than they should have given the situation. This has been true in pediatric glioma as well. There are a bevy of studies that have been published or presented looking at vemurafenib or dabrafenib alone, or the combination, or even selumetinib alone in recurrent low-grade glioma. And in all of these, we see response rates of about 1/3 and stable disease or clinical benefit. In the vast majority, you're seeing numbers of 85 to 100% in these pediatric gliomas. And you can see all of these studies really were sort of under age 21, really what we think about as the pediatric population. And so what's the recommendation right now? Well, the NCCN actually has guidelines for this. And what they've said is that if you have a patient with a new low-grade glioma and you would be considering a treatment for them, think about a BRAF targeted therapy. The two combinations that they have listed, dabrafenib and trametinib, vemurafenib, cobimetinib, or if it's a pilocytic astrocytoma, remember most of those are driven by the fusion, think about selumetinib, MEK inhibitor monotherapy. For other low-grade glioma and high-grade glioma that are recurrent, if they have this V600 mutation, think about targeted therapy at recurrence. Now, the expert opinion commentary I'll add to that is we really don't have a lot of data in glioma to support vemurafenib and cobimetinib. I don't ever choose this combination if I can help it. The brain metastasis data were quite a bit weaker for that combination in melanoma. And so I would choose dabrafenib and trametinib or encorafenib and binimetinib over vemurafenib and cobimetinib if I had the option. Additionally, some of the combinations have a different toxicity profile. So you might consider encorafenib and binimetinib for intolerable toxicity. What if your patient falls outside of this sort of strict definition here? You're looking for other options, clinical trials. There are a lot of them right now. I'm not going to go into all of them. I'm happy to share these slides with anyone who would like it as a reference. But I think the thing to point out here is studies are looking at a lot of different combinations. Almost all of these studies are in pediatric glioma, but you can see our pediatric neuro-oncology colleagues are expanding their definition for good reason in these tumor types and going up to even age 30. And I know during during Dr. Romo's talk, the question came up, well, what about some of these other mutations? What about pairing it with other therapies? So you can see there's one interesting trial going on right now looking at giving radiation 6 weeks, followed by dabrafenib and trametinib immediately after in young adults and children with high-grade glioma. And then you can see that there is another here that is comparing selumetinib against standard chemotherapy in children with untreated or recurrent low-grade glioma. So people are starting to look at the efficacy in combination or compared to standard of care chemotherapy. You can also look that we have some exciting new drugs, such as this pan-RAF inhibitor, Day 101, in low-grade glioma. What if your patient doesn't have a V600 mutation? You can see some of these trials here will include any low-grade glioma in NF1 or an activating BRAF alteration. I would also say the things that you should consider in patients with other BRAF mutations, if they're class 2, class 3, or fusions, MEK inhibitor monotherapy, one of these novel BRAF inhibitors like the Day 101 drug or other dimer disruptors, a pan-RAF inhibitor, or a SHP2 inhibitor. There are a lot of trials going on now. That's one of the scaffold proteins that goes up between the receptor tyrosine kinase and RAS. And so there are several trials that are open right now. Some of them don't include active CNS disease. This one here is trametinib hydroxychloroquine for low-grade glioma only, and some other combinations looking at new RAF inhibitors or SHP inhibitors with MEK inhibitors that are promising for patients with these activating BRAF mutations that aren't V600E. And so the last thing I really wanted to make sure I focused on today in talking about these drugs in this class is toxicity, recognition, and management. And so here I've given you a pictorial guide of the things to remember and think about when you start a patient on these drugs, when you're talking about them. So with MEK inhibitors, there's this classic rash. We worry about cardiomyopathy. With combinations, we think about serous retinopathy or retinal vein occlusions. We can think about secondary skin malignancies, squamous and basal cell carcinoma. And then fatigue can be a big one, and fevers, particularly with RAF inhibitors, as well as some toxicities to muscles and to the liver that we might find through blood testing. And so this is not a trivial concern. So more than 90% of patients have toxicity on these drugs, and 50 to 70% have grade 3 or 4 toxicity. So this is serious. It's not that your patients are going to start them and be 100% fine. Although I would say my experience has been that young adults tend to tolerate them better than older adults. Despite the high rate of toxicity, only about 10% of patients have to stop drugs for toxicity. And I think this is for a couple of reasons. Patients don't often have a lot of other options when they got to this phase as part of the early melanoma clinical trials, at least. And these data are from melanoma, the toxicity data. I think what we see in glioma is similar. But I think what this does say is that anticipatory guidance, prophylaxis are critical. I will also say most toxicity occurs soon after initiation, particularly those first few weeks. So again, anticipatory guidance, prescribing some prophylactics along with the targeted therapy, and having close and available contact in the clinic are absolutely critical to ensure patients can start them effectively and stay on them as long as they are of benefit. And so some of the tips in thinking about using these drugs, you can start at a reduced dose, a -1 dose level, and up titrate over a week or two to see how the patient does, give them a chance to adapt. Use dose interruptions, use dose reductions. There, I think, is a lot of flexibility in dosing, and you can often re-escalate once patient symptoms are under control and you've figured out how to make it tolerable. And then also, I would consider switching within a class for severe toxicity. And so, as I mentioned, there are a lot of toxicities. This is not here for you to remember them all, but I did want to just point out some of the most common toxicities with each of these combinations. And so you can see there's a lot of phototoxicity and then more GI stuff with this Vem-Cobi combination. Fever is a particularly common toxicity of dabrafenib and trametinib, and probably the most common reason I switch off of this combination to something else. And then I would say with encorafenib and binimetinib, particularly as compared to dabrafenib and trametinib, there's a lot of CPK elevations. That might be a reason to switch back to dabrafenib and trametinib. And then for peripheral edema or decreased EF, you might think about encorafenib and binimetinib. So just things to keep in mind as you're trying to help patients through the toxicity period. Okay, and so I realize this is a bit of a whirlwind tour. A couple of take-home points I want to leave you with today. So RAF, MEK, or combination therapy can be very effective. I think it's exciting for those of us who have been in neuro-oncology and have seen many treatments that aren't effective. However, it really depends on the mutation. And so molecular tumor board, the NGS report, or a curbside is absolutely critical in selecting the right treatment. I would definitely just make myself available if anybody ever wanted to reach out about sort of an unusual BRAF mutation and trying to think about whether and which targeted therapy might be effective. I'm more than happy to field curbsides like that. And then lastly, but very importantly for our patients, toxicity is really common, but can be totally ameliorated, and the patient can be supported through that process with appropriate guidance from their neuro-oncologist. And so I am going to pause there and take any questions if we have time for that. Again, I apologize for being a little bit late today.
Thank you, Dr. Schreck. Zach Litvak from Swedish here. Great talk. We have time for one or two questions, and there is one in the chat. There's a question from Mohammed Janjua, and his question is for adult gliomas that have a documented BRAF mutation. Would you consider RAF, MEK, or combo therapy up front to be standard of care, or is this still a secondary therapy after initial protocols fail?
I wouldn't consider it to be standard of care yet. I have this discussion with my patients, and I think it really comes down to a question of timing and toxicity. I think the jury's still out a little bit on whether the natural history of a BRAF mutant GBM is the same or different from one that isn't. And so, you know, anecdotally in clinic, I have, you know, people who have all the classic markers of having an awful GBM and have lived several years longer than they should have with a BRAF mutation. And so would I want to start those people on a BRAF inhibitor? They're going to have to field the toxicities up for several years. Will it improve their survival? Will it improve their quality of life? I'm not sure. So I think it's worth talking about. I think it's an important question to answer, and one that we may have some hints at from the pediatric literature in a few years, but not one that I start across the board in patients.
Great, thank you for clarifying. All right. And I don't see any other questions in the chat right now. So we're going to keep moving, but if you have other questions for Dr. Schreck, please feel free to chat them in. And we're going to move on to Dr. Cobb's talk next. So Dr. Cobb's, you all know from earlier, but he's our director within the IV Brain Tumor Center for Surgical Neuro-Oncology. He joined Swedish back in 2013. After a career in the Bay Area, training and practicing in and around UCSF at what many consider to be the heyday of surgical neuro-oncology at UCSF, with the transition from Charlie Wilson to Mitch Berger, and at the same time having people like Mike McDermott at the facility. So really thrilled to hear Dr. Cobb's talk today. We'll switch those slides over for everybody and get started on understanding some options for what we do here at the IV Tumor Center in terms of translational research. Charles, thanks for being here today.
Great, thank you so much. Let me share my screen and then tell me if this is going in the right direction. Okay, it should be the that should be the first slide. Okay, is that working?
Yeah, we can see and hear you just fine. Your slides are looking good.
So it's getting close to lunch and everybody's a little fried. So I'm just gonna try to do a 30,000-foot view of what we are trying to accomplish at the IV Center. The IV Center is a translational research laboratory here and clinical facility where we try to do work that directly can be applied to patients. So a lot of our work is not as basic and more translational oriented. But just as a reminder, the overall advances in GBM therapies have been very poor compared especially to something like lung cancer, as you can see in this slide. And when I try to conceptualize what the main problems are for GBM moving forward, we're dealing with something that's a very heterogeneous tumor genetically and cellular wise. GBMs don't have as many characteristics mutations. Dr. Schreck mentioned in low-grade gliomas, there are certain mutations that you can focus on, but it's not quite as often in GBMs that you'll find these driver mutations that can be drugged. And then we have one drug, basically one drug that works in about 2/3 of our patients, or actually probably about 1/3 of the patients with GBM that are methylated for MGMT. So we really have a one drug challenge that we need to overcome. And then the biggest problem, I think, with the change in the environment of all of cancer therapy related to immunotherapy is we're dealing with a tumor that has a low immunological sort of a tumor suppressor microenvironment, as Dr. Heath and Dr. Lim have outlined. This is just a slide to show that the targeted therapies so far have been disappointing, and obviously the BRAF focus, which we just heard about, is great if that's present, but in GBM, as we know, only a small percentage of tumors can be targeted with driving mutations. And this slide outlines sort of the thinking that indicates why why GBMs have not responded to checkpoint inhibitors, because if you look at the mutation burden, for instance, of melanoma and lung cancer on this scale that shows they have 10-fold as many mutations basically as GBM. And so just by increasing T cell function by checkpoint inhibitors, you can get an anti-tumor response in them, which you don't typically see in GBM. So in GBM, what we're dealing with, this is just a slide to show that in those tumors like melanoma and lung cancer, you get so many mutations that you'll get altered proteins expressed that are sort of tumor neoantigens. And when these are presented to T cells in the presence of a checkpoint inhibitor, you can have an overall tumor response without any specific tumor antigen per se. However, in GBM, as we know, that the tumors are cold, as Dr. Heath mentioned, as Jim Heath mentioned, and they're covered with monocyte-derived, amyloid-derived suppressor cells, both macrophages and other types of mononuclear cells and polymorphonuclear cells, so that even in the presence of checkpoint inhibitors to PD-1 and CTLA-4, these tumors do not respond to the immunotherapy quite as well. And so from this sort of generalized perspective, I think the goal is to figure out, are there any ways we can enhance or identify targets on these tumors that we can train the immune system to attack? A, and B, can we increase the heat of the tumors? And it's going to be touching on what Dr. Heath was mentioning, to make them a hotter, more immuno-visible tumor. So the first thing I'm going to mention is just in terms of these obstacles that I mentioned, we are trying to go after all of them in the IV center in different ways. The genetic heterogeneity and low response to one drug, Dr. Parvi Hoti mentioned in her talk, and I'm going to briefly mention that. The problem is there are very few specific tumor-associated antigens in GBM. I'm going to discuss, and then at the end, I'm going to talk about what we're doing to try to overcome this immunosuppressed microenvironment that makes them cold tumors. So first of all, I'm not going to belabor this because this was Dr. Hoti's talk, but instead of trying to alter or improve the effects of temozolomide, my predecessor, Greg Foltz, and Dr. Hoti decided, let's take a shotgun approach, narrow down high throughput screens to 76 FDA approved drugs that have the ability to cross the blood-brain barrier, screen individual patients' own cancer stem cells, and come up with a top 10 of those patients and then pick 3 of those drugs that can be given in combination. And as mentioned, we've completed 9 out of 10 of these patient treatments for the phase 1 study with no significant adverse effects. And we're planning to move to a phase 1 study in upfront GBM, which may have a dramatically more greater impact given the fact that just radiation and temozolomide may alter a tumor cell's response to any given drug. And what's probably the most exciting for me is we're now working, as she mentioned, with the Institute for Systems Biology to do sort of rational understanding of categories of GBMs that may respond to a certain drug. For instance, there's a certain statin that some of them seem to respond to, and when you give this statin to these GBMs that are responsive, they all sort of go in a different direction. And we're trying to figure out if we can figure out the signaling pathways that you could target to block that sort of ability of the tumors to escape the statin drug, so that eventually we can come up with rational drug design based on screening of tumor cells and come up with a rational cocktail. Because I believe no matter what we do, the treatment of GBM is going to take multi-drug or multi-therapy approach. So the second thing we're working on is tumor antigens, or what can we train the immune system to attack? Years ago, my group, when I was at University of Alabama, hypothesized that there may be a viral association, and this has led to years and years of basic controversy about whether or not cytomegalovirus antigens are present in glioblastoma. We were pretty convinced that CMV was present. We had evidence of PCR and sequencing from GBMs, and multiple monoclonal antibodies to CMV seem to be present in GBM, and a high percentage of them. Other labs like this group in Norway also found that they could identify these similar CMV antigens and GBMs, and also that the T cells in those GBMs that were CMV specific were exhausted T cells and non-functional, and they had high levels of checkpoint inhibitors associated with them. So despite this fact, early on, my colleagues at Duke and I got together, and they decided to do clinical trials to vaccinate with dendritic cells GBM patients with one of the predominant antigens that the immune system sees for CMV, which is PP65. And really, in a dramatic series of now 3 phase 1 studies, they have shown in probably a total of about 30 patients that the median survival of those patients that got the dendritic cell vaccine to the CMV PP65 antigen has been somewhere in the area of 30 months or greater. And there are some of these patients that have lived out beyond 10 years in some of these studies with really dramatic results. And they published the last study in Clinical Cancer Research with the title Long-Term Survival in GBM with CMV PP65 vaccination. I will be the first to confess my lab still has difficulty understanding what's going on, whether this is actually bona fide CMV or maybe some type of similar virus with similar antigens, or could it be off-target effects? So we're currently doing experiments, and I won't go into the details, to try to isolate and perform mass spec and protein sequencing on these antigens that we see not only in glioblastoma, but in multiple other tumor types that appear to be CMV antigens. And then there's this other concept that was first told to me by one of my colleagues who has been doing adoptive T-cell immunotherapy for glioblastoma using CMV-specific T-cells in Australia. And he said he thinks there are off-target effects that CMV, T-cells targeting CMV may have really off-target anti-tumor effects. And this is a paper that came out in the last year, which shows that the peptide for this antigen that the Duke group is vaccinating with is almost identical to one of the melanoma tumor-associated antigens. And when patients with melanoma have a CMV infection, they have improved survival, suggesting that the immune response to CMV may not only have a CMV specific effect, but have an anti-tumor effect. So we're kind of trying to entertain all possibilities of what's going on here. And we're trying to isolate these proteins and figure out exactly what they are, because it seems like, despite our confusion, that something may be going on clinically in the clinical trial setting. Another very exciting project that Dr. Karimi in my lab initiated is associated with the concept of alternative splicing. So we all know that DNA encodes for RNA with introns and exons, and that processed RNA involves putting together exons. So for instance, this RNA will encode for this protein with A, B, and D, whereas if you have an alternative splice event where this exon is added in, then this protein will actually have an additional bit of protein, which, if it's tumor specific, could be a tumor specific antigen. So we hypothesized that this may be going on in glioblastoma, and we looked back through multiple RNA-seq databases, and we found 103 genes that were associated with alternative splicing and associated with disease progression in GBM. 58 of those were, and we selected 21 of those to look at with Western blotting to see if they were altered. And just to cut to the chase, we found that in many cases we had, sorry, I have to move something around on my screen. We had, we could see that in normal compared to tumor, there were alternative splicing events that made the protein have different size. And in this case, in 5 out of the 6 GBMs that we compared to normals, there were these upper bands that were not seen in GBM, sort of confirming that there may be tumor-associated spliced proteins that were not seen in the normal tissues. The next thing we did was, to go into our own archives, where I've often taken normal tumor and adjacent GBM. If I have to go to a deep GBM, I will take out the tumor, the normal tissue overlying the tumor. And we've done, in collaboration with the Institute for Systems Biology and now with folks at Ohio State, we've done huge mass spectrometry studies where by taking 3 pairs of matched tumor and normal, we have looked at about 500,000 peptides covering about 6,000 proteins. And of these, we found about 400 that seem to be alternatively spliced consistently in the GBMs compared to the normals of the 3 different patients. And a brilliant student in our lab, George Sun, has developed a software pipeline that allows us to compare the tumor, which are shown here in red, and the matching blue being the normal, for all of these peptides, and an algorithm that can identify highly expressed peptides that are seen only in the tumor but not in the adjacent normal. And we're expanding this to more cases now. But to cut to the chase, we see that some proteins which are spliced alternatively, or maybe not even spliced alternatively, are only expressed in the tumor but not the normal, like HMOX1. And then this protein, for instance, MSI2, we see it in tumor but not the normal, tumor not in the normal, these peptides here. And when we go back and compare tumor and normal Western blots, we see that the tumor typically has an altered version of the protein not seen in normal. And so what we hope to do is expand these studies to find more and more targets. And then the real goal will be to find targets that are expressed on the cell surface that may be amenable to approaching with antibodies or CAR T therapy. And as you probably know, the concept of a CAR T therapy is to take, for instance, a T cell receptor that is specific for one of these. Let's say we identify 20 novel epitopes that are tumor associated. We can make T cell receptors that are specific to those peptides. We can put them into, we can genetically express them into a T cell receptor, into a CAR T, so that that CAR T cell will be trained and specific to that specific peptide expressed on the tumor cell. And hopefully, if it's not expressed on other cells in the body or in the normal brain, then we will have a bunch of tumor-associated antigen CAR T cells that we can work with for patients, so that you could potentially take out a tumor, do mass spec, find which protein or epitopes they have, and then come up with a cocktail of CAR T cells specific to that patient's tumor. That's far-fetched, but we're working on a grant right now with a group that's a CAR T expert to try to come up with a strategy to do this. So the last thing I'll mention, which Dr. Heath talked about already, was that we know glioblastomas are cold tumors, and the studies he did that were published recently that he described, by looking at areas of GBMs where you see infiltrating T cells in the presence of PD-1 inhibition versus no infiltrating T cells, and look at specific proteins that are expressed in those areas, he was able to identify proteins that are associated with a poor T cell infiltration, most notably B7H3. And as he mentioned, B7H3 is an antigen normally not expressed on cells, but in tumors, it's often expressed on the cell surface, and it's immunosuppressive, and it promotes tumor proliferation, invasion, migration. And so, as he mentioned, our goal is to take this basic science information and work with a company that we were speaking to this morning, Macrogenics, who has inhibitory antibody to this B7H3, and maybe move that forward in collaboration with ISB and the group at UCLA to try to see what happens if we block the B7H3 antigen in the setting of a PD-1 checkpoint inhibitor, to see if we can increase the ability of T cells to infiltrate and kill tumor cells. So a lot of things we covered, but basically we're trying to go in a multi-pronged approach to overcome some of these major thematic obstacles that we see in glioblastoma, and it kind of summarizes what the group here is doing at the Ivy Lab. Thank you very much.
Awesome. Thanks for that overview, Charles. Just checking to see if we have any questions in the chat. We don't have any questions, so I think maybe we'll use the opportunity to make up a little bit of time. And I believe that Dr. Smith-Cohn is going to be introducing our next speaker.
Yes. So I have the pleasure of introducing Dr. Joe Mendez. He is an assistant professor in the Department of Neurosurgery at University of Utah and is an investigator at the Huntsman Cancer Institute. He received his bachelor's degrees in environmental engineering and science from Rice University, followed by his medical degree at UCSF. He then completed his neurology residency at WashU in St. Louis and completed his neuro-oncology fellowship at Memorial Sloan Kettering Hospital in New York City. And Dr. Mendez specializes in neuro-oncology, and he has focuses on the whole spectrum. And he has a particular interest in CNS lymphoma, and he is actively involved in medical education over at the University of Utah. We welcome Dr. Mendez.
Hi there, everyone. Let me just pull up the PowerPoint. Can everyone see that okay?
Yes.
Perfect. All right, thank you guys for having me. I appreciate it. So as Dr. Smith-Cohn mentioned, I treat, one of my specialties is primary CNS lymphoma. So today I'll be talking primarily about that. Want to give a quick overview of the disease itself, just so that we're all on the same page. And then spend the majority of the time talking about treatment paradigms, how we arrived at them. And then, of course, looking at the advances that have happened in primary CNS lymphoma. We all know, but just to recap, so primary CNS lymphoma is a rare but aggressive form of extranodal non-Hodgkin's lymphoma. The definition really is strict in the regards to the lymphoma involving only the central nervous system, so no systemic disease. So primarily brain, spinal cord, left meningeal, and orbital involvement only. In regards to the histologies, it's a diffuse large B-cell lymphoma, typically. Of course, you can see other types, but those are far more rare. When we look at the epidemiology of primary CNS lymphoma, you can see here over 2 large databases over 40 years, incidence has been relatively stable at about 0.4 per 100,000. And if we look at age groups, you can see here that this is a disease of the elderly, with incidence rising with age, and most notably is the most common in 70 to 79-year-old patients. Clinical presentation, like anything in neurology, is based on location of lesion. Primary CNS lymphoma has a predilection to the periventricular region, and as a result, most patients will present with some sort of cognitive complaints typically. As far as the workup's concerned, it's very important to extensively evaluate the CNS compartments, in particular the brain, parenchyma, spinal cord itself, and then of course the cerebral spinal fluid and the space, particularly via LP, and then of course the orbits with ophthalmologic evaluation. The importance of this is to understand which compartments are involved with primary CNS lymphoma, as this will be prudent to reevaluate following administration of induction therapy to assess for responses in each of the compartments. In addition to that, a systemic involvement should be, in the extent of systemic involvement should be evaluated with PET-CT, again, to rule out any evidence of systemic lymphoma, and then potentially consider a bone marrow biopsy as well. If we look at how we actually obtain the tissue, most commonly we obtain tissue via surgical biopsy through parenchymal biopsy on the brain MRI, or sorry, in the brain. In general, it's advocated to avoid steroids for obvious concern and for the biopsy to be non-diagnostic potentially due to the potential therapeutic benefit of steroids, although not sustained. There's no clear indication for surgical resection in primary CNS lymphoma, partly driven by trying to reduce risk to patients, but also because this disease is very chemo responsive, not really a clear indication as far as survival benefit in this patient population. If there's not a parenchymal lesion, or you have suspicion, but the lesion is in a difficult area, there are other ways to clinch the diagnosis. One would be in patients with leptomeningeal involvement. You could obtain a cerebrospinal fluid evaluation, looking for cytology, and then flow cytometry with the finding of a monoclonal B-cell population. Again, if you have evidence of ocular involvement, a vitro biopsy can also be performed, where flow and cytometry or cytology can also be performed to obtain the diagnosis. So what do we see on imaging? Usually primary CNS lymphoma is a homogeneously enhancing lesion. As I mentioned, it's typically periventricular. It can be multifocal and often is. In addition to that, a heralding finding is typically pretty striking diffusion restriction of the lesion itself. If we were to complete a PET-CT, these lymphoma lesions are very avid, with typically an SUV above 15. So on occasion, I will use a PET to help me distinguish between true persistent disease or potentially surgical post-treatment effects that can be seen on MRI after therapy. This is a patient of mine. Just want to display ocular lymphoma in the appearance. And you can see here the ocular lymphoma. In regards to prognostication in primary CNS lymphoma, there are primarily 2 scoring systems that are used. I'll talk about one that's very easy to apply, and that's the Memorial Sloan Kettering prognostication system. You can see here it's divided into, or based upon age, greater than 50, or KPS less than 70. So in this study by Sloan Kettering, they did RPA partitioning, and were able to define 3 classes that were clearly, as you can see in the Kaplan-Meier, statistically different in regards to overall survival. So you can see, just comparing those patients that are young, have a median overall survival about 8.5 years, whereas the class 3 patients who are older than 50 and a KPS less than 70 have only a median survival of 1.1. This RPA classification system is commonly applied in clinical trials to help distinguish patient populations. We'll now move on to treatment paradigms and spend the majority of the presentation discussing treatments in primary CNS lymphoma. So just a historical background, whole brain radiation therapy was commonly used as a treatment modality. One in particular, it is responsive and produces responses, survivals of somewhere around 11 to 12 months. Shortly later, methotrexate was introduced in the 1990s in combination with whole brain radiation therapy with superior outcomes. And really this establishes the idea that primary CNS lymphoma is a chemosensitive cancer and really sets the stage for the development of primary CNS lymphoma being treated primarily with chemo only. This is a phase 2 trial done from the Italian group. And in this study, they compared high-dose methotrexate versus high-dose methotrexate and high-dose cytarabine. And what you can see here in the overall response rates and 3-year overall survival is outcomes were better in the arm that received polychemotherapy and provides the rationale for the application of polychemotherapy in the treatment of primary CNS lymphoma. This is a theme that I'll outline a little bit later as we look at the current regimens being used in the US. This clinical trial is the only phase 3 conducted in primary CNS lymphoma. It's from the German group. In this study, they looked at patients and treated them with high-dose methotrexate or high-dose methotrexate with whole brain radiation therapy. And the most striking finding is there's no difference in overall survival between these two groups. And interestingly, neurotoxicity was more common in those patients who received whole brain radiation therapy. Following this, you can see here, this study was conducted at a Sloan, and it was a retrospective study reviewing and trying to understand neurotoxicity in primary CNS lymphoma. What they were able to do is describe the phenotype of these patients. So clinically, they're stereotypic and progressive dementia. Radiographically, they have progressive white matter changes. And most importantly, the risk factor was found to be radiation therapy. So along with this study from Sloan, as well as the phase 3, it really established that radiation therapy, is very toxic or can be very toxic, and has led really to transition moving away from radiation therapy as a primary treatment modality in newly diagnosed primary CNS lymphoma. Now we'll go back to the treatment paradigm. So in general, patients are treated with an induction chemotherapy consisting of, as I mentioned prior, based on the literature, a polychemotherapy regimen with methotrexate as the backbone. The most common treatment strategies or inductions are going to be the MTR, which is rituximab methotrexate Temodar, and then RMVP, rituximab methotrexate vincristine procarb. These are probably the most commonly used in the US, so I'll kind of focus on those two. In regards to their efficacy, in general, these two have fairly similar outcomes with 2-year overall survival, somewhere between in the 60-70% range. So are very comparable, and which is why you see the diversity of the inductions being used. More importantly, there's been no clear head-to-head comparing these induction therapies, making it challenging to have a clear standard of care. Following induction therapy, these patients are assessed in each of those CNS compartments that I mentioned to look for a response, with a goal, of course, of obtaining a complete response. If that goal is achieved, patients will proceed with consolidation therapy. I've listed 3 here, but primarily what's most commonly used is high-dose chemotherapy. It's non-myeloablative, or myeloablative chemotherapy followed by autologous stem cell rescue or transplant, which we'll talk about when we get to advances in the field. So in regards to the high-dose chemotherapy that's used, each of the inductions actually has a paired, so to speak, consolidation regimen. So rituximab, methotrexate, Temodar is typically followed with EA as the consolidation regimen. And then RMVP is typically followed with high-dose cytarabine as the consolidation regimen. Now moving on to advances in primary CNS lymphoma. First, we'll talk about the utilization of autologous stem cell transplant and rescue. So as we look at this, there are numerous trials I shouldn't say numerous, there are a few trials that I could discuss and bring up, but I wanted to highlight this one of the earlier ones. It's a phase 2 study of 33 patients. These patients received induction therapy with RMVP, then subsequently received conditioning with thiotepa, busulfan, cyclophosphamide. The key thing here is understanding that the TBC is actually the therapeutic regimen in this treatment. Subsequent to this, patients receive an autologous stem cell transplant, or as I refer to it, a rescue, in the hopes of them surviving this myeloablative chemotherapy. You can see here impressive response rates of 97%, very high 2-year overall survivals of 81%. Challenging, though, is that there was an 11% death rate among the patients who participated in the study, which does raise some concerns about the safety of this treatment. If we look at the data in a little bit more detail, you can see here that the patients are most commonly less than 60, actually all of them, and a significant of them are less than 50. If you recall, when I was reviewing the epidemiology in primary CNS lymphoma, the majority of patients are older, particularly over 70. So this really raises the question on the generalizability of this, generalizability and application of this treatment modality. So this group, what they really did is explore specifically the toxicities related to autologous stem cell transplant or rescue in primary CNS lymphoma patients. Mortality rates typically in autologous stem cell transplant are less than 5%. This study explored a few cases of this, and what they found was a 7% treatment mortality rate, which is obviously high and higher than those seen in non-Hodgkin's lymphomas. What's really striking is what you can see here is there's a high rate of febrile neutropenia and oral and GI mucositis. These patients commonly complain of and suffer from the need for parenteral nutrition, in addition to a PCA to control the pain associated with their mucositis. And as you can see here, the median number of clinically significant AEs is 5 per patient, obviously very high. Really the key take home about autologous stem cell transplant, and it's really starting to become standard of care. A large number of institutions that are seeing patients with primary CNS lymphoma will be recommending patients undergo consolidation with autologous stem cell rescue or transplant due to these high responses, but in addition, long-term survival. Now we'll take a look at the application of targeted therapies in primary CNS lymphoma. Before we get there, a key thing we need to understand is molecular genetics are starting to be explored in primary CNS lymphoma. And some discoveries have been made in a sense, the understanding, specifically the BCR signaling axis, playing an important role as a driver in the pathogenesis of primary CNS lymphoma. As you've heard from prior presenters, this has been a big move in the field of neuro-oncology, probably most profound in gliomas, but primary CNS lymphoma is trying to make headway as well. The understanding of mutations such as MYD88, CD79B, and CART11 being common in this disease process. Of course, with the understanding of these molecular genetics raises the application or the ability to apply targeted therapies to this disease process, which we'll get into in a little bit. And then in addition, there's also been finding of copy number gains in chromosome 9, as well as increased expressions of PDL1 and 2 ligands, raising the possibility of immunotherapy playing a role in primary CNS lymphoma. If we look specifically at targeted therapies, this is actually the BCR signaling axis. And as you can see here, key alterations seen are those in asterisks on the pathway. The first agent that we'll look at is ibrutinib, which is a Bruton's tyrosine kinase inhibitor, obviously attacking the Bruton's tyrosine kinase itself along the BCR pathway. This was first studied in 2017 in the phase 1 with 20 patients with relapsing remitting primary CNS lymphoma and secondary CNS lymphoma. They were treated with single agent ibrutinib. And what's impressive about this study is you can see here very fast responses. So the image that I've outlined here is an 8-week period of time where you see a near complete response in that patient that's highlighted. In addition, a 77% clinical response, which is impressive in relapse and remitting disease, a median PFS of 4.6 and an overall survival of 15 months. These numbers are not great, but in the literature for relapse and remitting primary CNS lymphoma, these numbers are actually quite good and better than what has been shown prior. In particular, what was notable, as I mentioned, secondary CNS lymphoma was also included in this population of patients. Interestingly, this is the first drug where primary CNS lymphoma has had greater response than secondary CNS lymphoma patients. So very interesting. Moving on, we'll talk a little bit about lenalidomide now. It is an immunomodulatory MI drug and acts at the NF-kappa beta, and so has also been utilized as a potential therapeutic agent in primary CNS lymphoma. The phase 1 study was conducted and published in 2018 in 14 patients with relapsed refractory primary CNS lymphoma and secondary CNS lymphoma. And what you see here is very similar to the ibrutinib paper with good response rates greater than 50%. Of note in this study, they did have a significant percentage of responders who maintained that response for greater than 9 months. Now, where has the science led us with these two applications? Well, most importantly, both ibrutinib and lenalidomide with these publications have now been incorporated into the NCCN guidelines and are now standard of care or treatment options for relapsing remitting primary CNS lymphoma. In addition to that, ibrutinib is currently being studied in multiple applications, one with the Sloan Kettering group, the application of ibrutinib in combination with rituximab and methotrexate, so polychemotherapy-based regimen in relapsing remitting disease. And then in addition, lenalidomide has also been explored in a polychemotherapy regimen referred to as Reverie with rituximab combined with lenalidomide. Both of those obviously need more information and more clinical trials to evaluate their true efficacy. Now we'll move on to immunotherapy. To be honest, immunotherapy in primary CNS lymphoma is lacking at this time. Nivolumab has probably been the most utilized in this disease. The most notable study is only a case report published in Blood, noting 4 patients with primary CNS lymphoma who had clinical and radiographic responses. So a lot to be desired in this front. Lastly, what we'll talk about is the role of rituximab. So the HOVEN 105 clinical trial was recently had its first release of data. It was a phase 3 randomized trial from 3 countries, including 200 patients that were newly diagnosed primary CNS lymphoma. Therapeutic regimens included their induction therapy of MPVP, and then a group received that regimen, and another group received the addition of rituximab to that regimen. And really the findings showed there's no difference in response rates or PFS. Unfortunately, it's not enough time to understand the impacts of this on median overall survival. But what this trial really has shown or challenged is the role of rituximab in primary CNS lymphoma. However, maturity of the data is needed in order to give definitive information and, more importantly, clinical application of these findings. So big take homes today on primary CNS lymphoma really is defined by the lack of systemic involvement. It's prudent to evaluate for systemic involvement as well as the extent of CNS involvement at the time of diagnosis. The treatment paradigm is defined by induction therapy, which is a polychemotherapy regimen, including methotrexate. Consolidation, various options, but autologous stem cell rescue is at the forefront of interest at this time. Our treatments for primary melanoma are very efficacious at this time. However, there's high probability of recurrence, including long late-term recurrences, including those beyond 5 years. And then, as I've highlighted today, targeted therapies are playing a significant role in the recurrence of primary CNS lymphoma. Thank you guys for your time today. I'm happy to answer any questions.
Thank you, Dr. Mendez. Awesome overview of CNS lymphoma. One question I have, and I think a lot of others do too, is the diagnostic algorithm currently that's appropriate, especially given some of the molecular rearrangements that are now understood. Personally, I don't really see any reason in doing an LP or doing vitriol sampling if tissue can be safely obtained. And I think the bigger question is steroid treatment up front really contraindicated if you're going to get them in the OR within 24, 48 hours? Because even if you start to have some tumor apoptosis, you're going to be able to make the molecular diagnosis quite often.
Yeah, I think the challenge currently right now is molecular diagnostics has not been integrated into the diagnosis. So for example, the 2021 WHO does not really outline those molecular changes as diagnostic entities themselves. There's definitely been a push to incorporate things specifically like MIghty88 being a part of that algorithm as far as the molecular diagnosis is concerned. So there are institutions that are using things such as, for example, an LP in assessing cerebrospinal fluid for MIghty88 mutations, or done in ophthalmology where they take the vitreal biopsy and evaluate for MIghty88 mutations to be supportive of the diagnosis. In regards to the question about steroids and timing, I think it's a challenging question. I think we all who treat primary CNS lymphoma can give accounts to where patients have received steroids and a non-diagnostic biopsy is obtained. However, I do agree with you. I think that if there's a short time interval between initiation of steroids and biopsy, particularly if the mass is a relatively good size, I think the yield is usually very good. However, it's always challenging to know if you're going to take some of the operating room and, of course, end up without your answer.
All right. Well, if anybody has other questions for Dr. Mendez, please chat them in. We're going to keep moving, and we are making up some lost time, which is awesome. Happy to introduce our next speaker, Dr. Dan Brown. Dr. Brown is currently chair of pathology and laboratory medicine at Lehigh Valley, based in Allentown, Pennsylvania. He has had an illustrious career over there over the past 20 years or so, including getting an MBA along the way. I just reviewed his CV again. He is not listed as the author of the Da Vinci Code under his book chapters, but it may be his alter ego. And that was a great transition from Dr. Mendez, because Dr. Brown's going to be giving us an overview of that 2021 update for the WHO diagnosis of CNS tumors, talking about a lot of what we've heard about already today in terms of the role of molecular diagnosis and some of the new classifications of tumors that we've kind of known about for the last 5 or even 10 years in some cases, but are now finally official diagnoses. Dr. Brown, really happy to have you here today, and so happy to be welcoming you to the Swedish family later this year.
Thank you, Zach. Appreciate that very kind introduction. And let me pull up my screen here. Okay, hopefully everyone can see that.
Yes, that looks great.
Okay. So yeah, so as Zach mentioned, I'm going to be giving an overview of the 2021 WHO classification of tumors of the central nervous system, focusing on some of the changes that we're seeing over the last several years or so. And this is what we're talking about. I actually don't yet have, because of supply chain issues, the hard copy in hand. It is on its way, but you can actually access the full classification online. So I do have it included as a link here if anyone wants to take a slightly deeper dive. It's listed there for you. So the very first publication of WHO classification of tumors of the central nervous system was back in 1979. And you can see that about every 7 to 10 years or so, there has been an update to that classification system. And there are many of us who have felt that waiting 7 to 10 years to update our classification system is far too long. But fortunately, there was a group of experts, international experts in both neuropathology and neuro-oncology, who got together and formed a consortium. And they called that consortium C-IMPACT, which stands for Consortium to Inform Molecular and Practical Approaches to CNS Tumor Taxonomy. And the goal of this group was to publish regular updates, and they actually published 7 of them over the last 4 or 5 years or so, as a guide to neuropathologists to assist us in trying to incorporate changes that we were seeing and information that was coming out of the literature to present better neuropathology reports and information that was going to help our clinical colleagues who are managing patients with brain tumors to really leverage the molecular information in our reports for treatment purposes. So you probably have seen many of these changes already because a lot of these were things that neuropathologists have started to incorporate in advance of the classification system. And I will tell you, though, that most of the experts sit on the WHO classification committee. So all of these changes have, in fact, been incorporated into the new classification. So I'm going to start with some general changes first, and then we'll get into some of the more detailed changes. So with molecular biomarkers having been, much further elucidated over the last several years, that certainly has been great for our patients. But because of that, there have been challenges that have arisen on how to actually organize the classification of our tumor types. We know that there are certain tumors that are readily and consistently characterized by defining molecular features. And the classic example there is the oligodendroglioma, which now in WHO and actually in 2016 required both an IDH mutation as well as one P19Q co-deletion. So that's actually in the diagnosis. There are other tumors where molecular patterns are not specifically required, but certainly can support that classification, such as the papillary craniopharyngioma, which we know most of these have an underlying V600E BRAF alteration. And then there's still other tumors that are rarely, if ever, diagnosed using molecular approaches such as the subependymoma. So what we currently have is still sort of a hybrid taxonomy, and this is still evolving. I do anticipate that moving forward, we're going to have more and more tumors that are specifically defined by their molecular alterations. So it has been, as has been mentioned previously, anticipate further C-IMPACT updates moving forward. Other general changes that hopefully most of you have been seeing in your neuropathology reports is the way that we are presenting our information. So we are going with an integrated and layered diagnostic approach. And essentially what you have is a top-line integrated WHO diagnosis, if you will. And then beneath that, the neuropathologist will list all of the relevant and salient features that were present on that case. The histologic diagnosis, what the grade was, and any molecular testing that was performed. So here's an example of an integrated and layered diagnosis. The integrated diagnosis being glioblastoma IDH wild type, WHO grade 4. And then here's our layered approach where we're listing the histology as GBM, and you can clearly see a nice example of a glioblastoma over on the right. Glioblastomas are graded as grade 4. And then we did a variety of molecular tests, and all of that information is listed here, some of which is useful in actually making the diagnosis, but other is more important as far as the patient management for this individual patient's tumor. Some other changes that you might be seeing is the introduction of the terms not otherwise specified and not elsewhere classified. This actually was the very first update that C-IMPACT now published back in 2018. So the term NOS is applied when the diagnostic information that's needed to assign a specific WHO diagnosis is not available. And an example here might be that you're looking at a small biopsy of what looks histologically like a classic oligodendroglioma. It fits clinically with the information on that case, and you do have some supportive immunohistochemistry. You have an IDH1 mutation, you have retained staining for ATRX, and you have no evidence of any P53 staining, but you unfortunately have exhausted your tissue and you don't have enough to perform 1p19q co-deletion testing. So technically you can't make the WHO diagnosis of oligodendroglioma because you don't have the 1p19q to confirm. So that's where you would say oligodendroglioma, comma, NOS, and then in a comment, you would indicate that confirmatory testing unfortunately could not be performed. Not elsewhere classified is slightly different. That's when you have ample tissue and you have all the testing that you need, but the results actually don't allow you to make a WHO diagnosis. So there's some clinical or histologic or molecular mismatch with what you're seeing. And so therefore you apply the term NEC. Now, both of these are basically alerts to the oncologist and the treating physicians that as a neuropathologist, we've not been able to make a specific WHO diagnosis. And it behooves one to then dive a little bit deeper into the report to find out what was going on, or perhaps, and maybe even better, having a conversation with a neuropathologist so you can understand the parameters that were or were not present in that particular patient's tumor. Some other general changes you'll be seeing is we've moved away from Roman numerals and we are now using Arabic numerals for CNS tumor grading, hopefully to reduce some of the confusion that can arise with Roman numerals. We've also shifted to grading within tumor types. And an example here is astrocytoma IDH mutant, which can now be graded as a 2, 3, or 4. This essentially eliminates the diagnoses diffuse astrocytoma and anaplastic astrocytoma from the integrated diagnosis line. Certainly these histologic features would be present in a layered approach, but we've simplified things such that with an IDH mutant astrocytoma, that is the single diagnosis graded as either a 2, 3, or 4. And then for certain tumors, we've gone to combined histologic and molecular grading. And an example here is glioblastoma IDH wild type who grade 4. I'm going to go into this in a little bit more detail shortly, but essentially you can now make the diagnosis of glioblastoma in a couple of different ways. One, you can have traditional glioblastoma histology in the setting of an IDH wild type diffuse astrocytoma, namely vascular proliferation and necrosis. Or if you have low-grade histologic features in an IDH wild-type astrocytoma, but you have very specific molecular alterations that are commonly found in GBMs, that is now sufficient to diagnose that as a glioblastoma IDH wild-type who grade 4. And as I said, I'm going to go into that in a little bit more detail shortly. In the new classification, we actually have 19 newly recognized entities and 3 provisional entities that need a little bit more study. And unfortunately, I don't have time to go into each of these, but I'm going to try and touch on several of them. And what you'll notice is that many of these new tumors fall into the pediatric type of diffuse gliomas. So in the 2021 classification, for the first time, we have separated out our adult type diffuse gliomas and pediatric type diffuse gliomas into 2 separate categories. And a lot of this work has been done because of the elucidation of the molecular differences between these broad categories of tumors. What you're seeing here is sort of a snapshot of how we're further subdividing our pediatric type diffuse gliomas. We now have 4 low-grade gliomas and 5 high-grade gliomas in the pediatric type. You'll also notice that many of these tumors have a very specific molecular alteration tied to them. I am going to talk about one from each category. I think we do have enough time to do that. And I'm going to start with a low-grade pediatric glioma. This is a new entity, the polymorphous low-grade neuroepithelial tumor of the young, or the plenty tumor. And I'm glad they abbreviated it because polymorphous low-grade neuroepithelial tumor of the young is a mouthful. And then I'm also going to touch on a single new high-grade glioma known as the diffuse hemispheric glioma, histone 3 G34 mutant. First, our plenty tumor. This is a tumor that tends to occur in children and young adults. There's a very strong association with seizures. These tend to be superficial temporal lobe neoplasms, and they can have both solid and cystic components. And hopefully you can appreciate in the image that I provided for you here that these look an awful lot like oligodendrogliomas. You can see they have fairly uniform round nuclei with some perinuclear halos. This is an infiltrative tumor, so we have some entrapped neuronal elements that are present. We even have some small microcysts and even some microcalcification here. So I can tell you that perhaps many of these tumors previously, before this entity was described, fell into the category of the pediatric oligodendroglioma. But we know these certainly aren't oligodendrogliomas. They do not have IDH mutations. They do not have 1p19q co-deletion. And what's unique about these tumors is that from a neuropathology perspective is that they do have C34 positivity. So that can give you a clue that you're actually dealing with one of these neoplasms. It's not specific, but in the setting of something that looks like an oligo that's IDH negative, CD34 positivity can help guide you on those cases. Almost all of these tumors have an underlying MAPK pathway activating genetic abnormality. There are a couple that you can see. You can see FGFR mutations, and you can also see BRAF mutations. And given that this is a low-grade tumor, these are graded as grade 1. They actually have a very good prognosis, and gross total resection, many of these tumors can be cured, and certainly seizures significantly improved. Okay, and an example of a new pediatric type high-grade glioma is the diffuse hemispheric glioma histone 3G34 mutant. So this is somewhat analogous to the diffuse midline glioma that was presented first as an entity in the 2016 edition of the classification. This is also a histone 3 mutated tumor, although it's slightly different. It's at G34 versus K27M. And obviously, by definition, this tumor is occurring out in the cerebral hemispheres as opposed to midline structures. This tumor also occurs in children and young adults. Imaging features can be variable. Some of these tumors certainly do look like high-grade gliomas on imaging studies, but there are other tumors that can look like low-grade gliomas despite uniformly having high-grade histologic features. And you see an example here. We've got vascular proliferation, palisading type necrosis, and lots of mitotic activity. So a very GBM-like histology, and I would bet that many of these tumors previously were probably diagnosed as pediatric glioblastomas. But these are unique tumors. They do have a very specific histone 3 missense mutation. These tumors are IDH wild type, and they all have ATRX and P53 mutations. And from a neuropathology perspective, what's useful is that these tumors are OLIG2 negative. So OLIG2 is an immunohistochemical stain that's nonspecific. It stains cells with glial lineage, so it'll stain normal glial cells as well as neoplastic glial cells. And it is positive in the vast majority of our infiltrating diffuse gliomas. So the fact that it is negative in this diffuse hemispheric glioma H3G34 mutant is a helpful clue, especially with this immunohistochemical profile of IDH negative, ATRX loss of staining, P53 positive, usually significant positivity, and OLIG2 negative, that you're dealing with this particular tumor even prior to doing molecular testing for histone 3 mutation. And these are high-grade gliomas, so they are graded as a WHO grade 4. Okay, I'm going to shift now into our adult type diffuse gliomas. And if you were fortunate enough to hear Dr. Coleman's presentation earlier today, excellent talk, I'm going to reinforce some of the things that he presented related to the changes in this family of tumors. Generally, we have seen a simplification in the number of diagnoses that we have with our 2021 version of the classification. So in 2016, we actually had 15 different types of adult type glioma diagnoses, and now we just have 3, and you can see them listed here. Our IDH mutant and 1p19q co-deleted oligodendroglioma, our IDH mutant astrocytoma, and our IDH wild type glioblastoma. The only real change from our oligodendroglioma tumor in the new classification is that instead of having 2 separate diagnoses, one for low-grade oligodendroglioma and one for anaplastic oligodendroglioma, we've simplified this much like we've done with our IDH mutant astrocytoma, such that we have a single diagnosis now that can be graded as either grade 2 or 3. And then in the layered approach, we would then include what the histologic features were that gave you the grade 2 or grade 3 designation. But that's really essentially the changes we're seeing with oligo, so nothing terribly significant there. However, as Dr. Coleman presented earlier, we have made some significant adjustments in our approach to IDH wild-type glioblastomas. So I'll talk about those now. And many of these recommendations were published in the third update from CMPAC now back in 2018. We've known for some time that there is a subgroup of diffuse astrocytomas that, despite having fairly low-grade histology, they can have clinically aggressive behavior. And a lot of this work is coming out of the Cancer Genome Atlas Research Network, a real nice article published by Dan Bratt and colleagues in the New England Journal from 2015, looked at this family of low-grade astrocytomas with clinically aggressive behavior and found that the vast majority of these were IDH wild-type tumors. So that was a very significant finding. At about the same time, others were also looking at this family of IDH wild-type low-grade astrocytomas, and this is work out of Switzerland. Weller and colleagues who identified that those tumors that had combined gain of chromosome 7 and loss of chromosome 10 had very similar clinical outcomes with IDH wild-type GBM. And other work, and this is out of Hong Kong and Shanghai, identified that this very same family of tumors, IDH wild-type low-grade astrocytomas, that had either a TERT promoter mutation or EGFR amplification, both had progression-free and overall survival rates similar to IDH wild-type glioblastoma. And so with all of that information in the new classification system, the diagnosis of glioblastoma, IDH wild-type, WHO grade 4 can now be made with one or more of the following features. So you can have traditional GBM histology, like we're seeing over here on the right with microvascular proliferation and necrosis. But even in the setting of low-grade histology, if you have one or more of the following mutations, a TERT promoter mutation, EGFR amplification, or 710 copy number chromosome alterations, that is now sufficient for a WHO grade 4 glioblastoma diagnosis. That's a major shift in the way that we're looking at these tumors, not diagnosed solely on histology, but also on the molecular alterations that are present in this family of tumors. We've also made some changes to our IDH mutant astrocytoma category, and we'll talk about those now. Many of these recommendations were presented in the 5th update from CMPAC now. I touched briefly on the grading within tumor types, specifically astrocytoma IDH mutant can now be graded as a 2, 3, or 4 tumor, which essentially eliminates the terms diffuse astrocytoma and anaplastic astrocytoma from the integrated diagnosis line. But perhaps more importantly, the term glioblastoma IDH mutant no longer exists. And that's because we fully recognize the difference between these two high-grade tumors. Glioblastoma is now only used as a diagnosis in the setting of an IDH wild-type tumor. So if you have a tumor that histologically looks like a GBM, yet it has an underlying IDH mutation, the new diagnosis is astrocytoma IDH mutant grade 4. And the other alteration that we now need to assess in these IDH mutant tumors, and this also was presented by Dr. Coleman this morning, is the evaluating for homozygous deletion of CDKN2A. So we do know that there is a subset of these IDH mutant astrocytomas that have poor clinical behavior, and almost all of these have an underlying homozygous deletion for CDKN2A. So you can get to a grade 4 diagnosis now with an IDH mutant astrocytoma in one of two ways. You can have high-grade histologic features, palisading type necrosis, vascular proliferation, lots of mitotic activity, things that I'm calling GBM-like histology, but of course we're not calling these GBMs because these are IDH mutant tumors. Or in the setting of grade 3 or grade 2 histology, if you have homozygous deletion for CDKN2A or B, that is sufficient now to upgrade these tumors as grade 4 because we know that these are going to behave clinically much more aggressively. All right, shifting now to our ependymal tumors, we have made some updates in this family of tumors as well. Specifically, we have started to separate these tumors out based upon a combination of histologic, molecular features and their anatomic site. So the first diagnosis you see there is the supratentorial ependymoma ZFTA fusion positive. This is essentially a name change, if you will. So this is referring to what we previously called the RELA fusion positive ependymoma, because we now know that although RELA is the gene fusion partner in many of these tumors, ZFTA can fuse with other gene partners. And in fact, ZFTA is actually the oncogenic driver in the vast majority of these tumors. So it's more appropriate to call these ZFTA fusion positive supratentorial ependymomas. We have a new ependymoma, the supratentorial ependymoma YAP1 fusion positive. This tumor, at least in some preliminary clinical studies, which tend to occur in very young children, have a more favorable prognosis than the ZFTA fusion positive tumor. So this has been identified as a distinct entity. We do need to do some additional clinical work on these cases because they're somewhat rare to ensure that these in fact do have a better prognosis than their ZFTA fusion positive counterparts. But for the moment, these have been separated based upon that molecular alteration. We've also separated our posterior fossa ependymomas into two main groups, Group A and Group B, and this work was largely accomplished through methylation profiling of these tumors. So in our Group A tumors, these are tumors that on methylation profiling have either a significant reduction or absence of methylation. These tend to occur in younger children, and they tend to have more aggressive clinical behavior. Our Group B tumors have maintained or intact methylation status, and these tumors tend to occur in older children or young adults, and they tend to have a more favorable prognosis. So again, we are now separating our posterior fossa tumors into these two main groups based upon their methylation profiles. And then a new entity in the spinal ependymoma group, one that has a MYC-N amplification. This has been singled out because although quite rare, this is a very aggressive tumor from a clinical perspective. And so important to identify MYC-N amplification. And neuropathologists can often be clued into this diagnosis because these frequently have high-grade histologic features. And then the other change in our ependymoma group is that the myxopapillary ependymoma is now being graded as a grade 2 tumor. Recall that these previously were graded as 1 tumors, but from a clinical behavior perspective, more akin to a grade 2 tumor, so that has been changed. In our meningioma tumors, we still have multiple histologic variants and subtypes. What we did not change is our choroid and clear cell types remain as grade 2 tumors. And I have examples of a choroid meningioma here and a clear cell meningioma here. So these are still grade 2 tumors based upon their biologic behavior. However, the rhabdoid and papillary types, and there's an example of a rhabdoid meningioma here, these are now to be graded based upon the histologic features of atypia and not morphology alone, whereas previously these were automatically graded as grade 3 tumors. But now we need to use our traditional histologic features of atypia so they can be graded as either a 1, 2, or 3. Been some changes in our solitary fibrous tumor group as well. The term hemangioparasitoma has officially been retired. You might recall that we had a sort of a hybrid taxonomy previously with this family of tumors, whereby low-grade tumors were called solitary fibrous tumors and high-grade tumors were called HPCs. We now have simplified that. We're calling everything solitary fibrous tumor, which does align with the soft tissue nomenclature, and then simply grading them as grades 1, 2, or 3 based upon the presence or absence of mitotic figures and necrosis. We do have a name change in our nerve sheath tumors as well. We have an entity now that we're calling the cauda equina neuroendocrine tumor, which is previously what we called the paraganglioma in this anatomic site. And through methylation profiling, as well as chromosome copy number profiles, we now recognize that neuroendocrine tumors in this specific anatomic site differ from paragangliomas in other locations. And so we have created a new name for this particular entity at this location. And then finally, in tumors of the sella turcica region, we have officially separated the adamantinomatous and papillary craniopharyngiomas into distinct tumor types. Previously, these were always variants of the same type. We've known for some time that from a clinical, radiologic, and histologic standpoint, these tumors are different, but now with our understanding of the molecular basis of these tumors, as well as methylation profiling, we are able to distinctly separate these into two individual tumor types. And then finally, in our pituitary adenomas, the CNS has essentially adopted the WHO classification of tumors of the endocrine organs that was published back in 2017. I think most neuropathologists have already used combined expression of pituitary hormones and transcription factors to diagnose these particular tumors. And there's also been the proposal to use the term PITNET or pituitary neuroendocrine tumor as a replacement for pituitary adenoma, which fits better with the way that we refer to these tumors in other anatomic locations. So that was sort of a high level and fairly rapid overview of some of the changes that we're seeing in the 2021 classification. And in the couple of minutes I have left, what I thought I would do is share with you a case that I recently saw in follow-up that I think nicely highlights some of the changes that we're seeing specifically in our astrocytic tumor family. So this is an unfortunate 35-year-old female who presented with headaches and a left frontal temporal mass. You can see here, no significant enhancement post-contrast. She underwent a tumor resection, and you can see that we have a low-grade astrocytoma without any evidence of mitotic activity, vascular proliferation, or necrosis. On immunohistochemistry, there was evidence of an underlying IDH1 mutation. ATRX staining showed loss of staining in the vast majority of tumor nuclei, which is what we would expect. You can see nice internal control staining of a blood vessel here in the center. P53 showed positivity in a number of tumor cells, and Ki67 overall showed a low proliferative index. Now, had we been leveraging the previous classification system from 2016, we would have called this a diffuse astrocytoma IDH mutant grade 2. However, we now recognize that there's a subset of these tumors that are going to behave clinically more aggressively, and we need to assess for homozygous deletion of CDKN2A. So we did go on and do FISH testing on this, and you can actually see that this tumor did in fact have homozygous deletion for CDKN2A in the majority of tumor cells. So using the new classification system, the diagnosis applied is astrocytoma IDH mutant WHO grade 4. So even though the histology was that of a diffuse astrocytoma, which tends to be a low-grade histologic appearance, we graded this as a grade 4 based upon the presence of homozygous deletion for CDKN2A. So there was some residual tumor surrounding the resection cavity, and ultimately this patient was treated with chemotherapy and concurrent radiation. And she did well for about a year with stable disease, but unfortunately, as you can see, did develop areas of recurrence, in particular new areas of enhancement that we did not see previously, some peritumoral edema and midline shift. And she ultimately underwent a second resection of her tumor. And hopefully, even if you're not a neuropathologist, you can appreciate that there's a significant change to the histology in this case. We now have a significant increase in cellularity. There's much more nuclear atypia, pleomorphism. Mitotic activity was rather conspicuous. We now have vascular proliferation and areas of necrosis. So we have all high-grade histologic features. You can see the Ki67 is now off the charts, although we still do have an underlying IDH1 mutation. Now, had we been using the previous classification system, this would have been diagnosed as a glioblastoma IDH mutant grade 4. However, we now know that moving forward, we're only going to be using the term glioblastoma for IDH wild-type tumors. This one has an IDH mutation, so the diagnosis is astrocytoma IDH mutant WHO grade 4. This is what we called it a year ago. However, now using our layered diagnostic approach, in addition to homozygous deletion for CDKN2A, you can now tell that we have high-grade astrocytoma histologic features. So even though the diagnosis hasn't changed, hopefully the oncologists can appreciate that we have had progression now on the histologic features of this particular tumor. So if we have any time left, I'd be happy to answer any questions. And again, thank you for allowing me to participate in today's course.
Dan, that was a tour de force. Great talk.
That was a lovely talk. Thank you.
Yeah, it's going to take me about 3 times to watch it before it starts sinking in.
It's a great overview. Very concise. I don't see any questions.
I have one question for you, Dan. It's nice to see you, and we're looking forward with you joining our group. With hypermutator phenotypes in IDH mutant gliomas, do you feel that could have a role in the subclassification of these tumors in the future?
Yes, Matt, I do. I think, thanks for the question. I think, we're at a point where we're going to be providing further classification to these individual tumors based on a variety of alterations, including methylation profiling, to further subdivide these tumors. Unfortunately, that's a technique that not everybody has access to, even in the United States, but certainly globally. So we need to make that more accessible. So hopefully we can have that available moving forward, because there were several talks today talking about the specifics of these individual tumors, whether they have NF mutations as well as other mutations, and how those tumors actually behave somewhat differently. If we can further refine that so that we can triage these differently through our clinical trials, et cetera, I think that's really going to be important. So this is just sort of a snapshot, if you will, a moment in time of where we are, but things are going to be constantly evolving, and we're going to see these changes very soon.
Thank you.
Hi, Dr. Brown. Thank you so much. That was a really wonderful talk, and I agree with everyone that it was a wonderful overview. I think it was just more of a comment, is that what you just spoke to is that it's so hard to do a lot of this testing, even as you're joining the Providence system. We're all sending out testing to different areas, and finding, especially the chromosomal analysis and everything, is really complicated. So one of the things I struggle with in my practice is just kind of waiting for the final diagnosis and how much delay that's resulting in and how that plays out. And do you have any advice in terms of for pathologists? Because understandably, a lot of our pathologists, especially those who are not neuropathologists and are not in that center, are anxious to make a diagnosis without all this information now.
Yeah. So, I mean, that's an excellent question. And, it's certainly something that we face at my institution and in our clinical practice. So generally, I approach this in a couple of ways. So there's certainly a fair number of immunohistochemical stains that can point us in the right direction, at least from a preliminary perspective. And Dr. Coleman spoke to, what they do at their institution as sort of a screening panel. My hope is that moving forward, we're going to start to see more immunohistochemical, what I'm calling surrogate markers, if you will. So immunostains that can, really provide information as to what the underlying molecular signature is without having to specifically do full bore molecular type testing. IDH1 is a classic example. While that doesn't pick up all of our IDH mutations, it picks up 85%. Positive stain sufficient, don't need to go on and do molecular testing. There are some surrogates for methylation profiling as well. Histone 3 K27 methylation immunostain is a nice stain that can help you segregate those tumors that are methylated from unmethylated without having to do methylation profiling. So again, it's my hope that moving forward, we can have more of these surrogates, and that we can sort of at least preliminarily classify these tumors without having to do additional molecular testing. And, in my group, I really reserve, next-gen sequencing for those types of cases where I haven't been able to make a specific diagnosis with what I currently have available in our clinical laboratory. If patients are ultimately needed to have these specific alterations for clinical trials, et cetera, then we go and do that. But I do think that there's a lot that you can actually do from a diagnostic standpoint using some simple techniques already.
Thanks, Dan. That's great. Excellent. Any other questions? Okay. So we're going to move forward, switch gears a little bit. We invited Dr. Leah, Dr. Halaz over to give us a talk on proton therapy. Leah obtained her medical degree from Harvard Medical School. She completed a residency in radiation oncology at Harvard. Then she completed fellowship training at Brigham. She is the program director of Radonc residency at UW. She's co-director of the Alvord Brain Tumor Center. She also sees patients at Harborview and Seattle Cancer Care Alliance. She's a principal investigator of several proton therapy trials. We're glad to have you, Leah.
Thanks so much. Thanks, Kester, for inviting me. I'm excited to talk with you today. Over the next 15 minutes, I will speak on proton therapy for leptomeningeal disease. And Dr. Phillips gave a very good talk this morning on leptomeningeal disease and some of the treatments and advances there. So I'm going to talk about how proton therapy may be helpful. So basically on the agenda, I'm going to start with the basics of proton therapy. So proton therapy is like standard photon X-ray radiation therapy in its actions on the cell. And the difference with proton therapy is it is a heavy particle. So it has different physics and dosimetry. And so it's actually been around for a long time. Protons have been around from the beginning of time. But in 1946, the physicist Robert Wilson proposed the medical use of protons as a way to increase the dose of radiation to a tumor and decrease overall exposure to healthy tissue. In the 1950s and 60s, there were a lot of research trials in Europe as well as in the United States at the Harvard Cyclotron Lab. And then it was 1990 that the first clinical center at the US Center at Loma Linda opened up after FDA clearance. And overall, 15 years ago when I was at the Mass General Hospital in training, we were only one of 2 centers using proton therapy. And now in 2022, there are 38 centers in the United States with about 200,000 patients treated worldwide. So just to give you a sense of where proton therapy is available in the United States, clearly from this map, you can see it's really concentrated on the Eastern Seaboard. We opened our center 9 years ago, which I think has been a great center because it's really been a resource for a big area, British Columbia, as well as a lot of the Pacific Northwest. We're happy that Utah has opened their proton center very recently. And when I was training at Boston, I remember taking care of about 19 proton patients who are pediatrics, because we mostly use protons for pediatrics, as I will discuss. And 3 of them were actually from the Pacific Northwest, 2 from Washington, 1 in Oregon. So I think it was really great to move back to my hometown here in Seattle and work on protons for CNS, especially for the pediatric population. But I specialize in taking care of adults. And so I think this talk is going to talk a bit about how proton therapy can really improve and expand some of our treatment options for our adult patients. So what is proton therapy? So protons are subatomic particles. And the reason why it is so expensive and you have such big buildings dedicated to proton therapy is because you need a cyclotron to accelerate these particles to about 2/3 of the speed of light. With that acceleration, you need a high energy to really penetrate the patient. And this diagram here, with the y-axis being the dose and the x-axis being kind of how far into the patient you're going, shows that at different and higher energies, you can get further and further in. So when we treat with our proton therapy, we are up here on the 231 mega electron volts to really get that into the patients. And what happens is as the particle enters the body, the energy is really loss is really small and constant until it hits the end of range. And when it hits the end of range, the particle loses a lot of its mass, gives off all of its dose, and then it stops. So the important part of proton therapy that is unlike X-rays that keeps going, proton therapy is radiation with breaks and stops at a certain point based on its energy. So it causes DNA damage along the path. So in thinking about physics of protons, this is kind of a schematic of how it works. On the y-axis, again, is that relative dose. On the x-axis is the depth in tissue. As a radiation oncologist, my aim is to treat the tumor. And so if you're thinking about brain tumors, you have healthy brain in front of it, you have the tumor itself, and then you have healthy tissue behind it. So our goal really is to get radiation therapy to only treat the tumor and not treat the healthy tissue. But obviously with physics, we're not allowed to do that. We have to work with particles that we have. And so it's impossible to completely get at that, although there are some tricks for people using brachytherapy where you put the radiation right in the middle. And with X-rays, what we do is we usually use multiple X-ray beams. It comes in to the skin, it elevates its dose, and then it drops off quickly after you hit the tumor. So you never use a single beam, but you use multiple beams to get at this. Proton therapy just has a different dosimetry where it enters at a certain dose, it goes into the body, and then it elevates right at the end of the Bragg peak and then falls off. So we use what we call a spread out Bragg peak, which stacks a lot of these Bragg peaks together to get at the tumor. And overall, what it decreases is some of the entry dose and a lot of the exit dose. So this is a comparison of a single photon beam versus a proton beam in its dose map. So this is not exactly how we treat patients. We always use multiple beams in both ways, but just gives you an idea. So here on the left, you can see that a photon beam comes up, you get the higher dose in red that you want to the tumor, here retinoblastoma, and then it keeps going. In a proton beam, it comes in, you give the high dose, and then it stops. But again, we use multiple beams in both of these ways. So how do we use these the proton therapy in terms of actually giving us some benefit? So I think one of the poster children for protons, and as I was showing in the map, I really don't think proton therapy is right for all tumors. It's really specific indications, and especially for pediatrics. Because in kids with pediatrics, they have developing tissues and long-term to live. So the long-term late effects of radiation therapy can be quite impactful. So craniospinal radiation, and this is a patient with medulloblastoma, has been someplace that we've seen quite a bit of this. So if you look at an IMRT plan with photon therapy, though we're able to really concentrate that high dose, we still have low dose spread to some of the anterior organs and more low dose spread to some of the anterior aspects of the skull base. With proton therapy, since we can stop it where we want, we have no dose to a lot of the anterior organs and lower dose to a lot of the anterior aspects of the skull base. So protons in pediatrics has really been shown to decrease neurocognitive decline, pituitary dysfunction, hearing loss, secondary malignancy, and cardiac disease. But how about adults? So adults are a little different. Adults do not have developing tissue. They also don't have as good a prognosis long-term. But the unique aspects of proton therapy can also make our current treatments more tolerable. So one of those areas is an adult medulloblastoma, and proton craniospinal radiation is just more tolerable for adults. So clinically, I noticed this because having trained in protons and using craniospinal radiation in adults, when I came to the UW and we did not have protons, I treated my first 6 patients with PNET or disseminated glioma. And I was surprised by just how sick they got, how they were in the ER quite a bit, how a few of them went to hospice right away. And it was really interesting how when you take such a big amount of radiation that you give, kind of one of the biggest treatments we give, aside from total body irradiation, that is much less tolerable. And so MD Anderson did look at their series now a few years back, where they looked at 40 patients with adult medulloblastoma treated with photon or proton CSI. And overall, they found less toxicity with protons, including less weight loss, less grade 2 and nausea and vomiting, less esophagitis, and less pancytopenia. So this is where you increase the therapeutic index of craniospinal radiation, which can be really important from a tumor control for those tumors that we know spread along the CSF, like medullo, as well as PNET, non-germinous germ cell tumor. But also think about diseases like leptomeningeal metastasis, where we know that the CSF is seeded, but at the same time, we don't have the best treatments for that. We also think about patients with disseminated glioma, really a poor prognosis for a long time, though with the exciting treatments that I saw today, hopefully can be living longer and may need more consolidated radiation, as well as CNS involvement of ALL and AML. And this is where we've used craniospinal radiation. So to take a step back to leptomeningeal metastasis, about 4 to 8% of patients with solid tumors, but really the incidence has been increasing. And that's probably for a few reasons. One being increased sort of use of MRI and picking this up. But a very important one being the increase of systemic therapies that really can have our patients living for very long. So I really think, for instance, a lot of the patients with targetable lung cancer who are living several years on osimertinib, and then somehow the tumor the cancer continues and lodges in the CSF. And so we're seeing patients like that. Median survival is still very poor, 3 to 4 months. But there are some groups with better prognosis, with high KPS, nodular versus kind of the classic sugar coating, and some of the patients with, for instance, breast cancer that's targetable with HER2 mutations. And overall, there are multiple series. There was a recent meta-analysis looking at all the series using photon or standard craniospinal radiation. And overall, though there was good tumor control often, it was associated with severe side effects. And so really hadn't become so commonplace in what we used. Protons, as I explained, can kind of improve that side effect profile. And Memorial Sloan Kettering recently published their phase 1b trial. They treated 21 patients with 30 gray and 10 fractions. Most were lung cancer patients or breast cancer patients. And they did a 3+3 sort of design with some dose de-escalation. And overall just had 2 patients with dose limiting side effects in the end. So that was grade 4 lymphopenia, grade 4 thrombocytopenia, and fatigue. And as you can see in this waterfall plot with the 21 patients in the months kind of along here on the x-axis, that overall the blue being improved or stable symptoms with carcinomatous meningitis, as well as the orange being progression, that though there was a poor prognosis as would be expected, that there are many patients who actually lived beyond that 6-month mark. And so the median CNS progression-free survival was 7 months, median overall survival was 8 months, which in comparison to a lot of the drug trials is a fairly good survival. It is important to note that they did a really great quality of life evaluation, and there was a decrease kind of 2 to 4 months after radiation. So this is not without side effects, but at the same time can allow for some good tumor control. They also published their 58 patients that weren't in the prospective trial, but kind of their experience altogether, giving us bigger numbers, again, mostly lung and breast, and overall found a median CNS progression-free survival of 6 months, median overall survival of 8 months. You know, clearly there is selection bias in figuring out which patients who have good KPS can really withstand this craniospinal radiation, and patients who have better prognosis, but really favorable outcomes when you compare to other treatments. So I think that was exciting kind of beginning data, and clinically that's what we've seen. We've really kind of picked out very specialized patients who can undergo the craniospinal radiation. And I think overall with looking at this tool, it kind of increases some of our therapies that we can give. I think of one of the patients that I recently treated, 24-year-old with the H3K27M mutated glioma, disseminated, you know, clearly a really poor prognosis, although I was very excited to see all the CAR T-cell data that Dr. Lim had presented, because a patient like this could really respond to something like that. But I think of the craniospinal radiation that I gave this patient, and though it may need to really be in conjunction with a lot of these new therapies that are there, you know, this is a patient who 6 months ago was treated that way, and then next month going to Europe. She feels that well. So I think that's very important in terms of being able to give some patients the palliation that they need and to be able to treat all tumor that we see. We also have been starting to treat patients, for instance, with glioblastoma with PNET features, a very kind of small population. And one of our residents had looked at the 10 patients that we kind of dug up over the many years. And it was interesting because 5 received involved field radiation, 5 received proton therapy, clearly small numbers, but overall 3 out of the 5 who received just involved field had new experiences of spinal cord metastases. And all the patients did quite well with this therapy. So again, we're kind of pushing the envelope a bit and using radiation in areas that we didn't before for better tumor control. Finally, we've been more and more also treating patients who are going into transplant who have CNS disease from leukemia, AML, and ALL. And overall, the craniospinal is sort of integrated with the total body irradiation, and MD Anderson also looked at their patients doing this with 23 photon and 14 proton patients recently. And overall, most of those patients had allogeneic stem cell transplant, and they found less grade 1 to 3 mucositis within those patients treated with protons, and only 1 CNS relapse. So in conclusion, for CSF spread, craniospinal radiation is often helpful for tumor control. Toxicities have really been limited by the use of traditional photon therapy, but proton therapy can utilize the end of the Bragg peak to really stop this right in the middle of the spinal canal, right past the spinal canal in the spine, and really improve that therapeutic index and open up new treatment options. So thank you very much. I'm happy to answer any questions.
Great, thank you. Thank you, Leah. Question, so we're using protons nowadays for low-grade gliomas. Are we seeing more delayed and neurocognitive decline in that patient population with proton?
With protons versus photons?
Photon, yeah.
Yeah. So, currently we have opened the NRG study, which is BN005, which is proton versus photons for low-grade glioma.
Right.
And, overall, we're able to spare the hippocampi much better with proton therapy. And that's kind of the whole idea. I mean, we believed in entering this protocol, even though it's hard to have accrual across the United States because people are sort of set in their ideas, of which one is better. But we've had patients in there. I think we don't know the overall answer. I think with all the new data on hippocampal sparing for whole brain radiation and other papers like that, then that leads to the thought that really protons are going to have less neurocognitive side effects long term. And so I think that's the good reason. But I think important to kind of look at this really closely with neurocognitive testing, which is what
that's what I was going to ask. Yeah, are they getting baseline neurocognitive testing before proton? Okay. Yeah,
so that's what the trial does, neurocognitive testing and as well as quality of life testing. So an important trial to look long term, but as you know, it will take many years to kind of get that exactly.
Right.
I mean, I think the beginning trials from MGH saw really good neurocognitive outcomes with protons, but again, that's just a single arm.
Right. How does it compare with radiation necrosis? Do we see a lot of radiation necrosis with proton versus photon for high-grade?
No, it's a really big question of mine. And, overall, I've done two studies kind of looking at this in our patient population. So one, we looked at the high-grade gliomas that were being treated. We don't treat that many high-grade gliomas with protons, although kind of years back, we had a little bit of a split practice where some were and some weren't. And we had sort of blinded look at pseudoprogression rates, and those were not different. But one thing that is different about protons is that you do see sort of at the end of range that there can be a higher radiobiological effect and that there can be enhancing changes there that can change into radionecrosis. So we looked at that with our meningioma patients, and overall you see it. Most of them are not symptomatic, but it worries me to kind of see that as well. Clinically, we use sort of multiple beams, and we're working on the physics of it to try to decrease the LET overall to overcome that. But that's definitely an important area of study as well.
Cool.
So the overall answer is no. Nobody's really saying that there's increased radionecrosis, but we're all interested.
Yeah.
Leah, that was a fantastic talk. And I have a question to both you and Kester. So with proton transplant radiation being a new modality for the patients with lepto disease, I guess when would one think about doing the referral, since there's not a whole lot of proton centers and often these patients don't have very good survival for a matter of a short number of months?
No, it's a really good question. And I think that's why I also highlighted some of the quality of life aspects. When I trained, it was definitely leptomeningeal disease, only treat where it hurts, don't treat sort of larger areas. So the patients I see do best with it, one, are the ones who are kind of highly motivated and in terms of wanting more aggressive treatment, usually the younger ones and who have good KPS. And then generally, the treatment is quite tolerable. Also, those patients, who are kind of CNS only, those are the ones that we've been treating. So just when there's systemic disease, it's very much under control. That has been important. And then, I think symptoms, I am always one who goes for the drug first. If we get a targeted drug that gets into the CNS, I think that probably has a better chance of kind of a longer term. And so I think that's still kind of a question, but most of the patients we see have already gone through multiple treatments already.
Yeah, I agree. I think KPS and age also factors in. The younger patients, yeah, I would probably do a referral if they have a good quality of life, good KPS. You're not talking about somebody with a KPS of 40 or 50, but someone, who is maybe 70 and above.
Yeah, and those are the ones that are most gratifying.
Right.
Having treated some of them overall, is that you can get a long, durable control for those patients, and really extend their quality. So,
thank you.
Thank you.
Great. Sorry about that. My clinic is calling. So that, on the topic of standard of quality of life and symptom management, it gives me great pleasure to introduce our next speaker, Dr. Sharma, who is at Pacific Neuroscience Institute. She trained in neurology at the UW. She did a 2-year fellowship at the Mayo Clinic. That wasn't enough, so she did palliative care and hospice at the UW. She has a special interest in quality of life and symptomatic management of patients with brain tumors. She's going to provide an overview of the survivorship clinic, the role of a survivorship clinic in brain tumor in neuro-oncology.
Thank you so much for that introduction. Can you see my slides on display?
Yeah. Yes.
Thank you. I'm really honored to be here. It feels great to be back with a lot of familiar faces. As Kester has mentioned, I trained at the University of Washington for my neurology training and for palliative care, and love to see a lot of familiar faces. And also with the Providence system, I've gotten to know a lot of people. So thank you so much for having me here and for making survivorship a part of this symposium, because it is such a crucial part of care for our brain tumor patients. And increasingly, it's been a joy to see over the last few years the increased focus to both to survivorship and also palliative care within neuro-oncology at different programs. So the objectives of my talk today are to really describe the importance of survivorship care, but I really want to provide a very practical model on what are the things we should be focusing on, because I recognize that there's a dearth of people who can do a lot of this work or have an interest in it or who are trained in it. But I think this is something that every patient who goes to a brain tumor center deserves and will benefit from. So how can we make it easier for people to integrate some things, which is what I'm trying to do in my role here at Providence St. John's and Pacific Neuroscience Institute. So what is survivorship? That definition has changed over the years. When we were thinking about cancer care more traditionally, we thought about survivorship as someone who had been through their cancer journey, finished their treatment, and now we're surviving and living cancer-free. This wasn't feasible for neuro-oncology patients who really were never going to reach a point where they were considered survivors from that definition. They were always going to wait for the next recurrence, or they were worried about when the tumor would come back. And so now there's a newer definition of survivorship from the NCI, which really fits our patients also, which considers the survivor from the time of diagnosis through the balance of their life. And it also makes room for their family members, friends, and caregivers. Like often wives will tell me, or husbands will tell me, I feel like a survivor in this too, in a different way. And this definition allows for that, so that everyone who's involved in this really tumultuous and painful process is a survivor of it. And they're going through really intense phases, through a very intense disease process, which is different than what we see in a lot of other cancer journeys, which I'll touch on just a minute, how it's different. But this definition also allows you to separate from the disease, which would be, in our cases, glioma, leptomeningeal disease, brain mets. And we're thinking about all the treatments that we could do. We could do chemotherapy, IV therapy, visits to the hospital, injections, CAR T therapy, and maybe we'll do that and we will not get a response, but that doesn't mean that the patient isn't a survivor, because when we look at this new definition, we're really looking at the patient experience and how they are affected by their community, how they have a social system, how they're physically reacting to treatment and suffering through treatment or doing well through treatment. And several speakers today touched on the toxicity aspect of treatment and how they're cognitively impacted by their process. So it's really a patient-centered look versus a disease-centered look. And a neuro-oncology journey, increasingly I describe this as a roller coaster. And as patients go through their phases, they're like, you're very right, Dr. Sharma, like it really, in the beginning, it already feels like too much, and then you're coming down again and you're going up again, and it's life-changing. It's most often lethal. It impacts every aspect of life, from how you're thinking, how you're functioning, how you're working with your family, how you're going to work. There's a very high symptom burden, as we're all aware, which also leads to high distress for patients and their loved ones. And there's a very high rate of dependence. Some studies have found that 80% of patients with brain tumors are never able to go back to work, which is much higher than other cancer populations. This leads to profound caregiver burden. We're also looking at things like seizures resulting in inability to drive. Depending on which state you are, it could be as long as a year, which is not insignificant, especially when there's no good public transport. So there's a lot of different aspects to the neuro-oncology journey. And most of all, it's the fact that their personality changes, their cognition changes, they become different people through the course of this journey, which may not be an easy process. And so a few months ago, the brain tumor social media, which is a hashtag that was started by a patient survivor, they bring together patients, clinicians, caregivers in an online chat every month. And it's a really lovely place. And there's so many active advocates who are living with brain tumors. And I really like hearing their journeys on Twitter. But this was a question about survivorship. And Charlie Blotner, who's a social worker who works with cancer patients, but also is a brain tumor survivor, describes it as anyone who wakes up the day after the initial diagnosis is a survivor in my mind. I think just being alive is what I consider surviving these days. But the difference between brain tumor survival and other cancers, I'd say, is that you have to continue planning for the big decline, the cognitive deficits, the mobility, the vision issues, the issues when they start to interfere with activities of daily living, where I know that I can't do things or won't be able to do things. I need contingency planning for that. And another patient who has a grade 3, and she shares about that, discussed that before I was diagnosed with brain tumor, before prognosis, I assumed survivor meant cured or all better. But now I've learned that survivorship means that I'm still alive, and it helps me to deal with the uncertainty. So really, this definition has helped our patients feel more part of that survivorship place, where their focus is on continuing to live their best life versus focusing on, okay, my treatment will be done and then I'll live my best life, which can really be harmful and not something that's going to be real. But the other important thing is that needs for patients with brain tumors will change throughout the journey. So while we're still focusing on the patient and not the actual disease process and the treatment, we do need to recognize that with brain tumors, there is a certain cadence to their journey. There's an up and down. And this was a beautiful model from Kester Phillips, who is a palliative care specialist in Australia, who wrote this paper 4 years ago now, where she focused on these different transitions in high-grade glioma. And I think they can also fit a lot to other conditions like leptomeningeal disease. Thankfully for brain mets, we're having longer periods of black plateauing now, longer periods where they're stable. But with the high-grade glioma, you're really starting from diagnosis, you're getting radiotherapy, and you might feel okay. Then you have a recurrence, then you deteriorate again, and then you're eventually talking about death. Now, the timeline may change dramatically depending on your markers, how you respond to treatment, but we need to be aware of the fact that needs in the beginning are different than needs in the middle and needs in the end. And our care and our services should be aligned with those needs. And the only way we're going to be aligned is if we learn about them, which has only really started happening in the last 15, 20 years, and continuously monitoring their needs. So hearing about it, which is where a lot of work with patient-reported outcomes starts to come up. And we have to be proactive in gathering this information and making sure that we are supporting them, because universally the data shows that caregivers at least want more information, want to be asked more often how they're doing, and would like to have services that they can trust and rely on when suddenly something changes when their loved one deteriorates. And so to provide high quality survivorship care, we need to focus on different aspects of decline in these patients, including the physical, the cognitive, the emotional, the social changes, and also concerns about the financial aspects of brain tumor care in the future. And I'll touch briefly on some of the big highlights in each of these, just to emphasize to you what we really are the biggest concerns from the literature so far. So of course, we are more familiar with disease and treatment-related side effects. We all deal with this with radiation, with chemotherapy. We deal with fatigue, nausea, appetite changes. A lot of our patients are on steroids. We're looking at steroid toxicity, side effects of medications such as Keppra. And so there's a whole variety that we need to be able to follow, and not everyone is going to have all of these symptoms, but anticipating them, making sure that we address them will help them get through treatment more successfully. And if they can get through early treatment more successfully, then as we get later on, when symptoms are increasing, stamina is decreasing, and fragility is increasing, we can have created a model for success, and they'll have known what works for them for certain things. So I often suggest making sure that at every visit we're going through a checklist. We're checking in on patients as they're going through radiation, either mid-radiation, at the end of radiation is usually most practice. But for some high-risk patients, even checking in every 2 weeks, or having a nurse check in every 2 weeks to make sure we're staying on top of these symptoms. And then from a cognitive and emotional perspective, this is a huge area, and an area where there's complete lack of evidence. We've extrapolated everything we know on emotional management from general depression and from other conditions, but we have not really done studies in brain tumor patients. And there was a recent Cochrane review that was updated in 2021, which found once again that there are no evidence for any of the medications that we use. And they are toxic in these patients. Almost all the antidepressants have risk of seizure, although bupropion is most well known for it. A lot of them will interact with other medications. And yes, there's a lot of excitement about data in terms of fluoxetine and how it might help, but then should everyone be on fluoxetine? Like, we really don't know those answers. And apart from depression and anxiety, which is very common and understood as part of the adjustment disorder, patients who have frontal lobe disease can have really significant irritability. They can have lack of insight and judgment and awareness, significant disinhibition, which is quite heavy for caregivers. The social aspect I've discussed, so I won't go into for lack of time, but we're looking at patients who become very dependent and lonely. And then one other aspect that isn't really covered is how expensive the care is. Having a brain tumor in America is not for the poor. Even though we like to think that we're providing care, most centers that treat county patients or patients with low or poor insurance don't have the same trials that centers that richer centers do, or academic centers do, or centers that don't take a lot of insurances do. So there's very high treatment costs just from that, and patients sometimes pay out of pocket to travel to trials. But also a majority of patients, as I mentioned, are unable to work. Their caregivers sometimes have to stay home. And we are not considering the other burden of care, which is parking, going to appointments, traveling. And later in life, almost 100% of our patients will need a caregiver to help at home because they become so dependent from a physical perspective. And in America, that is not covered by insurance, and most caregivers are $25 to $26 an hour in most major cities. So, and then lastly, we're looking at future goals, like how are we talking about who they want to make decisions for them? If they're doing well, are we talking about returning to work or thinking about alternative careers? Are we helping them with legacy building? Or are we helping them with their children and how they're talking to their children and helping them cope? So obviously there's many areas that we need to focus on with patients. And a key part of having survivorship care is high quality communication between the patient, the caregiver, and the clinician. So all of these areas start with being able to ask the questions, being able to talk to patients in an empathetic way, and being able to get the answers. And then, as I mentioned, once we get the answers, following them on an ongoing basis. So really a good patient-reported outcome method that allows us to manage symptoms and follow them. And then lastly, addressing them. And that's where we get into research that needs to be done to address a lot of these symptoms, which is still has not been a priority in brain tumor care. And so all of this requires integration of palliative care principles, and all of that can lead to high quality survivorship care with these pillars. And what are palliative care principles? Sorry, I also wanted to mention the timing is important, that we want to have the right conversation at the right time. Otherwise, we'll lose the rapport with the patient. If we're talking about advanced directives right when they're diagnosed, they might get scared, they might get pessimistic, they might feel this is not the doctor for me. So we also want to time it at the right time. And palliative care is the art of alleviating suffering, is what the definition that I like, and the pursuit of quality of life. So it is not hospice, it is not end of life, it is really improving life for patients, and all of us could do with some palliative care. And what we find is that when we integrate palliative care into any type of chronic illness, so serious illness care, we improve quality of life, and we improve patient symptom burden, we improve caregiver quality of life. And so I want to end the last few minutes by discussing some models of survivorship that exist out there. So this is from UCSF. They had a wonderful donor who was a patient who's lived with brain cancer for a long time, who helped them start this program that the goal is to enhance the wellness and quality of life of patients. And they did a wonderful presentation at SNO this year. It's really a multidisciplinary, very thoughtful program that was developed based on patient feedback and focus groups. And based on their feedback, they found these areas which I've touched on, that patients want cognitive support, they want more wellness opportunities, health education, and they want to connect to each other. And lastly, they want to have meaning and purpose, which is built into the program. And so in each of these areas, they've started either a support group, education sessions they have a cognitive care clinic where they have neuropsychologists. There is a nutrition integrative medicine course that patients can do. There's a peer support program where the volunteers are trained and they reach out to other new diagnoses, newly diagnosed patients. For the connection aspect, there's a monthly webinar series. So a lot of small things have been brought together to create this larger program that meets different needs for different patients. Now, obviously this requires a lot of funding and resources. When I started at Providence St. John's PNI, I had no funding and resources, but I really wanted to start a survivorship program. And we did have a wonderful survivorship nurse practitioner who worked with the oncology service. And so we developed what we call the Comprehensive and Supportive Care Clinic, which was started in last February, so about a year. And it's me and a nurse, and we have administrative assistants. So it's a very small group right now. But even with that, we've been able to slowly develop our panel of patients. We focus on symptom management from an early point. So we try to get patients who are starting treatment so we can establish rapport with them, because I find that if I can demonstrate to them the benefit of having my involvement early on, they will continue to have conversations with me, especially when the time gets tough. In the beginning visits, we just focus on radiation side effects, symptoms, nausea, constipation, which is a huge problem with some of the drugs we use. And then as we get to know each other better, we talk about goals of care. What does a good quality of life mean to you? Who makes your decisions? So it gives us time, especially with these high-grade glioma patients, to be able to have these conversations before things start to decline, and especially before cognitive impairment starts to set in. And then we also focus on diet and supplement education. We will provide counseling, but most importantly, I feel a big job of what we do is just connecting people to resources in the area, good therapists, good physical therapists, good family counseling, making sure that their children are supported. So kind of really providing a holistic view of not just the patient, but also the caregiver and the family that's going through the journey. And so far, it's been very well received. Patients haven't been scared of being referred to our clinic. I also practice neuro-onc, but this is something I do 1 day a week, and I find it extremely fulfilling. But as we are growing, we're trying to also add more to this. So that my next step is going to be adding a regular support group, especially for our young patients who are going through the same journey, but harder because they don't have the funds yet. They don't have a retirement. They don't have children. They don't have a lot of the community we look for when we're older that helps guide us through serious illness. We're also starting an education series. We're hoping to do a peer support program for caregivers. And we are hoping to get a social worker into our program. So this is sort of starting from zero and going up by adding just even a small amount of time every week dedicated to our highest risk patients. And one of the other things that's helped is that it's taken away time from our general neuro-oncology clinic where they would have focused on symptoms or they would have had to talk about goals of care. Often we can take that time to just move on to the next patient, which we have to do sometimes in a busy clinic, because we know that some of these conversations are happening in a separate time where I'm giving them plenty of time. I also do this clinic virtually, which is something that my prior research showed that patients really don't want to come to another physical appointment with brain tumors. And so we do a lot of virtual care here so that they have accessibility to us. And then I want to end with highlighting to you a patient survivorship plan that was developed by Dr. Leeper and colleagues that is available at the SNO website, which is a great way to look at, to give to the patient for them to develop their own plan, but also to kind of think about all the areas of creating a survivorship. So with that, I'll end, and I encourage all of you in your practices to consider how to bring more survivorship care to your patients, because I guarantee you that they want it and they need it and they will love you for it. Thank you.
Thanks, Dr. Sharma.
Thank you for that nice talk.
Great talk. Great talk.
So, is Corey still on? Corey, do we need to make any final statements?
Just it's been a wonderful, educational, meaningful course again this year. Just, closing remarks and any final comments, and we're going to go ahead and show the how to claim your credit slide.
Great.
And yeah.
I want to thank all of the participants, all of the organizers. I want to especially thank you, Corey, for all that you've done putting this together. You did 90% of the work. I also want to thank all of the sponsors, including Day Surgical, Integra, Novacure, Northwest Biotherapeutics, and UCB. I think it's been a really insightful and educational course. And I'm glad you taped it, because I had to run off, see a patient, do a few things, and I'm going to go back and see some of these talks again. So that's wonderful. Thank you so much, Corey.
Oh, my pleasure.
All right, thanks everyone.
Have a great day.